Good morning. Welcome to our conference, Cardiology for the Non-Cardiologist. It's a virtual symposium and it's our 6th annual. We are very excited to host it from Houston Methodist DeBakey Heart and Vascular Center. As we get into this program today, I want to start off with some housekeeping items. First and foremost, for you all to connect with us and submit your questions, we recommend two options. One is to text DeBakey, D-E-B-A-K-E-Y to 37607. The second option is on the website and go to pollev.com and enter DeBakey. I also would like to acknowledge the grants from Abbott Laboratories as well as Boston Scientific. I'd also like to thank the exhibitors, Boston Scientific and Medtronic. Please visit our virtual exhibit hall during the breaks. I would like to inform you about accreditation for physicians. Houston Methodist is accredited by the ACCME to provide CME for physicians. The activity has been approved for a maximum of 8 AMA PRA Category 1 credits. For nurses, Houston Methodist is accredited as a provider of nursing continuing professional development by the American Nursing Credentialing Centers Commission on Accreditation. Houston Methodist will provide 8.16 contact hours for this activity. Participants must attend the activity in its entirety and complete the corresponding evaluation in order to receive credit. We will also offer credits for physical therapy as well as physical therapy assistants at HCCUs. I would like to introduce my colleague, my co-chair, Dr. William Zoghbi, a world-renowned cardiologist. He's the Elkins Family Distinguished Chair in Cardiac Health at DeBakey Heart and Vascular Center, and he's a chair of Department of Cardiology. Good morning, Dr. Zoghbi.
Good morning, Dr. Shah, and really a pleasure to be with you here today. This is a pride of us to have this conference for people interested in cardiovascular disease. I know we do a lot of conferences for cardiologists, but part of the healthcare team is really to talk and interact and collaborate with primary care physicians, all kind of physicians, nurses, nurse practitioners, PAs, therapists, and really, I mean, it is very important for us to be able to speak the same language and share with the latest developments in this field. So we really like that very much, and I want to credit also Dr. Alpesh Shah for him thinking of this. Although he's an interventional cardiologist, our specialist in CTO, but it really is tells you about the importance of such sharing knowledge with you. So before we get started, I wanted to share with you your colleagues who is attending this course today. We have more than 200 individuals, and you could see the distribution of their background, which is, I think, very fascinating, because that's really the intent of this course, right, is to dialogue with all the members of the healthcare team. Also, I'm proud to say that we have almost 20 countries that are involved in attending this course. And the nice thing about this course is also will be available for you, as we will say, for the next 2 months. So if you need to take a break in between, I think you can, gather this material, offline if you want to at some point in time. I wish you were here with us. This is our picture of the Texas Medical Center. It's almost similar to downtown, which is in the far field if you have not visited Houston. An amazing complex of collaborating institutions in cardiovascular disease, genetics, and every facet of cardiovascular medicine and beyond. And this is our complex for Houston Methodist, the Research Institute, the new Walter Tower in the middle, and the whole complex. And this is where we live. So if you're traveling to Houston, we would love to host you. Just let us know when you're here so we can share some of these informations and tour you around. And our pride is also our MITI facility, which is the Methodist Institute for Technology and Innovation and Education. We're gradually back face-to-face after this long pandemic. And we hope also to host you in various areas that you're really interested in. Many of you follow us on the YouTube channel. I'm proud to say that we have almost 80,000 followers, and from our weekly grand rounds to multimodality imaging to such courses, really a great way to reach you not only in the United States but also throughout the world and share with you the latest in knowledge in cardiovascular medicine. So with that, I would like to turn it back to Dr. Shah and let him tell us about our program. It's a full-day program that touches pretty much on most areas of cardiovascular medicine, and I think hopefully you will see it very helpful in your daily practice at whichever level practice you are doing. So, Alpesh?
Thank you, Dr. Zoghbi. I was just looking at that global map and only to realize we have attendees from Asia, Europe, Africa, South America, North America. It's just wonderful to see this new way of learning, the virtual. Well, we have put together an amazing program for you all today. It's going to last for 8 hours, all day here. But we have a very comprehensive program which will be presented in 15-minute sessions by thought leaders from Houston Methodist Hospital in those subspecialties. So the sessions are totally divided into 8. We will have 2 sessions at a time and a break after that. So the first one will deal with CAD, risk identification, treatment and management updates. The second session will be about common diagnostic testing, indications and interpretation, after which we'll have a short break, followed by advanced diagnostic testing, indications and interpretations. Session 4 will be valvular heart disease with advances and treatment choices. Lunch break after that, followed by ischemic heart disease, evolving therapies, and advanced heart failure diagnosis and management. After a short break, again, we'll go into cardiac electrophysiology and arrhythmia, diagnosis and management, and followed that with vascular, endovascular disease therapy. Also, just to restate that all registered attendees will receive access to view the presentation at any time for the next 2 months following this conference, and this is a QR code you can utilize to get to that. So without further ado, I'll like to re-invite Dr. Zoghbi to lead us into our morning session.
Thank you, Alpesh, and I think it's great to start with something that is, I think, very important, no matter what area of medicine you're practicing, and even for the general public, is coronary artery disease. Risk identification, treatment, and management. And in this session, the first speaker will be Dr. Faisal Nabi, and Dr. Nabi is truly one of our multimodality imagers. He heads the cardiovascular imaging laboratory at Houston Methodist Willowbrook, and he will be talking about a topic that is, I think, very important to all of us: detecting CAD before it strikes. Dr. Nabi.
Good morning, everyone. I'd like to thank Dr. Zoghbi and Dr. Alpesh Shah for the opportunity to speak to you today at the 6th Annual Cardiology for the Non-Cardiologist. I will be talking to you on how to detect CAD before it strikes. So a lot of my talk will cover the 2019 ACC/AHA guidelines on primary prevention of cardiovascular disease, a really great resource for your review. So let's begin with some truths. Atherosclerotic cardiovascular disease is the leading cause of morbidity and mortality globally. It is a leading cause of global expenditures and is projected to increase due to the increasing prevalence of cardiac risk factors. And really, prevention is paramount. It's far less costly, and therefore the identification of subclinical disease in the asymptomatic phase has really emerged as an economic imperative. So let me begin with a clinical case. This is a 59-year-old Hispanic female who's asymptomatic, relatively active, who presents just to make sure her heart is okay. She is a non-diabetic, has a history of psoriasis, reports her mother had her first myocardial infarction in her late 60s. She's a lawyer, is a non-smoker, leads a relatively sedentary lifestyle. On physical exam, her blood pressure is 148/80, her BMI is 30, otherwise a normal physical exam. Her labs show a total cholesterol of 210, HDL of 40, LDL of 147, a triglycerides of 92, and a hemoglobin A1C that was normal. Her EKG below is normal. So we get a lot of these patients in clinic regularly. And, a couple of the things that I often think about is really, what should I advise her? How should I assess her cardiovascular risk? And does she already even have the presence of coronary artery disease? So we know from the Inner Heart study that risk factors are prevalent, and there have been the classic risk factors that we know about are associated with cardiovascular disease, whereas exercise and lots of fruit and vegetables is protective. We also know from this study that the more risk factors you have, the greater your odds ratio of having a cardiovascular event. And so one of the basic things that I would tell these patients is what the AHA calls Life Simple Sevens, A, B, C, D, E, where we would counsel patients on, some patients, we would reserve high-risk patients reserved for aspirin therapy. We would get them all to have optimal blood pressures, assess them and treat them for any cholesterol issues, encourage smoking cessation, encourage a nutritious diet and a healthy weight. Those patients who are diabetics, getting their glucose under control and encouraging regular exercise. However, in this large cohort study, it showed very nicely that almost 62% of patients who had their first atherosclerotic event had either no risk factors or one risk factor. So almost 20% of this population had no risk factors before they had their first cardiac event. So there must be more than simply treating and looking for the traditional risk factors. So if you look at the guidelines recommend in anybody 40 to 75 years of age to assess the traditional risk factors, but also to calculate a 10-year risk of atherosclerotic cardiovascular disease by using the pooled cohort equation. This equation can be found online, and a number more than 7.5% is usually the trigger where you would intensify your preventative therapy, specifically add pharmacotherapy for lipid and blood pressure management. So here is that calculator I just showed you, and you can see here very nicely that inputting her data, I was able to get a risk of 5.1% for her 10-year risk. If you look at the guidelines, this 5.1% is considered borderline risk. And the next thing the guidelines recommend is to look for any other risk factors that now what they consider risk enhancers, which have been associated with cardiovascular disease and would therefore make you risk stratified to a higher risk group. And these include things like a family history of premature disease, primary hypercholesterolemia, chronic kidney disease, metabolic syndrome, preeclampsia and premature menopause, chronic inflammatory conditions such as our patient who had psoriasis, and whether you had South Asian ancestry. So the presence of any of these risk enhancers, again, encourages reclassification to a higher risk group. So I sat down with our smart lady. I told her risk was 5%, but she had a risk enhancer with psoriasis, and therefore I would recommend statin therapy to treat her dyslipidemia. However, she had already been on Google before her office visit, and came back to me with that she was not excited at all about taking statin therapies because of all she had read online. And therefore, the guidelines have allowed us as a 2A indication that in patients whose the risk decision is uncertain, we can actually look for anatomical presence of coronary disease in the coronary arteries by checking a coronary artery calcium score. And this was a 2A recommendation, again, by the guidelines, and anybody who, if the decision remains uncertain. And this is very reasonable, given the fact many studies have shown that patients who have zero risk factors can still have very high elevated calcium scores, and these patients are at very high risk for clinical events. And also similarly, those patients who may have multiple risk factors, they may actually have no calcium score, and those patients are very low clinical risk. So what is a coronary artery calcium score? It's a very, very simple test offered here at Houston Methodist. The patient who literally lies in the scanner for no more than 10 seconds, holds their breath. There's no contrast, there's no IV, there's no stress involved, and a very low radiation dose is delivered. And basically, you're looking for calcification in the coronary arteries. That calcification is pathognomonic for the presence of coronary atherosclerosis. And the amount of calcification that is found correlates directly with the amount of plaque burden. Studies have shown that if you have a low plaque burden, a calcium score of 0, your future risk is very, very low, generally on the order of less than 0.3% per year. Whereas as your calcium score and atherosclerotic burden increases, your hazard ratio for events tremendously increases, almost 10 in those who have a calcium score greater than 300, and their annual event rate is equivalent to those with non-coronary disease, which is 2%. This test, calcium scoring, has been shown to be a great discriminator of incident atherosclerotic vascular disease in multiple studies, and reclassifies almost 55% of intermediate risk patients. Of all the biomarkers available, all the risk factors that are available, of all the other anatomical testing that is available, calcium scoring has been shown to be the best test in predicting an incident cardiac event. So I went ahead and sent this patient for a coronary artery calcium score, and you can see here the very bright pink that pops up is calcium in the coronary arteries. So right away, you have to diagnose this patient with coronary atherosclerosis and diagnose this patient with the presence of the disease. The calcium score was 288, which is considered a moderate amount. So if you look at studies, this is actually very common in those patients who you are considering statins. Almost 43% have positive calcium scores. And even in those patients who a statin was not recommended, almost 20% of those patients will have a positive calcium score. And studies have shown nicely that if your calcium score is greater than 100, these are associated with increasing events compared to somebody who has no calcium. You can even put this calcium score into a MESA calculator, which then refines your risk further. So in adding her calcium score to the other risk factors, her risk increased from 5% from the pooled cohort equation to now 8.5%, and would now very likely make her a solid candidate for statin therapy. And that's really what I did. I showed her the test results, I showed her calcium scores, and she was much more inclined to this therapy, having seen that the disease is already present. Now, we often get asked about aspirin. Studies have shown that if your calcium score is greater than 100, in general, the benefits of aspirin therapy then outweigh your risk, and especially if your calcium score is greater than 400. Studies have also shown that if you measure calcium scoring, you're much more likely to initiate pharmacotherapy and lifestyle, including aspirin and lipid lowering, as well as encouraging exercise and dietary changes. Furthermore, the effect is also for the patients themselves. And this was a randomized study in patients who underwent a calcium score versus a no calcium scoring. And the calcium score group actually at the end of the study at 4 years had much better blood pressure control and cholesterol and weight control. And all thought to be due to the understanding that the disease process had started, and therefore much more vigorous in their own health care. Studies have also shown us now from both retrospective and randomized data that in those patients who have a detectable atherosclerotic disease, whether by calcium scoring or coronary CTA, that those patients who are then started on therapy with statins have an improvement and reduction in the risk of cardiac events compared to those patients who have atherosclerotic disease but are not treated with statins. Now, let's just say we had the same patient and I checked her calcium score, and this time the calcium score was 0, or in other words, completely normal without the presence of atherosclerosis. What does this mean for our patients? Well, a calcium score of 0 actually is a fantastic test that tells you the long-term prognosis of your patient is excellent and actually reclassifies them to a lower risk. This is a study in patients out to almost 15 years, showing you that the patients with a calcium score of 0 can have a warranty period at certain cohorts of out to 15 years with a risk of less than 1% per year. So, a very, very powerful test. This is the power of a calcium score of 0. So in this particular patient, if our calcium score had come back 0, I would advise her against statin therapy. This would hopefully benefit her by, we know these patients have excellent prognosis, but also she would not have the cost or the side effects of this therapy. And I would likely recommend repeat calcium scoring in anywhere between 3 to 5 years, depending on her clinical risk. So this is also not unusual. Studies have very nicely shown in those patients who are eligible for statins, having a calcium score of 0 was found in 44% of patients. And those patients, whether you treated them or you didn't treat them, had low risk regardless. And this is just another study showing us that of all the markers, biomarkers we have, risk factors that we have, and other anatomical tests, there is no better test than a calcium score of 0 in the downward risk weight classification of your patient. So I will conclude, and I hope that it's important for us to realize that all individuals should be encouraged to follow a heart-healthy lifestyle. It's recommended to calculate a 10-year atherosclerotic cardiovascular disease risk derived from the pooled cohort equations to guide decision-making. After calculation of the PCE, it is reasonable to use additional risk-enhancing factors to guide decisions for borderline or intermediate risk adults. If the risk still remains uncertain or the patient is reluctant to take medical therapy without further evidence, calcium score is a reasonable tool to help you to risk classify your patients either upward or downward. Please don't forget, calcium score is a very easy test to do. It detects the disease. It estimates the burden of atherosclerosis. It is really the best test for personalized risk assessment. It leads to significant improvement in cardiovascular risk prediction and will lead to an either a safe escalation or de-escalation of therapy. I thank you for your attention today.
Thank you very much, Dr. Nabi, for this very comprehensive and important lecture about prevention and how do you risk stratify individuals in addition to the conventional risk factors. So calcium scoring is really very important in practice and individual management. I would like to remind you, and we'd like to have this session as interactive as possible, because this is a way for you to answer questions that may have been burning in your mind for some time. If you are on the web, you can go to pollev, POLLEV.com, and enter DeBakey and respond to the activity. Or if you want to use text messaging, you could text DeBakey, DEBAKEY, to 37607. I think that would be great. And I know we have some questions already coming. We will collate all these questions towards the end, which is like about half an hour from now or so. And our next topic in relation to coronary disease is managing cholesterol, statins and beyond, and will be presented by Dr. Kershaw Patel, who's our expert in prevention. His interest is risk modification and prevention, particularly in heart failure and morbid conditions and metabolic syndrome. So Dr. Patel will give us a feel on how to manage cholesterol nowadays.
Hi, my name is Kershaw Patel. I'm a cardiologist here at Houston Methodist DeBakey Heart and Vascular Center. It's my pleasure to be a part of this meeting and session. Specifically, the title of my talk is Managing Cholesterol, Statins, and Beyond. I have no relevant disclosures. For today's talk, I'm going to focus on some details from a few documents, and I wanted to highlight those up front so that you can reference them for additional details. Specifically, this was the 2017 Expert Consensus Decision Pathway on Non-Statin Therapies that was published in 2017. We're also going to highlight some details from the 2018 Multi-Specialty Guideline for Cholesterol Management. And we're also going to highlight some of the recommendations from the 2019 Guideline for Primary Prevention of Cardiovascular Disease. Now, I want to start with discussing the relevant reductions in LDL cholesterol and its associated reduction in cardiovascular disease events. We have a large amount of data to suggest that lowering LDL cholesterol by 1 millimole per liter, which is approximately 40 milligrams per deciliter. So reduction in LDL cholesterol by about 40 milligrams per deciliter reduces major coronary events by approximately 23%. So for every 40 milligrams per deciliter reduction in LDL cholesterol, you can expect about a 23% reduction in major coronary events. Now, statins are the first line therapy for lowering LDL cholesterol because that's where the majority of data are showing that reducing LDL cholesterol reduces cardiovascular disease risk. And the majority of these trials actually looked at the intervention of statins. So statins are considered the first line therapy for managing LDL cholesterol to manage atherosclerotic cardiovascular disease risk. Now, I want to highlight that because that was one of the main points of this, the title of this talk was managing cholesterol with statins. But for a large amount of people, for a substantial amount of people, not the majority, but for a proportion of individuals who have atherosclerotic cardiovascular disease events, some of them are not able to tolerate statins at a certain dose or tolerate statins even at very low doses. And so for some individuals, they need to be on additional lipid-lowering therapy that are not statins to manage their atherosclerotic cardiovascular disease risk. So actually for today's talk, I'm going to focus predominantly on non-statin therapies because these agents sometimes get a lot less attention. But I want to stress that first-line lipid-lowering agents are statins because of the safety profile and the large amount of data suggesting cardiovascular disease benefits with statins. So let's go ahead and start talking about non-statin therapies. Well, we think about non-statin therapies in the same groups of individuals who we would recommend statins for. So those are individuals with secondary prevention indications. Those are individuals who have already had a clinical atherosclerotic cardiovascular disease, a myocardial infarction or a stroke or some type of coronary intervention by stenting or by coronary artery bypass grafting. So those are secondary prevention. But then, this is the cardiology for the non-cardiologist meeting. So we're going to predominantly be talking about primary prevention. Those are individuals who have not had a heart attack or stroke. And so we think about those groups of individuals who have statin indications. Those are the ones with severe hypercholesterolemia with LDL levels greater than or equal to 190 milligrams per deciliter, those individuals with diabetes, and those individuals who have at least intermediate or high atherosclerotic cardiovascular disease risk. So for those individuals who we think about statins, we're also going to think about non-statin therapy. Now, There's several factors that we have to consider. Anytime we're talking about reducing atherosclerotic cardiovascular disease risk, we have to talk about lifestyle. Lifestyle is the foundation of what we do for reducing cardiovascular disease risk, whether it's modification of diet or improvement in physical activity. We also have to talk about whether or not our patients are able to tolerate the statin therapy, because that may affect their ability to actually adhere to the treatment plan. Anytime we talk about reducing cardiovascular disease risk, it's not just about cholesterol. We know that it's also about blood pressure control, physical activity, management of other lifestyle factors like body weight, diabetes management. There's many other risk factors in addition to managing cholesterol. And then when we talk about non-statin therapies, we have to think about the risks, benefits of those therapies. Will those therapies help us achieve our target LDL levels if we're trying to target a level? And then we also have to think about whether or not patients are responding appropriately to those therapies. Now, one of those groups of individuals that statins are indicated are for those who have had a heart attack or stroke. Now, typically those patients will be managed in part by a cardiologist. So I'm not going to focus much on this slide for the cardiology for the non-cardiologist meeting. But on this slide, there's mention of non-statin lipid-lowering therapies, ezetimibe and PCSK9 inhibitors. I highlight those two specifically because those are agents that have a large amount of randomized controlled trial data suggesting that those agents can reduce cardiovascular disease endpoints. Bile acid sequestrants also have some data, but not to the degree that ezetimibe and PCSK9 inhibitors. And then there are other things that can be considered, like referring to a registered dietitian, lipid specialist, as well as some other agents that we're not going to focus on here because the data are less compelling from reducing cardiovascular disease risk. Now, some of these trial data and slides are publicly available. I've listed the reference at the top. And I want to highlight two trials specifically. The first we'll highlight is the Improve It trial that studied the effects of ezetimibe. This trial was performed in patients who had an atherosclerotic cardiovascular disease event, specifically an acute coronary syndrome. And after stabilization, for individuals who had lipid levels at these ranges listed here, over 18,000 participants were randomized either to simvastatin at a dose of 40 milligrams or the combination of simvastatin and ezetimibe at 40 and 10 milligrams respectively. These patients were followed for cardiovascular disease endpoints, and we saw that this combination of ezetimibe and simvastatin reduced LDL cholesterol modestly, as well as improved other cardiometabolic parameters. And importantly, we saw that there was a reduction, while modest, a 6 to 7% relative risk reduction in a cardiovascular disease endpoint over a long follow-up period, suggesting that ezetimibe is an effective non-statin lipid-lowering agent. The second trial that I mentioned, we're going to highlight again, the reference is listed here where you can find these slides, was the second trial is called Fourier. Fourier evaluated the effects of evolocumab, which is a PCSK9 inhibitor. PCSK9 inhibitors are specifically evolocumab, and there's another one called alirocumab that's been studied in a large cardiovascular outcome trial. These are PCSK9 inhibitors that are monoclonal antibodies, where basically they work by inhibiting PCSK9, effectively increasing the amount of LDL receptor on the liver that helps bring in LDL cholesterol from the circulation, effectively lowering LDL. So in the Fourier trial, they were looking at cardiovascular disease endpoints, and they looked at over 27,000 patients with established atherosclerotic cardiovascular disease who received one of these, the placebo or the PCSK9 inhibitor. Again, there was a dramatic reduction in LDL cholesterol, and importantly, there was about a 15% relative risk reduction in the combined cardiovascular disease endpoint. So those are some of the randomized trial data suggesting non-statin therapies like ezetimibe and PCSK9 inhibitors can reduce the risk for cardiovascular disease. But for cardiology, for the non-cardiologist, I want to focus on those same groups we recommend statins for in primary prevention, where they may benefit from these non-statin lipid-lowering therapies. And those are severe hypercholesterolemia, patients with diabetes, and those individuals who don't have severe hypercholesterolemia or diabetes, but are at increased risk. And those groups you may be familiar with from these primary prevention guideline tables, where you see some of those groupings here. And so for those individuals with severe hypercholesterolemia who are already on statin therapy, you can consider ezetimibe therapy if those individuals aren't able to achieve certain LDL targets while on maximally tolerated statins. You could also consider bile acid sequestrants, where the recommendation and the evidence may not be as strong. And then for select individuals, you could consider a PCSK9 inhibitor, and I've highlighted some of those recommendations here. Now, for the diabetes group, for some individuals who are at high risk, so based off of a calculated or estimated atherosclerotic cardiovascular disease risk of 20% or more, the guidelines suggest it would be reasonable to add ezetimibe. And what about those individuals without very high or severe hypercholesterolemia or without type 2 diabetes? Well, in individuals who calculate out to be at intermediate risk, so they have at least an ASCVD risk estimate of 7.5% while who are already on statin, you could consider ezetimibe or bile acid sequestrant. So this is a summary figure that highlights the statin benefit groups where you could consider non-statin lipid-lowering therapies, the factors that we need to consider, as well as those options, ezetimibe, PCSK9 inhibitors, where there's a large amount of data, and then you could consider bile acid sequestrants at all. Again, I want to highlight that statins are the first line agent for reducing LDL cholesterol and reducing cardiovascular disease events like heart attack and stroke. But for those individuals who may not be able to tolerate statin therapy, whether it's due to myalgias or other possible side effects, or if those patients aren't able to achieve their LDL goals, or for whatever reason, they may need additional assistance with achieving certain lipid targets, those individuals should be considered for non-statin lipid-lowering therapies. And so I hope that this review of some of the primary data, as well as some of these guidelines and expert consensus documents, were helpful to think about managing cholesterol with statins and beyond. And I'm happy to answer any questions during the question and answer session, and I look forward to the discussion. Thank you so much.
Thank you very much, Dr. Patel, for this overview of management of cholesterol issues and reducing risk of patients. And as Dr. Patel mentioned, we will answer many of your questions in the Q&A period, which is in 15 minutes or so from now. And I see several questions that are coming through either texting or on the web, and also on your live stream screen. I think we'll be able to answer some of these. All right, I think we're going to move on and address heart disease in women. And we know that heart disease in women manifests itself a bit differently, maybe at a different time period. Certainly is still the #1 killer of women. I think it's very important to understand risk factors, prevention in women. I think this is really very important. And to address this this morning will be Dr. Carla Kerlmeyer, colleague, and she's the director of our cardiology clinic here at Houston Methodist, and that's her expertise and her interest. Carla, share with us some of the latest on prevention of heart disease in women.
This is Dr. Carla Kurlmeyer. So for the next few minutes, we're going to talk about cardiovascular disease in women. So recently in Circulation, there was a call for action for cardiovascular disease in women awareness and also improvement in further investigations in epidemiology, access, and delivery of equitable healthcare. And in that document, there were 6 different pillars that they were calling for action to be focused on. And these pillars include raising awareness, optimizing prevention and clinical care, supporting research, engaging communities, advocating for improvements in social determinants of health and public policy and legislation, and monitoring progress through health surveillance. We've known for a very long time, ever since we've been collecting data, that cardiovascular disease is the leading cause of death in women. And this pie chart has not changed since we started collecting this data. Deaths due to cardiovascular disease in women have always been nearly twice as much as all forms of cancer combined. The only years that'll look different from this is 2020 and 2021 due to the COVID-19 pandemic. It became quite obvious in 1998 that there was a huge disparity between men and women with respect to the delivery of cardiovascular disease care, because deaths due to cardiovascular disease in men were decreasing, whereas they were increasing in women. So it was the thought that maybe this disparity in cardiovascular care between men and women was secondary to awareness, because for a long time, women had been excluded from research studies in cardiovascular disease. And also cardiovascular disease had been seen as a man's disease because it presents much earlier in men and much later in women. So in 2003, the National Heart, Lung, and Blood Institute, it launched the Heart Truth and its Red Dress Project. And the purpose of this was awareness, to engage communities, and to also advocate for increase in policies and research support for cardiovascular disease in women. And as part of that movement, women, it was fashioned after the breast cancer awareness campaign, which was highly successful. So there was a red dress pin and a slogan that went with it that said, heart disease doesn't care what you wear, take care of your inner as well as your outer self. There were speaker kits that went to healthcare providers throughout the United States. And they were encouraged to share this information with not only with their patients, but also through community speaker programs at religious institutions and other community outlets. And there also were red dresses that were donated by designers that rotated throughout the national meetings in cardiovascular disease to also help increase physician awareness. So you can see here's the black line is showing you where this disparity was discovered. That's 1998. And you can see the red line's women, the blue line's men, and deaths due to heart disease were definitely increasing in women and decreasing in men. In 2003, the Heart Truth Awareness Campaign was initiated. And you can see after that, there was a significant decline in deaths due to heart disease in women, and it almost equals that of men in 2011. So as part of the surveillance and monitoring progress, the women were surveyed again in 2019, and the results of these surveys were compared to the same survey results in 2009. And what they found was that women were 74% less likely in 2018 to identify heart disease as a leading cause of death. And when they looked at the groups that did not know this, they were predominantly the younger women age groups, less than 30. And they also were women of color, including Blacks, Hispanics, and Asians. So it just goes to show how important and how successful this awareness campaign was, but how important it is for it to continue to and specifically reach this younger age group and these minorities. So they can also realize a reduction in mortality due to cardiovascular disease. We're now going to switch to the second pillar. The second pillar says to optimize prevention. And we're not going to hit all of the risk factors. We're just going to hit the ones that are most important to women and the ones that saw changes in the 2019 prevention of cardiovascular disease guidelines. So in this slide, we're looking at blood pressure. And literally, you can see on the bottom hand panel, we have the males and females and all of the different races. And then the bars are representing awareness is blue, treatment, those receiving treatment is red, and those who actually have their blood pressure controlled is in yellow. And what you see is there is no disparity between genders or across the races, but the biggest and most alarming thing is less than 25% of patients actually have their blood pressure controlled. So this is leading to a significant increase in future cardiovascular events, not only atherosclerotic cardiovascular disease, but also atrial fibrillation and heart failure, specifically HFpEF. So when we look at the 2019 AHA-ACC guidelines for prevention of cardiovascular disease, and we look specifically at blood pressure, normal blood pressure is defined as a blood pressure of less than 120/80. And in those people, we just tell them to continue following a heart-healthy diet, getting aerobic exercise, and keeping their weight at ideal numbers. Elevated blood pressure is defined as 120 to 129 over less than 80. And those patients, again, non-pharmacologic therapies such as a low-salt diet, 150 minutes of aerobic exercise, and maintaining ideal body weight are what is recommended. Stage 1 hypertension is defined as a blood pressure of 130 to 139 over 80 to 89. When you see a patient with this, the next step is to estimate their 10-year risk of cardiovascular disease. And if it's greater than or equal to 10%, then you need to initiate, in addition to the non-pharmacologic therapies, you need to start blood pressure lowering medication with a goal of the blood pressure on average being less than 130/80. If they don't have a greater than or equal to 10% cardiovascular disease risk, then you continue with non-pharmacologic therapy. In patients with stage 2 hypertension, defined as greater than or equal to 140/90, all of those patients, regardless of their 10-year cardiovascular disease risk, need to initiate non-pharmacologic therapy and also need to initiate blood pressure lowering medication with a goal of keeping all of their blood pressure numbers less than 140/90. Now let's switch to diabetes. Diabetes is the most significant cardiovascular risk factor in women. Women with diabetes have a 5 to 7-fold increase, depending on the series or depending on the cohort that you look at. A 5 to 7-fold increased risk of cardiovascular disease if they have diabetes compared to women who don't. In this slide, what we're looking at is the cases of diabetes mellitus that were diagnosed in 1988 to 1994, and we're comparing it to 2015 to 2018. The men are shown in the blue bars, the women are shown in the red bars. And what you see is compared to 1988 to 1994, in 2015 to 2018, there was a significant increase in the amount of diabetes mellitus that was being diagnosed. And there also was a significant increase in diabetes mellitus that was not being diagnosed in both sexes. So this was not a gender thing. There was more of it. And when they looked at the type of diabetes mellitus that was being diagnosed more, of course, it was type 2 diabetes mellitus, reflecting the obesity epidemic. So if we look at the ACC-AHA guidelines on the treatment of type 2 diabetes mellitus, it starts off with the hemoglobin A1C. If it's more than 6.5%, this is consistent with type 2 diabetes mellitus. And basically, these patients need to receive dietary counseling regarding a heart-healthy diabetic type diet. They also need to be instructed to partake in at least 150 minutes per week of aerobic exercise and get their weight to ideal numbers. They need to have aggressive treatment of their other cardiovascular disease risk factors. And then there needs to be consideration of adding metformin as the first-line pharmacologic therapy to improve their glycemic control and reduce the cardiovascular disease risk. If, when you check that hemoglobin A1C in 3 to 4 months and it's not less than 7%, then basically what's recommended is you look again at the cardiovascular disease risk factors. And if the patient has other cardiovascular disease risk factors, so they're in that intermediate to high risk group, there is consideration to start an SGLT2 inhibitor or a GLP-1R agonist to improve their glycemic control and reduce their cardiovascular disease risk. If they don't have any other cardiovascular disease risk factors and therefore are not in this intermediate high risk group, then you refer them back to their primary care provider or their endocrinologist to better to obtain control of their diabetes. Now, if their hemoglobin A1C is less than 7 on metformin, then they're just enforced to continue with the metformin and the physical activity and maintaining their weight at a healthy level, and also the heart-healthy diabetic diet. Now, let's switch to lipids. So lipids are interesting in women because they vary throughout a woman's life cycle, because they really change with respect to the hormonal milieu. So in adolescence, we need to be universally screening all adolescents with a lipid panel to look for familial hypercholesterolemia. And in those young women who are started on hormone-based oral contraceptive pills, we know that this will lead to an increase in triglyceride and HDL and a decrease in LDL. We need to be checking their lipid panel after they're started on these medications to make sure that their triglycerides are not in the very elevated range, because if they are, in addition to making sure that they're following a low-fat, heart-healthy diet and also getting 150 minutes of aerobic exercise, we need to consider other measures if we can't get their triglycerides to goal with these healthy lifestyle measures. In pregnancy, we know that triglycerides increase and LDL also increases. And in women with familial hypercholesterolemia, these increases can be significant and therefore concerning and possibly detrimental to the health of the mother. So the FDA now recommends that in this group of patients that the preventive cardiologist or the lipidologist sit down with the patient and have a discussion about the risk versus benefit ratio in their particular case and decide whether or not the statin should be discontinued or continued. During pregnancy, this is the time when women develop other risk enhancers for future atherosclerotic cardiovascular disease events. And these other risk enhancers include preeclampsia, gestational diabetes, and preterm delivery. In the perimenopausal phase, this is when the hormone levels are waxing and waning, and therefore women will see a slow increase in their LDL cholesterol, Lp(a), and total cholesterol. And it is also at this stage that they start having mammograms and other vascular screening imaging done. And so it's at this time that we should also do another risk assessment to determine whether or not they've picked up these additional risk enhancers, which include autoimmune disorders, breast arterial calcifications, and carotid atherosclerosis. So again, it's time to do a thorough risk assessment in these particular patients and decide whether or not they would benefit from coronary calcium scoring. And menopause is when the LDL and Lp(a) and total cholesterol take the biggest jump, when there is no longer estrogen at all. We know that premature and early menopause, which is defined as less than 40 years of age, has been associated with increased future cardiovascular disease events. During menopause, also what happens is there's an increase in fat mass, there's a decrease in skeletal muscle mass, and there's an increase in visceral adiposity, all that have been independently associated with increased risk for future cardiovascular events. In the older adult who's at intermediate or high risk for cardiovascular disease events, or if they've already had a cardiovascular disease event, lipid-lowering treatment is recommended in these individuals, and you should not de-escalate lipid-lowering treatment in the elderly who are tolerating their cholesterol-lowering medications. So the sex-specific risk-enhancing factors, again, they include premature menopause, which is defined as menopause less than 40 years, preeclampsia, gestational diabetes, gestational hypertension, preterm delivery, small for gestational age infants, autoimmune disorders such as lupus and rheumatoid arthritis, and also the arterial imaging that we mentioned, including carotid atherosclerosis and breast arterial calcification. So this is looking at a large cohort study called CHAMPS, which stands for Cardiovascular Health After Maternal Placental Syndromes. And maternal placental syndromes were defined as preeclampsia, gestational hypertension, abruption or infarction of the placenta, There were more than 1 million women included in this cohort study, and they were followed for, on average, 8.5 years for cardiovascular events. And what you see from this Kaplan-Meier curve is that those women who just had maternal placental syndrome were at increased risk compared to those women who had normal pregnancies. Those women with maternal placental syndrome and poor fetal growth were at even higher risk. And the highest risk was those women with maternal placental syndrome and fetal death. If you look on the right-hand side, that's showing you your forest plot. And you can see just having maternal placental syndrome increased your risk of future cardiovascular events by 2-fold. If you added on additional traditional risk factors, the risk for future cardiovascular events increased significantly. So according to the 2019 ACC/AHA guidelines on primary prevention of cardiovascular disease, heart failure, and AFib, this is where they offer advice based on data on how to handle these risk-enhancing factors. So in adults who are intermediate risk, defined as greater than or equal to 7.5% to less than 20% 10-year atherosclerotic risk, the risk-enhancing factors favor initiation or intensification of statin therapy. And in adults at borderline risk, defined as 5% to less than 7.5% 10-year atherosclerotic risk, the presence of risk-enhancing factors may justify initiation of moderate intensity statin therapy. So this is vague for a lot of us because we really didn't quite know what to do with that. But we do have data from the multi-ethnic study of atherosclerosis, and this study included a lot of women, and all these women were low-risk women. 90% of them were low-risk women. And basically what it showed is that coronary artery calcification scores could differentiate between all of these women who were presumably in that low-risk category, which ones were at increased risk for atherosclerotic events. And you can see in the left-hand panel, it's showing you coronary heart disease events and cardiovascular disease events. And you can see that if your calcium score was more than 0, you had a significant increase or a significant decrease in survival compared to if your calcium score was 0. On the right-hand panel, they then separated it according to the calcium score. And you can see that with respect to the coronary heart disease event or coronary vascular disease event, again, if your score was anything other than 0, if it was between 1 to 299, you still had a significant increased risk of future cardiovascular or significant decrease in survival than if it was a coronary artery calcium score of 0. And if the score is greater than or equal to 300, this risk or this decrease in survival decreased significantly. So this table is in the 2019 ACC/AHA guidelines on primary prevention of cardiovascular disease, heart failure, and AFib, and is talking about selected examples of candidates who you may want to consider for coronary artery calcium measurement who might benefit from knowing their coronary artery calcium score. And at the very bottom, it says middle-aged adults with a pooled cohort equation calculated 10-year risk for atherosclerotic cardiovascular disease 5 to 10%, with factors that increase their atherosclerotic cardiovascular disease risk. These are risk-enhancing factors, although they're in a borderline group. So this is the group that we're talking about. This is where most women fall. So they're like low risk, but they have these risk-enhancing factors. So it's saying just knowing their calcium score will help you to determine better what their individual risk is. Also in the older age women, the 60 to 80 year group, which is bullet number 3, these women frequently have tried statins and have developed myalgias. If they have a low risk burden, based on risk factors, and their 10-year atherosclerotic cardiovascular disease is only elevated because of their age, they would benefit of receiving a coronary artery calcium score because it could determine if it's 0, you would no longer need to push statins. If it's something greater than 0, you may need to consider trying multiple different statins or PCSK9 inhibitors to get their cholesterol to go. So this is a study that was looking at digital mammography as a screening for coronary artery disease. And on the left-hand panel, you are seeing individual patients that had both mammogram done, and then they went on to have coronary artery calcium scoring done. And in the top-hand panel, you can see there was no calcification on either imaging study. And then progressive increased examples of as the breast vascular arterial calcification increased, so did the coronary artery calcification increased, as shown in the right-hand panel. This is demonstrated more clearly in the bar graph right in the middle, because literally you could see in all patients, the very first one, if the breast arterial calcification was 0, only 31% of patients had coronary artery calcium score. If it was greater than 0, you can see that increased to 70% of patients having coronary artery calcification. And you can see that as you go across that figure in the middle, that as the age increases, so does the number of patients who have coronary artery calcification if their breast arterial calcification, if they're noted to have breast arterial calcification on their routine screening mammogram. The right-hand panel is showing you the receiver-operated characteristics of the sensitivity and specificity of breast arterial calcification against the Framingham risk score and also against the pooled cohort equation. And you can see that it had a slightly better sensitivity and specificity if the breast arterial calcification score was added on to the Framingham risk score or the pooled cohort equation. So we didn't have time in this talk to talk about the second point in that pillar, which is to optimize clinical care to improve morbidity and mortality in women. And in this, underneath this bullet is important information on how to recognize different symptoms for myocardial infarction and acute coronary syndrome in women, how to recognize different presentations for acute MI and acute coronary syndromes in women. There are different treatment strategies for acute MI and acute coronary syndromes in women, specifically with respect to spontaneous coronary arteries dissection or SCAD or MINOCA, which is MI with no obstructive coronary artery disease. There, underneath this heading is we need to also recognize different invasive strategies. So radial versus femoral access. Radial access leads to less bleeding and vascular complications in women and therefore decreased morbidity and mortality. Also, we need to recognize different presentations for cardiomyopathy, such as Takasubu's postpartum cardiomyopathy, which occur almost postpartum exclusively in women, Takasubu's almost exclusively in women. And finally, it's important to recognize different presentations for heart failure, such as HFpEF, because this is the most common type of heart failure in women. And the most important bullet is to ensure that all women receive guideline-directed medical therapy following their acute MIs, following their presentations for cardiomyopathy, because previous studies have shown that this also, in addition to awareness, was one of the reasons the discrepancy existed in the first place. Women were being undertreated and not receiving the guideline-directed medical care that they deserved. Thank you very much.
Thank you very much, Carla, for a great presentation. I think this is a very important topic. And I think we get to a fun portion of the program now to answer your questions. And there are quite a few, actually, questions. So we have our speakers with us today, Dr. Nabi, Dr. Patel, Dr. Kurlmeyer. And I'm going to start with the first question. So there are quite a few. So please be brief and address it so at least our audience knows some of the answers that you're going to tell them. First one is probably for Dr. Patel, but whoever. How long should aspirin be taken in patients with an elevated CAC score? Indefinite?
That's an excellent question. Aspirin has gotten a lot of press recently with the updated USPTF guideline. I'll keep this brief. So aspirin should be considered for individuals at excess risk for atherosclerotic cardiovascular disease after optimizing lipid-lowering therapy and statin therapy. In select individuals who are not at increased risk of bleeding, a calcium score greater than or equal to 100 can help guide that selection. This should be selected for individuals who are not at increased risk of bleeding. And based on the 2019 primary prevention guideline, individuals greater than the age of 70 years of age are actually not recommended for routine use, in part because of the excess bleeding risk. For the duration of how long to use, I think it depends on the comorbidities and increased bleeding risk factors, such as age, kidney function status, as well as use of other agents that may interact or potentially increase risk of bleeding, such as NSAID therapies. It's all about weighing those risks and benefits and should be monitored regularly if you are going to decide to use aspirin therapy.
Great, and I think I just want to remind our audience that we're not talking here about secondary prevention, some people who had a previous heart attack, et cetera, right? How do we decide, again, Kershaw, how do we decide the risk of intracranial hemorrhage or GI bleeding if we use aspirin as a prophylaxis in calcium? I mean, you're going to go by clinical, issues, problems? How do you decide?
Yeah, it's a great question. We don't have good scores with good discrimination of bleeding events. What I would say is what I recommend is assessing bleeding risk factors. First, I absolutely review the medication list. If they're on anything that's going to increase their risk of bleeding, we really need to decide if it makes sense to be on aspirin. Also looking at things like kidney function. We know worsening kidney function is associated with increased bleeding risk, as well as weight, because sometimes individuals with low weight may be at higher risk for bleeding. So it's and then also the history. It's absolutely imperative we discuss if they have bleeding risks, if they've had an abnormal colonoscopy, if they have hematuria. All of those bleeding risk factors have to be considered. Unfortunately, we don't have good bleeding risk scores, and so it's a risk-benefit discussion based off of the traditional risk factors.
Very good. Another question about fish oil. Said, thank you, Dr. Patel, for an excellent presentation. I had a question about whether supplemental fish oil over the counter has any role in reducing cholesterol or risk, most importantly. I would add to that versus icosapent.
Yeah, it's a great question. Fish oils have been studied for many years in terms of improving the lipid profile for patients. The majority of the data comes from high quality evidence, comes from purified types of fish oils. Specifically, icosapent ethyl has been studied in a large placebo-controlled randomized trial that shows for select individuals at very high risk for atherosclerotic cardiovascular disease that may be beneficial. I do not recommend the routine use of over-the-counter fish oil for improving lipid profiles, predominantly because the evidence is not there for over-the-counter fish oils because they just haven't been studied rigorously in a randomized controlled trial. Now, they may improve lipid profiles, but our ultimate goal is in cardiology is to prevent strokes, heart attacks, and heart disease. And so I would not recommend routine use of over-the-counter fish oil for those reasons.
Carla, a question your way. I had a patient in her 40s with breast arterial calcifications on mammogram, but subsequently a CAC score was 0. Should the breast arterial calcification be considered as presence equivalent to a to higher risk to start a statin therapy?
So absolutely not. I know the study that I showed was literally looking at the correlation between breast arterial calcification and coronary artery calcification. All the data is really behind coronary artery calcification, and the data around breast arterial calcification is just emerging. But it was quite apparent from that study that if we identify breast arterial calcification, that's one vascular bed, and we need to go on to coronary artery calcification to determine what sort of statin therapy that they need at that particular, or if they need statin therapy at that particular point.
A question to you, Dr. Nabi. Are calcium scores similar wherever you go in the United States to get them? How much variability do we have on this?
Yes, thank you, Dr. Zoghbi. Calcium scores, there's kind of a uniform way we do them. And I think the biggest difference, no matter where you get it, is really the price. So
I think that they're reproducible, wherever we go. Very good. Dr. Kurlmeyer, what about women on medroxyprogesterone? Have you seen any issues regarding weight or heart disease?
So again, it comes down to the underlying risk for the individual. So if it's somebody, if we're talking about, I'm not for sure what stage of life we're talking about for the medroxyprogesterone, but if we're talking about for postmenopausal woman for hormonal replacement therapy, again, it really depends on what her underlying cardiovascular risk is and whether or not she has a significant burden of cardiovascular disease, coronary artery calcification or coronary artery calcification score. And then it also depends on what you're using it for. If you're using it for menopausal symptoms, we've known for a long time from the Women's Health Initiative and hers that literally you just use it for the shortest duration and the lowest dose possible just to treat symptoms to prevent any other adverse events. They weren't cardiovascular events. They were specifically strokes and breast cancers and that sort of thing. So again, the question was a little bit vague. I didn't know exactly what stage they were talking about, but with respect to whether or not you can use it, the answer is yes, but it depends. You have to do a risk analysis and decide whether or not it's safe for your particular patient.
Great. Dr. Patel, when indicated, which bile acid sequestrants do you typically prescribe?
That's a great question. A long time ago, there was a trial that actually looked at cardiovascular outcomes in a bile acid sequestrant, a non-statin lowering therapy. That agent was colselvalam. It's not typically used these days because we have now statin therapy and other alternative agents with good, robust data in the statin era. But a bile acid sequestrant has been evaluated in a cardiovascular outcome trial, and that agent was colselvalam. And so if you were going to reach for a bile acid sequestrant, that's a reasonable option. And it actually is endorsed by some of those documents that we discussed.
I just want to share with our audience also regarding calcium score, a great test for early detection of coronary disease, particularly in asymptomatic and where you're really not sure about starting therapy. And remember, starting therapy is also regular preventive therapy in addition to medications, right? But for people who already have a very high calcium score, truly there is no other indication to repeat it down the line. For people with known disease who have been intervened upon with stents and other things, certainly you really don't need to do that. So think about where the indications are, because it's an amazing tool for risk stratification. And this is really precision medicine, because you're talking about the phenotype of a particular individual as opposed to risk with markers, with biological markers and otherwise. All right, well, I cannot thank you enough, our faculty, for your presentation in our first session. I think it's time to go to our next session, and I'm so glad also of the interaction of the audience with you. Thank you again for your contributions. Our second session for today is about common diagnostic testing. So this is common, and we're going to have advanced diagnostic testing a little later. Indications and interpretations. The first one is something that we are facing actually nowadays for the past 5 years plus, which is digital health management in cardiovascular disease, and will be presented by Dr. Ahmed Soliman, who is truly our expert in digital health. And he is the Associate Director of our clinic here at Houston Methodist and DeBakey Heart and Vascular Center. Ahmed?
Hello, good morning. My name is Ahmed Soliman. I'm a cardiologist here at Houston Methodist, and I have the pleasure of talking to you today about digital health management in cardiovascular diseases. So I have no financial disclosures. We will be mentioning some devices or applications just for the sake of demonstration. So we're going to try to discuss digital health in general. We'll talk about the use of digital health and telemedicine in cardiovascular risk management. We'll talk about a few devices or applications and tools. How can we use digital health? In addition to steps on working on digitalizing your practice. So when you try to dive deep into digital health, it may feel a bit overwhelming. I'll try to simplify one's understanding of how to use digital health for the benefit of your patient, the system, and for your practice. Let's start with the biggest digital health change that we have seen over the last year or so. Telemedicine, a practice that to many did not make sense and was difficult to imagine, but became very popular after an abrupt introduction during the pandemic. In my opinion, telemedicine is a very, very important step in initiating care for a patient and to continue chronic management. It all revolves around patient-generated information and data. While listening to the patient by examination is very important, but listening to the patients themselves has a significant impact and value. Digital health mostly revolves around implementing digital tools and technologies to be able to deliver healthcare and personalize that care to a specific patient. But while telemedicine revolves mostly around communication to the patient or with the patient and the use of remote data to provide that care. So if you think about it, these two must go hand in hand. So let's talk a little bit about where one can use digital tools in cardiovascular health. If you take a look at these different aspects, these are the core steps for cardiovascular health management for chronic care. And digital tools and remote monitoring and telemedicine are definitely a factor in regards to this management. So in the digital world around you, it feels like there's an onslaught of different devices and tools. You know, when one is trying to figure out which tools to use, it can become overwhelming and distracting. So here are a few of my thoughts on how to decide about these tools. Simplification of the device, the platform, and the process is a very important step in making it patient and clinician friendly. Notice I said here reasonable, not cheap. You want the data to be presented to you in the way you practice so that you can manage the patient efficiently. While being part of a startup sounds very exciting, it's very hard in a busy practice. The integration is one of the most hardest parts of this, but if you find what fits for all the above points, it will be worth the effort to work on the integration and interoperability, as painful as it might be. So let's talk a little bit about what tools you may have to provide that type of care. We could talk about a few of these cardiovascular risks that one can use digital tools to help in management. Activity is an extremely important part of cardiovascular health, right? But for the most part, it's always been patient-reported activity. For example, a patient tells you, I walk 3 days a week, couple of miles here and there, and for the most part, it's a little bit exaggerated, usually. This type of information gives you the ability to have a proper conversation with your patient on different aspects of how they can improve their physical activity and health, increasing distance, speed, resistance exercise, etc. Smoking. To be honest with you, I actually did not really think that this was going to have or be that effective. But what I've learned over the last few years was that in situations where you need to support the patient a little bit more often than just the 6-month visit, especially for something critical and ongoing and hard, like smoking cessation, using digital tools and some element of live communication with the patient and encouragement makes a significant difference. Don't underestimate that kind of feedback and live communication on a regular basis with your patient. It makes a big difference. Food tracking, everybody knows there are a lot of apps around for dietary changes, but it's again how you use it and how you communicate with the patient. So different diet ideas, fast food and outside restaurant specific healthy options, Again, the concept here is that you're providing these digital tools to the patient with some element of live communication and feedback. It has to go both ways. In the last decade or so, the remote and continuous glucose monitoring has improved significantly. And with insulin pumps, this field, when managed well with patient engagement, has a tremendous potential that is already being demonstrated. And to show the we are not waiting movement driven by patients is a true example of how patients are not waiting for the medical community to move on the digital tools that are available to improve their health. Now, this is one of the most important issues that is not well managed: blood pressure. Something, in my opinion, so simple for the most part, and yet not well managed. In the United States, we are on the decline for good blood pressure control over the last few years through data published just this last October from the National Health and Nutritional Survey. We're not doing a good job as a healthcare system for something that's clearly a major and top cardiovascular risk. There are quite a few platforms, either through Bluetooth blood pressure devices, applications, medicinal support, and organization applications that you could connect to your platform or to your system and provide an up-to-date feedback, medicinal adjustments, etc., to get your patient's blood pressure under better control. Monitor it and manage it chronically rather than an office visit every few months or once a year. The last thing I will discuss with you in regards to tools, digital tools, are rhythm identification. There's a big concern, and frankly, there's a good point to at least part of it, of over-identifying and subsequently over-testing for these abnormal heart rhythms. There's also proof that there is proper identification of abnormal heart rhythms. In my practice, I've diagnosed quite a few patients with atrial fibrillation throughout the last couple of years through these devices, in addition to quite a few with PVCs, although the device would say irregular and flag it for atrial fibrillation, it would turn out to be PVCs. One of them just diagnosed a couple of months ago with ARVC. While you may or may not necessarily agree with these tools or think that they are overreaching, these tools are being marketed to the patient directly. And for patients, this is something that they could use to look at their own rhythm and provide to their clinician. So my advice, if they're going to use it, or if you're going to recommend it, A, use it judiciously, and B, explain to the patient what it can be and what it cannot be, and its clinical impact. You know, digitalization is all around us in many, many aspects. Think about it. When was the last time you physically walked into a bank? 10, 15 years ago, we did not even imagine of ride sharing or Instacart. So let me give you a few ideas or steps to consider to digitalizing your practice. One needs to be flexible. This is a very fast-moving industry, and I mean fast. But you do need to know, you need to be in the know. Culture, I think, is a major point. There's no example stronger than the culture change during the pandemic regarding telemedicine. The culture change is from both the clinician side and from the patient side. Explaining to your patients, explaining to your practice will help them understand why you are doing what you are doing and how this will impact and how this impact make a world of a difference. Spend some time looking at how you manage your patients. Look at the specific point of care that you that would make your ability to deliver that care more efficiently, more seamlessly. How would you be able to engage your patient better? Start looking at different software, apps that would help with this vision. Invest individually or as a group, downloading different softwares or applications that can be helpful for your practice and helpful for helpful for engaging your patients. It may not be a bad idea to engage with industry to see what capabilities their products may provide. And always remember, this whole thing revolves around the patient. Patients always come first. Thank you very much. I appreciate the opportunity and welcome any questions at any time. Thank you.
Thank you very much, Dr. Soleiman. A nice overview of digital health, and I think I'm pretty sure we're going to have some questions for you down the line. I think we're going to go to some diagnostic modalities, and I know it may be confusing out there for primary care physicians, family medicine. Otherwise, there are so many testing, stress testing to use nowadays, and the questions, which one to use? And the topic is stress testing, so many types. Which one should I use? And I think it will be given by none other than Dr. Miguel Quinones. Mike Quinones has been chair of cardiology here before, authority in cardiovascular imaging, and it's a pleasure to have him today to address this question.
Good morning, and welcome to Cardiology for the Non-Cardiologist. I hope you are all enjoying the course. I'm Miguel Quinones, and today we're going to talk about stress testing. There are several different kinds, and I hope I can help you decide which one to use in a given patient. So what do we want stress testing for? Two very common indications are detecting coronary artery disease in asymptomatic patients. For many, many decades, people have been doing the so-called executive physical checkups where patients are put on a treadmill with an EKG looking for coronary artery disease. And then the other very common indication is the evaluation of chest pain, dyspnea, where we are looking for ischemia or obstructive coronary artery disease. So my best friend just had a heart attack. I want to know if I'm next. That's a common situation. People are asymptomatic and they're concerned about the risk and if they have CAD or not. So what should we order? We could do a treadmill stress EKG, a stress echo, a stress nuclear, a coronary CT angiogram, a calcium score, or just treat the risk factors. Well, the first thing we should note is that stress echoes, stress nuclears, and coronary CTs are not approved by any guidelines. So we're really left with either a treadmill stress EKG, a calcium score, or just treat the risk factors. And as I said earlier, the treadmill ECG has been used quite often in those scenarios, but there are important points that we need to remember about this. First, all stress tests, even the sophisticated ones, they detect lesions that are severe enough to cause some ischemia or at least impair the regional perfusion to a given area. And usually these are lesions that are 70% or greater. Some of the more sensitive techniques can detect lesions between 50 and 70, but practically no test can detect lesions that are like 20, 30%. So plaques that are less than 50% are often not detected by any stress test and definitely not by a stress EKG. Also remember that 30% of MIs occur in plaques that maybe a year earlier were mild, were less than 50%. And then they rapidly progressed, became unstable, and caused a heart attack. Thus, a normal stress ECG may give a false sense of security. When prevalence of disease is low, a positive stress ECG is likely to be false positive, and then that leads to more expensive testing to define whether it is true or not. Exercise testing in an asymptomatic patient, in general, it's just really better for determining functional capacity, and that helps with short-term prognosis, around 2 years or so, but it's not that great for detecting CAD. Therefore, routine stress ECG for quote-unquote checkups is not indicated by the ACC AHA guidelines. It actually has a class 3 indications. It's only approved for very selective indications in certain situations, a common one being commercial pilots, because they are obviously involved in an occupation that has a lot of safety for the general public. And again, all you get with a negative stress ECG is more of a prognosis for survival in 2 years than actually detection of disease. And as you heard from Dr. Nabi, calcium score is a much better way of detecting mild coronary disease or severe disease, because after the age of around 50 or so, we all tend to have a speckle of calcium in our plaques, if we have plaques. And of course, as you heard, the greater the score, the greater the likelihood that there may be coronary events. So for asymptomatic patients, this is a much better strategy than a stress EKG. So we're left now with a very big group of patients, those coming to us with chest pain, shortness of breath, in which we are now looking for ischemia and obstructive coronary artery disease. So patient comes in, and the first thing we do is we assess the probability that the chest pain may be in fact due to CAD. So we look at their age, risk factors, and so on, and determine if they have at least an intermediate pre-test probability, which means 10% or greater. And those are very common patients that we see. And in that situation, it's absolutely appropriate to do a stress test to look for ischemia. Another option is to do a coronary CT angiogram. That's going to be discussed later in selected situations. But most of us follow the strategy of doing a stress test. If it's negative, we're good. We can then do a calcium score, looking for long-term prevention. If it's positive, then we have to make decisions as to medical therapy versus going straight to angiography, coronary CT angio, and so on. So these are the choices, right? We can then go out with a treadmill EKG, stress echo, a nuclear technique, SPECT, or PET. So what does a treadmill EKG depends on? Depends on ST changes during the exercise, which requires a normal EKG to start with, and then you're looking for these ST changes that are consistent with ischemia. Stress echo, nuclear techniques, they use imaging modalities. With stress echo, we use the echo to look for regional or global changes in wall motion and ejection fraction indicative of ischemia. And with the nuclear techniques, we look for reduced perfusion in different regions supplied by coronary vessels. Now, CMR, or cardiac MRI, can also be used to detect flow abnormalities with pharmacologic stimulation. But this is usually done in very selective situations, like, for example, hypertrophic cardiomyopathy, in combination with assessment of viability, infiltration, scarring, and so on. So it's a much higher level of testing done in selected diseases. This will also be discussed shortly. So this is your typical positive stress EKG, where you start with a normal at rest, and then we get this very prominent ST depression, downsloping. This would be a very positive stress ECG. But the reality is that when we look at huge number of patients in this meta-analysis, the sensitivity and specificity of a stress EKG is at best mediocre, around 70%. Therefore, we have a fair amount of false negative and false positives. So in general, the other problem is that a lot of patients have an intermediate result. Maybe they get a little bit of ST change, but not classic. Maybe they just quite didn't get their heart rate to 85%. Maybe they didn't make it to more than 3 or 4 minutes on the treadmill, but their heart rate did get up to 85%, and the EKG was not positive, but they didn't have much of a functional tolerance. So you're left with an intermediate result that doesn't give you a clear diagnosis, and now you have to decide what next to do. Furthermore, if you're dealing with a low pretest probability in a patient, a positive test is likely to be false positive, requiring more expensive testing after that. And that is actually quite common in women. Likewise, if the patient has a very high pretest probability, classic angina, and the test is negative, you might still be left with an insecurity and may want to still go to another test. So it kind of leaves you in a situation that often you do not get the answer that you're looking for. So that takes us to the imaging modalities, and in fact, we do use them a lot more these days. So stress echo, as I said earlier, looks at heart function. normal at rest, as we see here. And right after the treadmill, patient lies down, we see the heart gets bigger, ejection fraction drops, and there's multiple areas of wall motion abnormalities in a patient that has multivessel coronary artery disease. Stress Nuclear is using the nuclear technology for perfusion assessment with SPECT. We're looking at regional changes that are relative to normal areas. So it's a relative comparison of the counts in the abnormal areas to the counts in the highest counts that are considered normal. And you can quantitate the severity of abnormalities with the perfusion. Likewise, with echo, one can assess the severity of abnormality by looking at all the segments that are affected during this stress. Meta-analysis done many, many years ago, over 3,000 patients, showed similar accuracy for stress echo and SPECT. So that the two techniques with exercise, this was done with exercise, are quite comparable in a patient that can exercise and that is likely to get either one of the modalities. Many years ago, we studied 248 patients. Comparing the two techniques, the same exercise was used for imaging with nuclear and with echo, and then patients were followed for 5 years, and both techniques provided very good separation in terms of event-free survival, if they were normal, versus abnormal findings. So both tests give you diagnoses and also potential for prognosis. Now, stress echo can also be done in a supine bicycle. And in that situation, there is the advantage that we can image during the stress, low, medium, and more higher levels of stress. This will be the peak. This is a patient that we can see the lateral wall becomes hypokinesis with peak exercise because of a large circumflex lesion. And the nice thing about the bicycle stress echo is that, first of all, it has a similar accuracy to treadmill stress echo. This was shown in our lab many years ago. And other advantages are that it's an easier test in the elderly patient. They feel more comfortable in the bike than in a treadmill. It's good for patients with dyspnea because in addition to looking for ischemia, we can look at diastolic function, assess feeding pressures with exercise, and pulmonary pressure. So it gives you a complete hemodynamic and heart function assessment during exercise. Dovitamin stress echo is the alternative for patients that cannot exercise. Doses of dovitamin are increased gradually until you get a heart rate that gets up to 85% of maximum. Sometimes atropine is used to get there. And this is a patient that at peak exercise, peak dovitamin, develops ischemia in the LAD territory compared to rest or low levels of dovitamin. So it can detect coronary disease. However, the sensitivities are not as good as with nuclear technology, particularly in patients with left ventricular hypertrophy. So it doesn't have the same accuracy that SPECT and PET have, and you get higher incidence of some arrhythmias, premature ventricular contractions, at times some ventricular tachycardia, and of course 1% incidence of AFib. Now, dovitamin is excellent for patients with low ejection fraction, where now we're looking for assessment of viability. That's a whole different discussion, a whole different set of patients in which the test can be very helpful. So in the conventional patient that comes to our office with chest pain, if we're looking at stress echo as a modality, we should do exercise if the patient can exercise, either treadmill or supine. Now remember, stress echo is limited by image quality. This is improved nowadays by using bubbles, using contrast media, echo contrast, and also in left bundle branch block. There is a higher rate of false positive in patients with left bundle branch block, and therefore other techniques might be preferable in those patients. The nuclear technology, as we said earlier, looks at perfusion. The accuracy is very good, but is limited by obesity, women with large breasts, and again, left bundle branch block can provide some headaches at times for this, particularly with exercise. In that case, adenosine or regadenoson is preferred. It's more expensive than stress echo. There is some radiation involved. It does take longer if the patient has to come back for second images at rest. It looks at relative changes in perfusion, and at times it might be difficult to separate well the region of scar from ischemia, particularly with severe ischemia. It may look like a scar. So this is not always a 100% perfect separation. Nowadays, we have PET scanning, and we have an excellent service here available for that. It is a nuclear technique, but it's a lot more specific, more sophisticated. These are typical stress and rest images. And the beauty of PET is that when you get your report, you get specific flow assessment in each of the coronary territories. At stress, at rest, and of course, when you do the difference of the two, that's called coronary reserve. So you really get quantitative information of flow in the different coronary territories. It can be done very well in obese patients, so that's one of the big indications. You get function at stress compared to rest, so you really get a very complete test. It's done with pharmacologic intervention, usually adenosine or regadenoson. So that's one of the limitations. You do not get information in terms of exercise function capacity. So it's great for obese patients. Likewise, it can be useful in left bundles, and you get this advantage of exact quantitation, but it's not for every patient. It's more expensive, and therefore it's good to think in terms of more specific indication. You are going to hear more about this from Dr. Albala in a little bit. So, patient coming with chest pain, stress modality. Can the patient exercise? Yes. In that case, the exercise treadmill is a low cost, which is great, but you get minimal gain. Exercise echo is cost effective. You get good information, and there's no radiation. There's nothing wrong with an exercise spec, but you do get a more expensive test, and you do have to accept some radiation. Patient cannot exercise? Absolutely. Pharmacology, nuclear technology, SPECT or PET is the way to go. PET being referred for very specific indications. So what other uses do we have for stress testing? Well, of course, we use stress testing for assessment of exercise capacity, functional capacity in heart failure patients, patients with chronic valvular disease, pulmonary diseases, and this is simply done with a treadmill, EKG, and oxygen consumption assessment. Risk stratification and prognosis in a patient that already is known to have CAD, that's a different story. In that situation, you really are looking for presence of ischemia and magnitude of ischemia, in which case imaging techniques, either stress echo or nuclear SPECT or PET, are preferred. Finally, patients with are exercised for hemodynamics, valvular lesions, looking for changes in gradients in valves or how much MR there might be. Specifically, patients with dyspnea looking for changes in pulmonary pressures. And in that setting, supine bicycle, stress echo Doppler is the best modality for that. And with this, I thank you very much for your attention.
Thank you, Miguel, really for a nice overview of stress testing and some of the challenges and maybe some of the ways of us deciding of which stress test modality to do. And I know we'll talk about advanced imaging in our next session. Now, the next topic is really germane and very important, particularly for non-cardiologists, is for preoperative assessment. We get a lot of those requests. I know our primary care physicians also get a lot of these requests as to when do you do testing, cardiac testing in such patients. And who best to give this talk but Dr. Nadine Faza. She is one of our faculty, really an expert in structural heart disease, valvular heart disease, and also the associate director of our fellowship training program. Nadine, tell us about what should we do, when should we do some testing when we assess somebody before operation.
Good morning from Houston. My name is Nadine Faza, and I'm one of the structural heart disease imagers here at Houston Methodist, and I'll be talking about perioperative cardiac risk assessment and management. I have no disclosures. More than 50 million surgical procedures are performed annually in the United States, the vast majority of which are elective. Major perioperative cardiac events are estimated to complicate between 1.4% and 3.9% of surgeries. In my talk, I will be highlighting the 2014 ACC/AHA guideline on perioperative cardiovascular evaluation and management of patients undergoing non-cardiac surgery. It's helpful to adopt a stepwise approach to the perioperative management and assessment of patients. The first question that needs to be asked: is the surgery an emergent surgery? Different surgeries can be categorized according to their urgency. Emergent surgeries are life or limb-threatening if not performed within less than 6 hours. Urgent surgeries are life or limb-threatening if not performed between 6 and 24 hours. Time-sensitive surgeries are those where the delay of more than 1 to 6 weeks will negatively affect outcomes. And elective surgeries are those that can be delayed for up to 1 year. So if the patient is undergoing emergent surgery, then the recommendation is to proceed to surgery without further workup or assessment. So in patients who are not undergoing emergent surgery, but rather needing elective non-cardiac surgery, the second question is the patient exhibiting evidence of acute coronary syndrome? If the patient is presenting with symptoms consistent with an acute coronary syndrome, with a STEMI, NSTEMI, or unstable angina, then the recommendation is to proceed to ACS evaluation. With regards to timing of surgery post-acute coronary syndrome, the ACC/AHA guidelines recommend at least a 60-day interval between an acute coronary syndrome and elective non-cardiac surgery. It's also recommended that aspirin be continued or restarted as soon as possible. For patients treated with PCI who are undergoing elective non-cardiac surgery, it is recommended that patients who have been treated with a bare metal stent have a delay in surgery of more than 30 days after the stent implantation. As for patients who were treated with drug-eluting stents, the recommendation is to delay surgery for at least 6 months. In cases where a delay in surgery is greater than the risk of stent thrombosis, it's reasonable to proceed with surgery after 3 months of stent implantation. Going back to our algorithm, for patients with no evidence of ongoing acute coronary syndrome, the next step is assessment of the perioperative risk for major adverse cardiac events. In the perioperative clinical risk assessment, the following should be evaluated for: coronary artery disease, heart failure, valvular heart disease, arrhythmias, and pulmonary vascular disease. The incidence of a major adverse cardiac event of death or myocardial infarction perioperatively is first and foremost related to the baseline risk. There's a significant increase in the post-operative incidence of major adverse cardiac events as the length of time from the myocardial event to surgery shortened. In patients with heart failure, studies have demonstrated improved perioperative outcomes for patients with stable heart failure who are treated according to guideline-directed medical therapy. Decompensated congestive heart failure is a contraindication to elective surgery. And stable patients with New York Heart Association class 1 to 2 symptoms may undergo surgery. It's recommended that patients with heart failure undergo surgery at centers of experience in managing high-risk patients. In patients with valvular heart disease, studies have demonstrated that patients who meet standard indications for valvular intervention with either replacement or repair on the basis of symptoms and severity of stenosis or regurgitation, valvular intervention before elective non-cardiac surgery is effective in reducing perioperative risk. In patients with pulmonary vascular disease undergoing non-cardiac surgery, mortality rates vary from 4 to 26%, and cardiac and/or respiratory failure rates range from 6 to 42%. Current guidelines recommend continuation of pulmonary vasodilator therapy perioperatively and preoperative evaluation by a pulmonary hypertension specialist before major elective non-cardiac surgery. Risk of a major adverse cardiac event of death or myocardial infarction can be divided into low risk and elevated risk. Low risk is defined as less than 1%, while elevated risk is defined as a risk of more than or equal to 1%. The revised cardiac risk index is commonly used to evaluate the perioperative risk for major adverse cardiac events. This index includes high-risk surgery, history of ischemic heart disease, congestive heart failure, cerebrovascular disease, preoperative treatment with insulin, preoperative creatinine levels of more than 2. Patients scoring 0 or 1 point are considered to be at a low risk for major adverse cardiac events. Patients scoring 2 or more points are considered to be at an elevated risk for major adverse cardiac events. Surgeries are divided into low risk, intermediate risk, and high risk surgeries. Low risk surgeries include breast, dental, endocrine, eye, gynecological, reconstructive, minor orthopedic, and minor urological surgeries. High-risk surgeries are aortic and major vascular surgery, in addition to peripheral vascular surgery. It is also worth mentioning that the American College of Surgeons has other tools for perioperative risk assessment that can be accessed online. Back to our algorithm, in patients with a perioperative risk of less than 1%, meaning an RCRI score of 0 or 1, it's recommended that patients proceed to surgery. In patients with a perioperative risk of more than 1%, then further evaluation is recommended, and that starts by determining a patient's functional capacity. Metabolic equivalent of task, or MET, is used to evaluate a patient's functional capacity. The ability to achieve 4 METs of activity without symptoms is thought to be a good prognostic indicator. Activities achieving 4 METs include walking up a flight of steps or a hill, or walking on ground level at a speed of 3 to 4 miles per hour. If unsure, it's reasonable to consider an exercise treadmill test to establish a patient's functional capacity. In patients who are able to achieve 4 METs or more, then no further testing is recommended before proceeding to surgery. So these patients with moderate to good or excellent functional capacity are able to proceed to surgery. In patients who are unable to achieve 4 METs or have an unknown functional capacity, then non-invasive testing is recommended if the results would change their management. Non-invasive stress testing is recommended in patients with an RCRI risk of more than 1 who have poor functional capacity are unable to achieve 4 METs, or in patients with RCRI scores of more than 1 and an unknown functional capacity. Stress testing is not recommended in patients with good or excellent functional capacity or with patients who have an RCRI risk score of 0 to 1. It's reasonable for patients with known coronary heart disease or other significant structural heart disease to have an ECG preoperatively, except for those undergoing low-risk surgery. It is not useful for asymptomatic patients undergoing low-risk surgical procedures. Preoperative echo is reasonable in patients with dyspnea of unknown origin for evaluation of LV function, patients with known heart failure and worsening symptoms or a change in their clinical status, patients with suspected moderate or greater degrees of valvular stenosis or regurgitation with no prior echo within 1 to 2 years, or with a change in their clinical status. Routine preoperative evaluation of LV function is not otherwise recommended. Coronary angiography performed routinely is not recommended for perioperative evaluation of patients. In terms of medications, it's recommended that beta blockers are continued in patients who are on beta blocker therapy chronically. Beta blocker therapy should not be started on the day of surgery, and statin therapy should be continued. In patients with mechanical valves, bridging therapy is indicated in patients with either a mechanical mitral valve or patients with mechanical aortic valves with risk factors. Risk factors include atrial fibrillation, previous thromboembolism, LV dysfunction, hypercoagulable states, and older generation mechanical valves. Patients with ICDs should be on a cardiac monitor continuously during the entire period of inactivation and external defibrillation equipment should be available. ICDs should be reprogrammed to active therapy as soon as possible. In summary, in patients with acute coronary syndrome, recent PCI or MI, decompensated heart failure, and severe symptomatic valvular heart disease, it's recommended that surgery is postponed. In patients with a perioperative risk for major adverse cardiac events of 1% or more, and an unknown functional capacity or a poor functional capacity, then further testing is needed before surgery. In patients with a perioperative risk of less than 1%, and in patients with good or excellent functional capacity, then these patients can proceed to surgery. Thank you so much for your attention.
Thank you very much, Dr. Faza, for a great presentation. I think it would resonate very much with our referring physicians, etc., all these patients that are going for surgery, what kind of surgery, what their risk is, and everything else. And I want to welcome our faculty back, Dr. Quinones, Dr. Soleiman, and Dr. Faza. We will have 15 minutes or so to ask questions. So I would ask the audience to, I know I've seen some questions already, but you could go through the chat, or you could go texting to DeBakey, to 37607, or if you're on the web, Polev DeBakey, and ask your question. All right, well, we have a couple of questions here. They're varied. First one is a clinical question. I think probably Dr. Soleiman or any of our famed general cardiologists here. I sometimes get patients with chronic pain issues, and some are savvy enough to blame the statin, which is almost always atorvastatin, quote unquote. Is there an alternative that might be used to avoid this? How would you handle such a situation? Maybe Dr. Soleiman first, and
sure,
maybe Miguel also.
Good morning, everyone. So first of all, I do explain to them the benefit versus the risk of statin therapy and the indications of it. Obviously, if they already have an established history of coronary disease or so forth, because there's a lot of misinformation out there, understandably so. Then we start working together, either decreasing the dose or changing it to a different statin. My two major statin therapies that I start with is usually either atorvastatin or rosuvastatin, but there's always different other choices as well. And I think gaining the confidence of a patient and the trust of a patient, trying to work with them on it rather than just telling them, well, you really need to be on it, you have to figure this out, is going to be something very, very important. So understanding that their complaints or their concerns about it, but also maneuvering through different doses, sometimes doing it every other night instead of every night, or different regimens in of itself can be beneficial. But at the end of the day, I also have taken patients off of statins if I also prove that they do not need it. So I think first find out, do they need it or not, and subsequently have them be a partner in the treatment of it because of the risk that they're mitigating with the statin therapies.
Mike, any other approaches? Or
Yeah, I think those were great comments and great advice. I'll just tell you an anecdote. I'm in the age range where I have aches and pains every day. So I take a low dose statin, and I decided to come off for a whole month. So for a whole month, I didn't take rosuvastatin. And guess what happened to my aches and pains?
They're still there.
They're still there. So now I'm able to tell that anecdote to my patients, because the reality is that we all have so many sources of aches and pains. Now, there's no question that statin-related myalgias is a real entity. And sometimes, and I'm not sure, there's no way to test who will or who will not. So it's always worthwhile to also give a little trial with CoQ10. Some patients just absolutely love it and they feel great. Others don't do anything, but certainly it's benign enough that it's worthwhile giving that trial too. And I agree entirely with Ahmed that you have to engage the patient and do share therapy here.
And also, obviously, for those incapacitating symptoms, right? We have alternative therapy to statins, PCSK9 and
Exactly.
others. I think, I mean, we have to be objective enough, but I agree with you. Actually, some of the recent data tells us in a placebo-controlled situation, just like you experienced, Miguel, quite a few of the patients, have symptoms on placebo too. So I think but most important thing is if the end point is reduction of risk, that's what we are aiming at with whichever approach is as a team approach and patient-centered approach. Okay, and this is from a technical point of view, Miguel and all of you, and including myself. There was a recent study that found inaccuracy of nuclear stress testing false positives. Please comment on this, and are these false positives eliminated with PET? I know Dr. Al-Mallah will be coming on board, but maybe your thoughts, any of you.
So I'll start first because there have been multiple studies, not one study, showing false positivity with every single modality. I am not too familiar with PET. I think Dr. Al-Mallah will comment on that later, but certainly the routine straightforward stress echoes that we do, stress spec that we do, they all have their possible sources of false positive. So there's no question about it. It's a reality that we deal with. The worst is, of course, is stress EKG. So that's where you have to put your hat as a clinician. And I have had patients that I did a nuclear stress because they had classic angina, and lo and behold, it came back normal. And I've pursued it. And likewise, there are situations where they come in positive, and then you have to deal with it. Now, there's one interesting thing about false positive. Most false positive nuclear stress tests have a small defect, and they tend to be more fixed than ischemic. Not always. So if you get a 5% relatively fixed defect in for example, a woman with large breast, and the laboratory did not do any specific maneuvers to reduce that, there are certain tricks that can be done. You should have some increased suspicion that it could be a false positivity, but every single stress test has that possibility.
Any other comments? Are we okay with that?
Yeah, I would agree also, but at the end of the day, remember, why are you doing the stress test? And what is the outcome of that stress test, right? So even if there is a possible false positivity, we generally speaking, do not take patients to the cath lab unless they have symptoms or they have heart failure, unless, God forbid, it's a heart attack, right? So I think we also have to explain to patients that a person that is doing very well regarding exercise or activity or so forth, and may have some coronary atherosclerosis and mild defects here and there, but they're doing reasonably well regarding activity, and they have a normal LV function and so forth. We have to take the overall picture. That's what I'm trying to say. It's not just one test as all.
Yes.
And sometimes what I have done, if I have somebody that has a relatively low risk situation, outpatient chest pain, a chest pain that may not be classic of angina, and I get what could be a false positive stress test, the next thing I do is a calcium score. And lo and behold, it might be 0. And if it's 0, then you really have a good situation to explain to the patient that the stress test probably was most likely was false positive.
Also,
exactly.
from
again, you have to have that hat. You have to have the clinician hat. You cannot just ignore symptoms and functional capacity and everything else.
So I agree. The overall picture is very important.
I echo that. You have to take it back to the patient and remember why we're doing the test. A lot of times you can even have a false negative and the patient comes to you with classical symptoms. And at this point, you can't just rely on one test. If you have a functional test, you go for an anatomical test, depending on the risk factors, the symptoms. So it's important to keep in mind the context in which you ordered that stress test and decide the weight you're going to put on a false positive or false negative. And look at if it's a false positive and a small defect, then by guidelines, you have to pursue medical management and reevaluate symptoms. So a false negative or a false positive is not the end of the story. This is kind of the crossroads where you decide on the next steps for management, and never ignore the patient's symptoms. When they come back complaining of the same symptoms, even if you have a negative stress test, that's not always reassuring.
I think this is a very important point, Nadine, is you have to take care of the symptoms of the patient, particularly if they have classic angina. In stress nuclear, as opposed to stress echo, if you have left main disease at times or balance triple vessel disease, your EKG may be the abnormal one because you look at relative perfusion as opposed to actual quantitation, which you can get with PET. That's the advantage of PET, and I think we'll talk about that. And again, I agree with Dr. Q. These false positivity, they're small. They're either anterior in women and inferior at the inferior base in the vast majority of individuals. And there is prone imaging that you could do to reduce that, attenuation, correction, other things that you could do that. All right, couple of more questions here. That's for you, Nadine. Is there a role for CT coronary angio risk stratification preoperatively when compared with stress testing?
So that's a great question. I think, if you're able to do an exercise stress test in the setting of preoperative evaluation to also determine the functional capacity of the patient, that would be my go-to test because you're getting the information related to functional capacity and to ischemia. But if you have a patient who had a CTA and it doesn't have any evidence of coronary artery disease, and then they're unknown or poor functional capacity, so I would definitely consider them to be at a lower risk given the CTA findings.
And to your point,
I think I'd like to add that a lot of the patients that we have to do this preoperative evaluation are patients with known disease, so they're known to have coronary disease. In fact, they may have had a heart catheterization 3 or 4 years earlier. So in that setting, number one, I want to echo what Nadine said about functional capacity and stability. Because people who have good functional capacity, they're stable clinically and are going for a relatively low risk surgery, you don't need to do much of anything, even if they have no CAD. But then you have these tricky situations. They want to have a big knee replacement surgery and they weigh 260 pounds and they're pretty low mobility and they spend their time with their TV sets and remote control. And in that situation, you may have to still go ahead and remember when I gave you talk, at this point in time, now you're looking at stress testing for prognosis and outcomes. So at that point in time, an imaging test, definitely pharmacologic one, would be the way to go, unless you had that information from a year ago that you can plug in. So many of these people are elderly, they have known disease, and each patient is a little bit of a different scenario. But I think the guidelines point that out very well.
Very good. Maybe another point to remember is even if you detect ischemia, you have to put it in the clinical context, right? How large is the ischemia? And, we rarely intervene, meaning intervention-wise as opposed to medical pharmacology-wise on these patients because it would delay the surgery. And people need to know that you have to be on dual antiplatelet agents for some time before you undergo that surgery. So, the physicians have to be cognizant of this. Obviously, the cardiologist has to be cognizant of that and relate what the clinical condition is to the referring physician, etc. Okay, a general question. How much coenzyme Q10, Dr. Soleiman, would you recommend for statin myalgia? I think Dr. Soleiman did not like the question. All right, he's back.
Am I there?
No,
Yes, you are.
You're there, but your image went away and came back. Irrespective, we can hear your voice.
Okay, so number one, we have to verify first, do they really have the effect of myalgia, right? Due to that. So like Dr. Quinones was saying earlier, it would be reasonable to give it a try off and back on again. Generally speaking, I always try lowest dose available for whatever dose medication, being it blood pressure, being it cholesterol, or so forth, lowest effective dose. So I always start at the lowest dose, which is starting anywhere between the I think it's, if I remember correctly, 60 to 100. And then if they do well with it, then that's fine. There's a lot of different doses that are available off the market, off the non-prescription as well, that you could get from over the counter from Costco or so forth, anywhere between 100 to 300 milligrams. But I always tell the patient the lowest dose available, we start with that. If they do well with it, then they're fine. Same thing I do with statin therapies, for example. Lowest dose effective, bring down the LDL as it's supposed to be, where the goal is, and that's fine. So lowest dose available if they get over the counter or our prescriptions.
The biggest problem with CoQ10 and all the supplements, it's not just CoQ10, every single supplement, is that because they are not regulated through the FDA, you never know exactly how much you're getting of anything. Actually, it's true for almost every single supplement. So with CoQ10, you have the 200, 400 milligram pills. You can take up to 800. It's relatively benign in terms of side effects. The problem is that depending on which one you pick up from Michelle, you never know exactly how much you really are getting. And that's really one of the big limitations that we have with every single supplement that is out there.
And remember
also,
and
that's why I tell the patients according to where they get it from, because if they get it from Costco I think starts at 100. So the different places have different doses. So I tell them whatever over-the-counter dose that they will get, just get the lowest dose and give it a try.
And remember also that data has shown that it may not be effective. So instead of putting patients on it and trying it and see if it really helps their symptoms, we have to be objective enough not to add one pill on top of another and on top of another. I mean, it gets expensive, and if it's not helping, it's not helping. All right, well, we cannot thank you enough here for you to join us today. Thank for our viewers. Thank you, faculty, for great presentations. We're going to take a little break, maybe 15 minutes or so, and then come back to talk about advanced imaging and their role in cardiovascular disease assessment. Thanks again. Welcome back to our cardiology for the non-cardiologist conference, and in this section, this is our session 3 this morning, as we will address advanced imaging and their role in assessing cardiovascular disease. I will go ahead and start the discussion on the appropriate use of echocardiography. As you know, echocardiography is ubiquitous, and we want to make sure that we use it appropriately. So hopefully you'll enjoy this next segment. We have a little technical issue, so I think we're going to go ahead and talk about cardiac PET, and then we'll come back to echocardiography and who best to present the modality of cardiac positron emission tomography, but Dr. Al-Mallah, Muaz Al-Mallah. He's the director of cardiac PET and really a known expert in the field, and he's president-elect of the American Society of Nuclear Cardiology. Dr. Al-Mallah will address PET and its utilization in cardiovascular medicine. Dr. Al-Mallah.
Thanks for the kind invitation to talk to you about cardiac CT and PET. What do I need to know? These are my disclosures. Okay, so let's start with coronary CT angiography and cardiac CT. As you know, this new tool has been around now for more than 10 years, and it allows high-quality images of the coronary arteries. The main strength of this technology is the ability to delineate the coronary arteries very well, and now this can be done with very low radiation dose. When we do cardiac CT, we can see either normal coronary arteries or mild plaque, or sometimes severe stenosis or diffuse disease, as you see in this patient. The accuracy of cardiac CT have been demonstrated on multiple studies. These are 2 multi-center studies which show that cardiac CT has very high negative predictive value. This means that if you send a patient to coronary CT angiography and the patient has normal coronary CT angiography, this means that the patient has very low likelihood of having obstructive disease. However, its down limitation is its limited positive predictive value, which may be even lower in real life practice, suggesting that if you have a stenosis, this may be a flip of a coin, and sometimes it was overestimating the stenosis. There is data to suggest that also that patients with normal cardiac coronary CT angiography will way less often require will way less often require referral to coronary angiography. As you see here, those who did not have any plaque or had only mild plaque required referral to coronary angiography much less often compared to those who had 1 vessel, 2 vessel, or 3 vessel disease on coronary CT angiography. In terms of outcomes, this has been the subject of 2 major trials. The first one is the PROMISE trial, which actually randomized patients in the US to either coronary CT angiography using a 64-slice scanner or higher, compared to functional strategy, and these patients were followed up for death MI or unstable angina hospitalization. As you can see, both modalities were able to predict outcomes very well. There were no difference between the CT-based strategy and the functional-based strategy. Another trial that studied this was the Scott Hart trial, which had a little bit different randomization scheme where patients initially had the stress EKG, and those later on were referred after the stress EKG. Those with positive ones were referred for either coronary CT angiography or standard of care. And here you can see those who were referred to cardiac or coronary CT angiography had lower event rate. The authors have suggested that this is primarily because of reduction of non-fatal myocardial infarction, and more analysis of this trial data suggests that because these patients were more often started on secondary prevention therapies such as aspirin and primarily statins in this study, these patients tend to have less events compared to those on functional strategy. However, the downside of coronary CT angiography has been increased referral to coronary angiography. So those patients who had CT angiography were more often referred to coronary angiography. This was seen in the Scott Hart trial and also in the PROMISE trial. So similar results on both trials on both sides of the Atlantic. However, as we just alluded to in the PROMISE trial, there was increased angiography, increased PCI and CABG, but no difference in outcomes of these patients. So given all these changes, now coronary CT angiography is in the guidelines for the assessment of those patients with low to intermediate likelihood of having obstructive disease. So this is not for patients who have EKG changes. This is not for patients who have been diabetic for a long time. This is not for those patients with known CAD. This is a tool that we use in patients with low probability of coronary CT angiography, low probability of obstructive coronary artery disease. However, as the risk increases, now testing for ischemia becomes the preferred modality. And when the risk becomes much, much higher among like patients with ST elevation or ST depression, this is where invasive angiography should be the way to manage these patients. Among those patients with extremely low risk groups, so you're talking about somebody with 20-year-old with normal EKG and chest pain, normal troponin, then probably reassurance is the way to go and no need for any diagnostic testing. Coronary CT angiography can be used to assess bypass grafts, as you see here. However, the problem in that case is that most often the native vessels are heavily calcified and become difficult to assess whether the native vessels have enough disease to cause ischemia. So the graft is not impossible to manage. Most often we are able to see grafts very well and we are able to characterize them. However, the problem are native vessels. Another concerning situation, which is stents, as you see here, I'm showing you a couple stents. Here's a stent which is clearly patent. Here's a stent in the proximal vessel. The stent has to be more than 3 millimeters to be adequately assessed by coronary CT angiography. However, if it is less than 3 millimeters, it becomes difficult because of all blooming artifact. And here's an example of a stenosis that you see here, which is correlated with coronary angiography. CT angiography is also the best tool to assess for anomalous coronaries and look for their course and whether it is malignant course or not, as you see here with intramural course of the left main before it gives LED. It's an anomalous left main arising from the right coronary cusp. We can also assess function, but this is associated with high radiation, so we kind of limit this to only situations only when other modalities that does not require radiation are not able to be used. For example, we start with echocardiography, cardiac MRI, but we can also assess with coronary CT angiography if needed. We can also look for pre-TAVR assessment. Now, cardiac CT is an essential tool to assess these patients. We can look at the annulus. We can look at the coronary heights and also the ascending aorta measurement and look at vascular access vessels. Incidentally, we could diagnose congenital heart disease, like for example here, where you have a patient with VSD, ASD, and others. We can also look for the valves, bicuspid aortic valve, look at the calcification. We can track areas, again, only when other imaging modalities may not be adequate, like echocardiography or cardiac MRI. In these cases, we can assess metallic valves, and for some these, sometimes we may not need contrast if we're just assessing whether the leaflets are moving. You can see here there's one leaflet which is stuck, and these are in 3D imaging. We can also look for pericardial complications, like here major pericardial effusion, pericardial thickness, and this patient with severe calcification and constriction. So to sum up, advantages of cardiac CT: it's a non-invasive procedure, fast, easy to perform. It gives us good visualization of high-grade stenosis in almost all coronaries that are more than 1.5 millimeter, assuming no major calcification there, and can provide extensive information about cardiovascular structure and function in multiple different pathologies. Let's move on to myocardial perfusion imaging. As you see here, this is an example from our cardiac PET program, and you can see here these images of perfusion PET, even in obese patient. And why is the interest in cardiac PET right now? It's primarily because it is a very accurate test that allows us to assess function, allowed us to assess accurately myocardial blood flow, coronary artery calcium scoring, and since these systems are hybrid systems, we can potentially combine it with CT. It is the most accurate non-invasive test. This was compared in the Pacific trial, and PET was compared to SPECT, compared to CT, and the authors in this trial did 3-vessel invasive FFR, and they found that cardiac PET was the most accurate test among all the different modalities that are available. It gives you superb image quality even in obese patients, as you see here. And this is a patient with a BMI of 43. We've imaged patients up to BMI of 70s, and we are still able to get very good diagnostic images. And this is one of those patients with a BMI of 62 from our lab. The test is very quick. It takes only 20 to 25 minutes, and you can be even abbreviated a little more to 20 minutes or so. We assess concomitantly coronary artery calcium scoring because these are PET-CT systems, so we are able to get a lot of information. And we know that from our data that we published in JACC Imaging a few years last year, in 4,000 patients, that among those patients with very high coronary artery calcium score, it does predict outcome. And we followed these patients, and we found that many of these have abnormal PET scans, and it will help us identify those patients with abnormal PET scans. We can also look at outcomes, and we can see that coronary artery calcium scoring add incremental diagnostic and prognostic value in these patients over myocardial blood flow. Cardiac PET is also associated with very low radiation dose. In fact, it is the lowest radiation dose among the different modalities, and we are even now able to do sub-millisievert cardiac PET. And this is primarily because the half-life of the radiotracers that we use is very low. In our lab, we primarily use rubidium, and it has a 76-second half-life. And this is why the current guidelines from American Society of Nuclear Cardiology clearly put guidelines. If PET is available, then consider PET before going to SPECT. And if you are able to do PET, get PET before moving on to SPECT, assuming that the study is appropriate. And this is because of the low radiation exposure. We are able to prognosticate patients. So those with normal perfusion have very low event rate, and those with abnormal perfusion defects have high event rate. And we are able to assess myocardial blood flow, and there have been a lot of data to show that in the presence of normal myocardial blood flow, it almost rules out obstructive disease. So normal myocardial blood flow make it less than 3% of having severe 3-vessel disease or left main disease. However, also the presence of abnormal myocardial blood flow, like in this case, even though it looks like a single single vessel disease, small perfusion defect, but when we look at the flow reserve, it looks extremely low. And this is a patient with 3 vessel disease, even though the images does not look like this is a 3 vessel disease. And it adds incremental prognostic value over ischemia assessment, and also could help us guide therapy. Those patients with very low blood flow would benefit from early revascularization, and they should be treated as that way accordingly. We can do many other testing with PET. We can do viability imaging, as you see here. We can also image cardiomyopathies and look for inflammatory cardiomyopathies, as you see here for this patient with sarcoidosis or biopsy-proven sarcoidosis who had VT arrest. And you can see the amount of inflammation this patient had despite having normal coronaries. We can also use it to detect endocarditis and complications from endocarditis, like abscess formation in this patient. You can see 2 abscesses that this patient had, which were confirmed by surgery. So you can see here that PET has a lot of advantages that makes us think that it is the way of the future. And if you have access to PET, this is the way of the future in terms of detecting coronary disease and performing all the additional modality, all the additional applications. But going back to coronary assessment, because this is what we do most of the time, you can see here that for the low risk patients, either very low risk, no testing, low to intermediate risk, this is where we send the patients to CTA. Intermediate to high risk, perfusion, and extremely high risk, they go directly to coronary angiography. And this is exactly what the European Society of Cardiology guidelines. And there have been a lot of advantages where we try to put the patient first and try to understand which patient would benefit more from CTA and which patient would benefit more from stress testing. And here's a list for your review. But for example, one area that obviously you cannot do CTA is among patients with abnormal kidney function, especially if they're not on dialysis. Those with high calcium score, CTA may not be a very appropriate option. Those who have non-CAD, unless you have a specific question to target, this may not be the appropriate group for CTA, and this is more falling in the realm of stress testing. On another end, if you have persistent symptoms despite normal stress test or suspected artifact, then these might be among those patients that would benefit from CTA. Again, after all, this is not a modality clash, but more of a patient-centered imaging, and we have to put again the patient in the center and try to make the appropriate decision for our patients and keeping them in the middle of our opinion, and be rather focusing on the modality, focus on which test would help our patient achieve the best shortest path to diagnosis and initiation of therapy. Thank you very much for your attention, and look forward to the discussion.
Well, thank you very much, Dr. Almallah, for reviewing where we stand in cardiac CT as well as cardiac PET. What I'd like to do now is in the next 15 minutes or so share with you echocardiography and Doppler and appropriate use. Certainly, this modality has evolved over many years from the early days, and it is really a family of techniques that you use nowadays to assess cardiac function. So not only 2D echocardiography, but color Doppler to assess particularly regurgitation, continuous wave Doppler to assess severity of valve stenosis. So I think this is a very important modality. Most of the time it is a first line evaluation of cardiac function. So we're going to go through common uses of echocardiography, evaluate chamber size and function. At times you wonder whether the heart size is big, and I think this is a great modality to do that. Presence and severity of valve regurgitation, pericardial effusion constriction, and in atrial fibrillation, left atrial appendage clot, particularly with esophageal echocardiography, patients with endocarditis, stroke, and peripheral embolization and aortic dissection. So if you take a look here, this is the vast majority of echocardiographic evaluation is to evaluate left ventricular function. And nowadays, yes, we use size, ejection fraction, total output. So basically, and also the whether there's hypertrophy of this heart in patients with hypertension. So this is very important, you know, in our armamentarium to evaluate cardiac function and cardiac risk. We can use 3D echocardiography now to evaluate total size and function, particularly if you have regional wall motion abnormalities that are affecting the heart. One thing that you will notice is in some of the reports is you see a notation for strain and strain imaging, and this is a great technique that has been on board now for more than 10 years, and it is basically shortening of this heart. So you hear about global longitudinal strain. Normal is a negative number, is less than minus 18 or so. So if you have a 16 and below, it is abnormal, and it is automated and it is quantitative, and I think that's the nice thing that we use it for, particularly for patients who have who are undergoing chemotherapy, where you want to make sure that you monitor heart function. So an assessment of LV function, we talked about ejection fraction being very powerful. In patients with chest pain, actually, rest echocardiography, if you're looking for coronary disease, is of minimal value unless you're suspecting pericarditis. Dyspnea or heart failure, abnormal electrocardiogram with all its connotations, cardiomegaly, patients receiving cardiotoxic drug. This is where strain, in addition to an evaluation of ejection fraction, would be important. And prior to major surgery, Dr. Faza has mentioned that to you, that it is not a routine indication, and we'll talk about that. For chest pain, rest echo, we just talked about, is often of little diagnostic value, and the exceptions are acute MI, pericarditis, dissection, and abnormal electrocardiogram. Stress echo for detection of coronary disease, which would be much more beneficial in those situations. Now, in patients with heart failure, imaging, even at rest, may infer some of the etiology, the underlying etiology. And we also know that there is this entity of heart failure with preserved ejection fraction, or HFpEF. So the combination of imaging of the structure and function of the heart along with Doppler would be very important. And you see here a dilated cardiomyopathy on the left, a hypertrophic cardiomyopathy on the right upper area, somebody with amyloid, and an individual with regional abnormality status post a myocardial infarction. Now, the application in heart failure is, yes, we want to assess LV function, but also at the same time, we want to assess the hemodynamics, determine the etiology, and see how much there is in pulmonary hypertension. So in those situations also, Doppler echocardiography is very important, because with Doppler, when we look at filling dynamics of the ventricle itself, along with tissue Doppler, we can infer whether the filling pressure of this heart is abnormal. So it is very helpful, particularly in individuals who suspect heart failure. In addition to that, you can estimate pulmonary artery systolic pressure from the tricuspid regurgitation jet. So on your echocardiography report, and you request it, there is usually an assessment of filling pressure, an assessment of pulmonary artery pressure using this modified Bernoulli equation, which really would be very helpful in the overall evaluation of somebody with dyspnea. Now, among the first applications of echocardiography has been pericardial disease from Dr. Harvey Feigenbaum. So pericardial effusion and constriction are very important in such patients that can happen after cardiac surgery, patients with uremia, and many other situations. So I think these would be very important. Another request for echocardiography is to evaluate sources of cardiac emboli, particularly patent foramen ovale in the younger individual, if you will. And here you could see the interatrial septum bulging with inspiration, along with a little puff of contrast, saline agitated contrast, that comes in from the right heart to the left heart, diagnostic of a patent foramen ovale. And also in patients with stroke who had abnormality in heart function, either an infarction or a cardiomyopathy. You could see here a very large left ventricular apical thrombus that is there, and at times we have to use contrast to enhance the images. And here you could see that in the non-contrast image on the left, it was suspicious but certainly not diagnostic of an abnormality. On the right side, a large apical thrombus, and that is very mobile and has high propensity for embolization in this situation. Now, valvular heart disease, as you know very well, is an important indication for echocardiography, be it stenotic valves, like here aortic stenosis or aortic regurgitation, and at the bottom mitral regurgitation and mitral stenosis. So we know that this indication is really a very strong class 1 indication. And the common scenarios clinically are evaluating of a heart murmur that could be suggestive of valvular disease as opposed to a flow murmur, assessing the severity of disease once you have it, and determining the optimal timing for surgery in continuous follow-up and serial follow-up of patients that come in for deciding on the time of surgery or transcatheter intervention on such patients. And in patients who have prosthetic valves, certainly looking at the function of the valve would be very important, and at times transesophageal in this situation is even more important to assess structure or abnormalities in endocarditis or leak around it. Now, in this area, we gonna emphasize the use of transesophageal echocardiography, a semi-invasive technique, if you will, certainly a procedure that has benefit compared to transthoracic examination. And the major benefit is in seeing the basal structures of the heart in much more accuracy. So it is greatly effective in left atrial appendage clots, just like you see here on the right side of the image. For patients with endocarditis, much better resolution. Prosthetic valve structure and endocarditis, certainly crucial in that situation, as well as aortic dissection. Endocarditis also is very important, a utilization of both a transthoracic approach in addition to a transesophageal approach in the right patients. And with certain algorithm, yes, you will start with a transthoracic examination. And if you have a high suspicion for endocarditis, you have a bacteremic patient that you're suspecting an endocarditis with a transesophageal, certainly is very much indicated. Everybody is concerned about the growth in advanced imaging, and including echocardiography. So that's the reason we want to make sure that the utilization is appropriate. And the American College of Cardiology started, several years ago, more than 10 years ago, what's called appropriate use criteria to evaluate when and what's the most appropriate situation. Yes, there are some undeterminate situations, but there are some that are inappropriate for various modalities, including echocardiography. So here for echocardiography, the appropriate use in which the expected incremental information combined with clinical judgment exceeds the expected negative consequences. And yes, echocardiography is very safe. We're talking about ultrasound here, but there are situations where, it is not appropriate. And Dr. Faza has mentioned that to you already in utilization and preoperative evaluation. So in a preoperative evaluation, class 1 indication for echo would be in patients with current or poorly controlled heart failure. A class 2 indication in prior heart failure and patients with dyspnea with questionable etiology, whether it's cardiac or not. However, a routine pre-op check with echocardiography is really not needed, particularly the patients who are ambulatory and asymptomatic. So the indications, conditions where echo is not cost effective, a routine checkup in asymptomatic patients with no clinical signs of heart disease, ambulatory patient with recurrent chest pain and no specific abnormality on physical exam, EKG or otherwise, stress echo is more appropriate in those situations. Palpitations without identified arrhythmia or specific abnormality on physical examination or EKG. elderly patients with strokes and whom anticoagulation is indicated anyway, or who have well-established risk factor for stroke that would not change your management. So in conclusion, know what specific information you are looking for and how will the results alter your diagnostic workup and or patient management. Beware of order sets, adjust them as needed, and know the limitations of the test, including echocardiography that you are ordering. And if in doubt, get an expert, give a call to an imager or a cardiologist that would help you in those kind of situations. So a thank you from all of us here at Houston Methodist. Dr. Deepan Shah, who is our next speaker, he's actually the director of our cardiovascular imaging. And this is the team that we have that keeps growing in all areas of imaging. So thank you very much for your attention. All right, and I think what we're going to do next is actually go to Dr. Deepan Shah, who will be addressing cardiovascular MRI and its utilization in cardiovascular disease. And the topic is entitled Cardiac MRI, the Ultimate Diagnostic Tool. And Dr. Shah is the director of cardiovascular imaging here and also the director of our cardiac MRI laboratory. Deepan?
Hello, this is Dr. Deepan Shah with Houston Methodist, and I'm going to be speaking with you about the role of cardiac MRI as a diagnostic tool for the non-cardiologist. So to start with, here's an example of an MRI scanner. You can see it's a round circular machine with a table on it that the patient lays on, and the table then goes into the bore of the scanner. Now, some of the advantages of MRI, it's non-invasive, but it's important to keep in mind that it involves high magnetic fields, and therefore we need to carefully screen patients who have any metallic implants or metallic objects within them. But using this MRI, we can actually acquire images of a very wide variety of different cardiac techniques. Whether it comes to looking at perfusion, looking at cardiac masses, valve disease, tissue characterization, looking for myocardial infarction and scar, and then pericardial disease as well. And what I'm going to try to do here is talk to you about some of the roles where cardiac MRI can be useful for the primary care, the hematologist, oncologist, the pulmonologist, or the rheumatologist, the non-cardiac specialist. So, first off, I think one of the probably the key pieces of information that we try to obtain for any patient when it comes to cardiac evaluation is assessment of contractile function. And so that's really assessed by ejection fraction, as well as looking for regional wall motion abnormalities. And as we'll see, MRI is outstanding for being able to visualize the myocardium to assess left ventricular contractile function. And it doesn't have limitations as far as acoustic windows or interference from enlarged lungs or rib spaces. And a typical LV function study by CMR is shown here. We're actually going to acquire a series of short axis views of the heart from the very base of the heart all the way down to the apex, as well as some of the standard long axis views. And these views can really be done in the course of about a 10 to 15 minute acquisition, and it doesn't require administration of intravenous contrast, and therefore no IV is needed for a simple LV function assessment study by CMR. And then having obtained these serial short axis views, we can then do planimetry of the end diastolic and end systolic contours of the left ventricular myocardium to then derive what the LV end diastolic and end systolic volumes are, as well as what the ejection fraction is. And there's numerous studies that have validated this over the last 25 or 30 years. And one of the advantages here is that there's no geometric assumptions that are being made. We're actually obtaining each sequential short axis slice. And as a result, it gives you much more precise measures of volumes and ejection fraction, as well as much more reproducible measures. And to give you a frame of reference, The typical reported interstudy variability for ejection fraction by CMR is about 3 to 5% compared to echocardiography, where the interstudy variability is about 9 to 10%. So what are scenarios where this can be useful? Obviously, in patients with cancers who are undergoing chemotherapy, this is one area where CMR could be useful if you wanted to get precise serial assessment of ejection fraction. And let me skip forward here and talk a little bit also about the right heart. As you'll notice, just as well as you can see the LV, you're able to very nicely identify the right ventricular myocardium as well using the same cine-CMR technique. And again, this requires no intravenous gadolinium-based contrast agents, or any contrast agent, I should say. Obviously, the RV is a little bit more complex of a structure, and as a result, measurement of the RV has a little bit more variability. So in fact, the interstudy variability for RV ejection fraction is a little bit less strong than it is for the LV, and it's typically reported to be about 5 to 6% variability. But this can be useful, obviously, in patients with pulmonary disease, where you're trying to get an accurate assessment of RV ejection fraction. And it can also be useful in patients where you're trying to assess serial changes in RV ejection fraction over time. So let's start off with a case. This is a 72-year-old woman who comes to the office with about a 1-month history of exertional chest pain. She has numerous cardiovascular risk factors here. She's on aspirin, insulin, statin, and an ACE inhibitor. On exam, she's not in heart failure, and her resting EKG shows some STT abnormalities. So this is a patient who is then needing some form of a stress test. So the question obviously is, what choice of stress agent or stress test are you going to utilize? You've got stress SPECT, CT, looking more at an anatomic assessment, dobutamine echo, or CMR. And I'm going to show you what the advantages of CMR are in a case like this. So this is a patient, when we did the cine-CMR images, what we do for any stress CMR study, we can see, in fact, that the overall LV ejection fraction for this patient is preserved. There is some subtle wall motion abnormality here in the inferior wall, but overall, no significant depression in LV function. When we proceed on to the stress CMR, you'll notice, and again, the top image here are the stress perfusion images. So this is done after administration of regadenoson. The bottom images are the rest perfusion images. And we're injecting gadolinium-based contrast very rapidly, and you're seeing the contrast enter into the right heart, into the LV cavity, and then you look to see it enter into the myocardium. And you'll notice in this patient that there is a delayed contrast uptake extending almost from about the 2 o'clock position here, the anterolateral wall, all the way over here to the inferior wall to about the 4 o'clock position. So this is, and we see this both in the very basal slices, as well as we extend down towards the apical slices as well. This is and these findings are not seen when you look at the rest perfusion. So this is very indicative of an abnormal stress CMR, suggesting perfusion abnormalities in this patient in really a multi-vessel distribution involving the LAD as well as the RCA territory. This patient then went on to coronary angiography, and you can see that there's several high-grade lesions within the LAD. There is a small lesion. There's a lesion here in a small obtuse marginal branch. And if you look at the right coronary artery, you can see there's significant disease within the RCA as well. So this is a patient who had multivessel disease, and based on the CMR, then went on for CABG, coronary surgical revascularization. Now, what does the literature tell us? If we look at this series here, which is a meta-analysis of multiple publications in the literature, what it really shows is that compared to SPECT, CMR and PET had a better overall diagnostic performance, with CMR being a little bit more sensitive than PET, and with PET being a little bit more specific. Advantages, obviously, with CMR over SPECT or PET is that there's no radiation exposure that's given. The other unique advantage of CMR, I think, is this ability to directly visualize myocardial infarction. So in this example patient here, we can actually notice that there's a small area of high signal, what we call hyperenhancement, in the anterior wall in this patient, which would correspond to LAD distribution. So this patient who had no known history of a prior MI actually turns out he had a silent or unrecognized myocardial infarction in addition to their multivessel coronary disease. And there's several studies that have shown that CMR is really the most sensitive technique for being able to identify small subendocardial infarctions. And what we know from numerous studies in the literature in the last decade is that the presence of an unrecognized MI confers almost the same increased risk of future mortality as the presence of a recognized MI. And again, cardiac MRI is really the optimal test in being able to identify these unrecognized myocardial infarctions. And then from a prognostic standpoint, again, a normal stress CMR confers very low risk, less than a 1% annualized event rate in this meta-analysis here, versus an abnormal stress CMR either by abnormal stress perfusion or by abnormal evidence of an occult myocardial infarction. Now, the other advantage, I think, is with stress CMR is that it can also identify other life-threatening causes of acute chest pain. So here's an example of a patient who presented for a stress CMR for evaluation of acute chest pain and is actually found to have an aortic dissection. Here's another patient on the left-hand side who presented for evaluation of acute chest pain, and we found this person actually had a pulmonary embolism as the cause of their symptoms. And in addition to that, from a symptom standpoint, some of these patients that present with acute chest pain may in fact have pericarditis. And as I'll show you here in a second, CMR can not only identify the abnormally thickened pericardium, as we see in this example case here, but I think most interestingly is in patients with pericardial disease, the delayed enhancement MRI that we perform after we give gadolinium contrast can identify if there's active inflammation of the pericardium. And in this person, we can see here who has a thickened pericardium, we see a pretty significant amount of high signal in the pericardial or in the pericardium after administration of contrast, indicating that there's active inflammation in this pericardium. And this person, after 3 months of intensive anti-inflammatory therapy, we can see the thickness of the pericardium, what it was at baseline, as is shown in the top panel here, to what it is at follow-up now. You can see that the pericardial thickness has actually reversed itself. And as a result, CMR can be used to inform duration of anti-inflammatory therapy in patients with pericarditis. Now, let's turn to a variety of different heart failure conditions that cardiac MRI can be very useful in. And I'm going to highlight just a few of these that I think are patient populations that will come across the non-cardiologist. So here's an example of a patient who presents with syncope, who has a known history of sarcoidosis. And we can see this person actually has an area of thickening or increased wall thickness in the septum here, as well as in the RV. When we do our delayed enhancement MRI with gadolinium contrast, we can see areas of significant gadolinium contrast uptake. And again, these are areas that are patchy, that are not consistent with an ischemic etiology. And this was a patient who turned out to have cardiac sarcoid involvement. And there's numerous studies in the literature that show that for patients who have extracardiac sarcoid, the presence of cardiac involvement detected by gadolinium contrast uptake confers a worse prognosis over time. Also, in patients that have thalassemia or patients that are getting or that have a concern for iron overload, there's a CMR technique called myocardial T2 star mapping, which allows quantification of the iron content within the myocardium. And this can obviously then be used to not only identify the presence of myocardial iron overload, but then be used as a a strategy to determine appropriate duration of chelation therapy for these patients. Here's another example of a patient who has a thick heart. You can see their wall thickness here in the LV is almost 1.6 centimeters with mild LV dysfunction. In fact, the RV is also thickened, and we can see the atria are quite enlarged. And the classic finding in this patient, though, is when you give gadolinium contrast, there's very diffuse gadolinium contrast uptake everywhere in the LV as well as the RV and also in the atrial walls. And this is really a classic finding that we see in patients who have cardiac amyloidosis. So to wrap up, I think, again, this, I'm going to finish off with this initial slide, which shows really kind of the versatility of the different types of applications where cardiac MRI can be useful. And I think, I really just touched on the tip of the iceberg, but there's a variety of additional indications where CMRs can be useful both for the cardiologist as well as for the non-cardiologist. I thank you for your attention.
Thank you, Deepan, for a great presentation on the role of cardiac MRI and some of the newer areas that you may not be familiar with, detecting ischemia and stress and so many other things. It's really a very powerful technique. Now we have some time, maybe 10-15 minutes for discussion. We have Dr. Al-Mallah with us. Muaz, great to have you. I don't know where you are in the world now. I know you were overseas, so you may still be there, but that's the beauty.
It's all virtually. I'm just a few meters from where you are. This is a new reality.
Yeah, we cannot tell where we are, but I know I'm here. So a great discussion, and I think we have some questions already from the audience. I love those questions. Please keep them coming because this is a great forum for you to address them.
Sure.
There's something about endocarditis, Muaz. Dr. Zoghbi showed an algorithm for transthoracic and TEE in endocarditis. But when is PET scan indicated to diagnose endocarditis? I think that's a great question.
No, definitely. This is a common scenario, and I think echo can do a lot in terms of diagnosis. And often you don't need to go to further testing. I think more related to imaging complications related to endocarditis. Sometimes if there is an abscess, there is extracardiac extension. If there are root abscess, most common. For CT, this is you can look mostly at like if there are emboli to the lung, if it's a right-sided lesion. The other area where PET can help, it's primarily on areas where echo cannot see, like for example, if there's a pacemaker, you're looking at the pocket, you're looking at the leads where you could have artifacts. For valves, it's primarily for prosthetic valves, metallic valves. It's not that powerful for native valves. So if you see it in native valves, it's good. But if you don't see it, it does not rule it out. We do a lot of endocarditis for LVAD patients. That's a common problem where different modalities may be limited in their assessment. So I think these are the scenarios, looking primarily for complications and looking for areas that are not routinely covered by echocardiography, like looking at pacemaker leads, areas where there is sometimes difficulty with echocardiography, like metallic valves, and also for LVADs with all the problems with metallic imaging.
Very good. Along these lines, that's a question from me to clarify those kind of things. Is certainly post-op, if the operation is rather recent, right, there's still some inflammation and healing. And the question is there a time window beyond which you feel that the diagnostic accuracy of an infection as opposed to a healing process would be good? Is it a month, 2? Do we have data on this, or just your thoughts on it?
So, I mean, in the first 3 months, we're a little bit cautious in our call, unless it's really a hot abscess that we see very high FTG uptake. Usually inflammation is diffuse and more lower in terms of intensity of FTG uptake. So in the very first 90 days after preoperative assessment, it may be a little bit specificity may be an issue. But beyond that, I think it's a really powerful tool. So I think a lot of caution has to happen in the very first 90 days. And in that period, you need to be very cognizant when you see diffuse, low-grade kind of FTG uptake, that this could be more of an inflammation rather, or normal healing process rather than inflammation and rather than infection. Another area which is sometimes lower our sensitivity is the partially treated. So if the patient has been on antibiotics for 2 weeks or 3 weeks and then they come to bed, we may not see that intense uptake that we usually see with untreated patients. So that's another important factor to keep in mind when we are considering these imaging tools.
Is PET more expensive than stress nuclear testing?
Yeah, definitely not more expensive, and that's why it is limited. I would still say that regular nuclear by spec is still going to be the more dominant, and it is the more dominant. I think there are few patients that would be more, it would be more beneficial to do them by PET rather than SPECT, and I highlighted them in my talk. So for example, if you have an obese patient where SPECT is kind of limited, if you have a patient with significant calcification and you're concerned about multivessel disease, if you have a patient with low ejection fraction and high suspicion for multivessel disease, transplant patients, patients where you want to do viability, these should be potentially channeled towards nuclear cardiac PET. However, SPECT still performs very well in thin patients, patients who need to exercise. I think that's a good tool to be applied, as well as the other imaging modalities that you have available, like stress echo and other tools.
Question directed to me is that you summarized the importance of echo very well. And I am a PGY2 internal medicine resident aspiring to be a cardiologist. I learned about point-of-care ultrasound to read at the bedside echo. What resources would you recommend to me to learn more about the echo during my residency? I mean, point-of-care echo is very strong. Now, you don't see it much applied, at least in the United States. But I have few thoughts regarding that. Number one, for the audience, I would like to refer you to a review we wrote, Dr. Shamsi Pasha and myself, Circulation a few years ago, and it's still very valid. I think point-of-care ultrasound is similar to any ultrasound. Obviously, the machine is much smaller, is portable, if you will, and you can get it at different sizes. But there are 2 points. One is acquisition. Since echocardiography is a handheld acquisition, you have to learn how to acquire an ultrasound. Interestingly enough, there's AI technology now to help you, and still, it's still in its infancy, but it would help you. But more importantly, it's a combination of good acquisition and good interpretation. And this is where the learning curve is. So as a PGY2, I think the more you are exposed to any of these techniques, including ultrasound, with experts, people who can teach you a few things, you can start acquiring that knowledge. So once you become a cardiologist and then have that, you can learn these tools. Now, you don't have to be a cardiologist to learn these tools, but my advice is you'd better know what you're doing. Number one is if this is an intensive care utilization, which can be very appropriate, remember that with some of these smaller techniques, smaller machines, the image may not be as good as a larger machine, particularly in a patient that is instrumented. And these are the most difficult patients, and you want the most accurate diagnosis. The quick utilization of such is LV size, RV size and function, both of them, regional, global, and whether there is a large pericardial effusion, yes or no. And you know very well post-operatively at times, the effusion may be dense because it could be blood as opposed to just an effusion. So you have to be very careful on the interpretation side. For valvular heart disease, point of care ultrasound doesn't work as well. You may detect it, but it's not the technology for you to evaluate its significance. So somebody who's hypotensive, if you will, somebody who's dyspneic, it can give you a little glimpse into the situation. And just like anything else, if you're not knowledgeable about it, you may actually refer to full-time echocardiography more often than not. And I think you have to kind of be careful of how to do that. But there's a lot of resources for you to gradually learn these techniques, which is, phenomenal really at the bedside and otherwise. So I'm glad of your interest. So best wishes going for a cardiology fellowship and be a cardiologist down the line. Question to you, Moaz, is with more and more detection and thought about infiltrative disease, such as amyloidosis, with your two hats of PET as well as MRI, how do we approach that after somebody is suspecting that there is an infiltrative disease, such as amyloidosis, besides the biological markers?
Okay. That's actually a common question, and probably the most question I'm being asked nowadays in terms of how are we going along all these different modalities. So first of all, you have to have a lower index of suspicion in the right population. And unfortunately, many of these patients are detected late. So we do rely on our non-cardiologists to look for all these additional flag marks, patients with with bilateral carpal tunnel syndrome, patients with many other clinical features that are suspecting HFpEF that's unexplained, severe LVH without hypertension. So these things that we do need you to help us identify these patients early. Now, the first step has to be echocardiography. And with echocardiography, if the echo is fine and all other possibilities have been ruled out, and like, for example, hypertrophic cardiomyopathy, hypertensive heart disease, then you may potentially go to PYP. If there is still concern about the diagnosis, even if there is still potential for other differential diagnoses, cardiac MRI is going to be extremely helpful to confirm your suspicion and say, well, yeah, this is cardiac amyloidosis. Once you know that, the most important step at that junction is to rule out AL amyloidosis. And you can do that by doing a simple urine test, checking your kappa and lambda, because AL amyloidosis is a quote-unquote form of cancer. It's a medical emergency, and patients need to be rushed in for chemotherapy. So it's very important that we don't miss these diagnoses. So once we have a normal kappa lambda, this is where PYP scanning comes in handy, because it will tell you to differentiate or confirm ATTR amyloidosis. If the PYP scan is very well done and confirmed, then you don't need the biopsy and you can potentially start therapy. However, if the PYP is borderline, or you start to have some your confirmation is still questionable, then you do need to make biopsy, or you need genetic studies in some cases to differentiate the wild type from the hereditary type ATTR. So to sum it up, start with echo, then move on to either CMR as needed. Then at that junction, you do need to do kappa lambda to rule out AL, and then to confirm ATTR by PYP. And then you decide if you want to, at that point, if you need biopsy or to do genetic testing to look for the type of amyloidosis this patient have to start therapy in these cases. But the most important step for a non-cardiologist is always be aware of these conditions and look for the flag marks for these, because the earlier we detect these cases, the more benefit that they will get from starting these therapies. If we detect them late, when everything is classic, we may not have a lot of impact on their natural history at that point.
That was a great discussion, really, Moaz, on how to handle the situation. And I think, we're more and more aware of it. It's not only awareness, it's very interesting, at least to me, is that as we treat patients with valvular heart disease, and that's now our next segment, with aortic stenosis, you know, the prevalence of amyloidosis in such an older population that we're treating, above age 80, most of them, is about almost 20%, 15, 20%, depending what, you know, what series you look at. And I think it's important to keep that in mind. The other thing is obviously the new treatment for ATTR amyloidosis, which is you know, phenomenal. There's something new that was not present during our training before. So this is really good. All right, well, I think thank you very much, Muaz. Thank you, Deepan, also for your contributions for this segment. We're going to go ahead and move to the last segment for this first half of this course, which deals with valvular heart disease. Thanks, Muaz, again, for joining us. So this next section here, session 4, is valvular heart disease advances and treatment choices. And if you ask me, what is an area that has been really revolutionized over the past 10, 15 years, it's really valvular heart disease. It used to be among the most, I wouldn't say boring, but you know, the more stagnant areas in our management was mostly deciding when to intervene, et cetera, et cetera. But I think with the advent of catheter-based procedures and interventions on valvular heart disease, not only for the aortic valve with TAVR, but for the mitral valve, and the investment in innovations of catheter-based techniques to replace valves, really has infused so much energy, and I think has been wonderful for patients because they don't have to go, in all the cases, to go to open heart surgery and have valve replacement. So with that, we have three lectures for you, short lectures on the state of the art. The first one we'll start with is TAVR, right? The percutaneous aortic valve replacement for aortic stenosis. Is it for every patient? And who else to give this talk but Dr. Michael Reardon, who really does not need an introduction, and one of the pioneers in this field. Surgeon by training, he's an amazing surgeon, but also very involved in catheter-based procedures and has been the principal investigator of many of these trials. And Dr. Reardon is actually currently in France, and because this year is the 20th anniversary of the first ever procedure by Dr. Alain Cribier, who we saw a couple of months ago. And there is a celebration for that in Rouen. So I know he's on his way there, but he was kind enough to record this before he leaves, and I don't know if he'll be able to join us. So, Michael?
Good morning. I'm Dr. Michael Reardon, a cardiac surgeon at the Houston Methodist Hospital, and today we're going to talk about TAVR for aortic stenosis. Is it for every patient? These are my conflicts of interest. I've been involved in the majority of the TAVR trials as a national PI or the study chair, and most importantly, I am a cardiac surgeon. I still like cardiac surgery operations. So let's look at the data. These are the two extreme risk trials that were run. The Partner 1A trial, randomized between medical therapy and TAVR. And what you can see is TAVR had a 20% survival advantage every year out to 5 years. We got to the core valve extreme risk, we can no longer randomize. We use the objective performance goal based on some BAV trials as well as the partner data, and you see that our TAVR survival is exactly the same. So TAVR got approved for extreme risk, and of course we don't want to operate on these people. Then moved to high risk, where the primary endpoint was all-cause mortality. The Partner 1A randomized against high risk. The CERTAVI high-risk trial randomized the core valve against high risk. And what you can see is there's no difference in the survival out to 5 years. So it got approved for high risk. The mean age in this, remember, was 84 years old. They went to intermediate risk. The primary endpoint in both of these was all-cause mortality or disabling stroke. And again, no difference through 5 years. So it got it approved for intermediate risk. The mean age in these trials was 81 years of age. Then we went to low risk. Partner at this time used a endpoint of all-cause mortality, all stroke, or hospitalization. In the Evolut low-risk trial, we stuck with a endpoint of all-cause mortality or disabling stroke and used a Bayesian analysis to give us a 2-year endpoint. And Partner turned out to be statistically superior, and we were non-inferior. So it got approved for low risk. The mean age in these trials was 74 years, so still nobody really young. That led to the current guidelines that are out there, and the current guidelines say that if you're less than 65, or you're likely to live 20 years or more, you should probably have a surgical aortic valve. If you're 80 or going to live 10 years or less, and you're a good candidate for transfemoral TAVR, you should have TAVR. Between 65 and 80, you should balance the anatomic risk of TAVR against the physiologic risk of surgery and the patient's wishes for either TAVR or SAVR. So let's look at the low-risk trials, since that's kind of where people really wonder. Again, there was the endpoint of all-cause mortality, all stroke, or hospitalization for the PARTNER trial. And the S3 current generation valve was already available when the trial started, so all the implanters already knew how to use this, and it was used throughout the trial. In the Evolut low risk, we decided to stay with all-cause mortality disabling stroke, but we then needed more time, so we added a Bayesian analysis. But you can also see we started with some first-generation core valve. Most of them were second-generation Evolut R, and about 23% were the third-generation Evolut R Pros, which we're using now. So again, the implanters had to learn this valve as we went along. Again, here are the endpoints that we achieved in both these trials. If we look at some of the Kaplan-Meier curves for all-cause mortality in these two trials, what we see is the all-cause mortality in a month is about the same, 0.4 for TAVR, 1.1 and 1.2 for surgery. And in a year, both are lower in the PARTNER trial and both are a little bit higher, but no difference in the Evolut low-risk trial. And this is because PARTNER actually recruited a lower risk patient in the low risk, which is reflected in both of these being lower, and we'll talk about that in a little bit. This was all stroke. We always worried about stroke with TAVR, but what you can see is that stroke is statistically less in TAVR in both of these trials. And it's been that way in every randomized trial except for the initial PARTNER 1A high-risk trial. Remember, embolic protection devices only became available halfway through this trial. We did not really allow them. We couldn't ban them, but only a few % were used. It's still a very low stroke rate. If we look at hospitalization, statistically positive for TAVR in both trials. And in fact, if I put together a three-part endpoint for the Evolut low risk using hospitalization, disabling stroke, and all-cause mortality, we see that TAVR is statistically positive in this trial also. That's why when we presented this in 2019, Eugene Brunwald said this was such an amazing set of data because they were both concurrent and both really superior. The question is, who wasn't tested? Because remember, randomized trials only apply to the population tested. Well, who was excluded? Bicuspid valve, significant coronary disease, unfavorable anatomy, associated procedures, and anybody appropriate for mechanical device were all excluded from the trial. If we look at bicuspid valves, most of us use the Sievers classification based on the number of Raphe. There are no Raphe 1, 1 Raphe 2, or 2 Raphes, 1 Raphe Sievers 1, 2 Raphe Sievers 2. The most common is a Sievers 1 with a left-right commissure that's fused. Now, we used to think when I first started surgery many years ago that bicuspid valves occurred only in young people, but when you're 80, they're still about 20% of what we see. In the 60 to 70 year range, where we're seeing a lot of the low-risk patients right now, they're 50 to 60% of the cases, and they weren't studied in the low-risk randomized trials. Raj Makar and Yoon at Cedars-Sinai has done a lot of work on this, looking at which ones can actually be treated and which ones can't. And what they found is if you had a heavily calcified Raphe and a heavily calcified opposite leaflet, you did very poorly. If you only had a calcified Raphe or a opposite leaflet that was calcified, you did okay. And the ones that did best were the ones without any heavy calcification anywhere, just moderate calcification. Now, we ran a low-risk trial for the Evolut valve, and this was a non-randomized, but all comers. And what we can see is the hemodynamics were excellent, and the amount of paravalvular leak was excellent. And we followed this out to 1 year, and again, superior hemodynamics, mean gradients in 1, EOAs above 2. So yes, we can treat these. You just have to select them fairly carefully. The paravalvular regurgitation, which we always worry about in bicuspid valves, in this trial that we ran was actually lower in the bicuspid valves than in the tricuspid valves. How about age less than 65? Well, if you look in the PARTNER trial, only 7% were less than 65, and in the Medtronic Evolut low risk, only 6% were less than 65. In the Evolut trial that I ran, only 1.3% were less than 60. So we have people in their 50s coming in asking for TAVR, and one thing I have to tell them is we didn't test people like you. How about anatomy? Anatomy too big, too small? Yeah, that makes sense. We couldn't treat those. They're just outside the IFU, although people are starting to treat some of them now. Bicuspid valves we talked about, and excessive LVOT calcification. One of those things that's very hard to define, but a lot of people did get screened out. And in fact, if you look at these trials, what happened is all these people were seen by the local heart team who had to say they were anatomically appropriate for surgery or TAVR and met all the inclusion and exclusion. So you would think that basically everybody would be accepted in the trial at the national screening. But for the partner trial, 34%, over 1/3, were rejected at the national level and 14.8% in Evolut. So it's like, as you can see, partner selected very carefully for people that would do well in TAVR. Significant coronary disease, partner said you couldn't do it if your syntax was over 32, Evolut over 22. But the mean syntax in Evolut in the arm that was set up for needing revascularization was only 7. So we didn't treat severe coronary disease in either of these trials. So we really can't comment on that. And if we look at this, we see that people that needed coronary disease didn't do as well, but people that had TAVR and did or did not need coronary revascularization did better in both categories. How about bioprosthetic valve dysfunction, which is really defined in 4 categories: structural, non-structural, thrombosis, and endocarditis. It's really structural valve deterioration that we're worried about. But we know that surgical valves, although we think they're the same, there are a number of early failures that we've seen that have been published. In fact, we published the first paper on early trifecta failure in 2017, and since there's been a number of papers showing this valve, like the mitral flow, fails early. And we do have some TAVR data. This is the NOTION trial, which was an all-comers 70 or above in the Nordic countries, randomizing the original early generation core valve against surgery. What we see is we maintain excellent hemodynamics out to 8 years. And if we look at moderate structural valve deterioration, defined as an increase of the mean gradient of 10 millimeters or more from the post-discharge echo to now, and a final mean gradient over 20, or intraprosthetic aortic regurgitation of moderate or more, we see the rate for surgery is 28.5 and SAVR is 14.1. So interesting, SAVR actually is much better than surgery in this trial. If you look at severe, which is patients that now have a mean gradient up around 40, it's very low in both of these. Both these valves last about the same. This is data that I just presented at the ACC. This is from the higher risk and Surtavi randomized trials, over 2,000 patients, and what we saw, the moderate defined is pretty much the same, was 4.38 for surgery and 2.57. That's a P of 0.0095, statistically significant for less structural valve duration per TAVI. This is interesting because surgeons have always told people, well, you can't have TAVR if you're young because surgical valves last longer. This directly contradicts that and say with this particular valve, there's less structural valve deterioration than with surgery. Now we have a number of trials of partner 1B, 1A, core valve extreme, core valve high, partner 2A, and even the Surtavi intermediate risk trial now. What they show you is that at the 5 years, all these valves are lasting really well. Now the good news is for Surtavi and Evolut low risk, as well as the partner 2A intermediate trial for Edwards and the partner 3 low risk trial, all these trials will be followed for 10 years. Now when I think about how I want to approach these people and who gets a TAVR versus who gets surgery, a lot of it depends on how long you're going to live. So if you're 80, which is where the guidelines say you should start doing TAVR, well, you're going to live about 10 years based on U.S. life analysis. Now remember, once you have aortic valve disease and you have a surgical prosthetic set in, you're not going to live up to the normal life expectancy. You just never do. But we'll take 10 years. If you have a Carpentier-Edwards pericardial valve, the risk of that wearing out in your lifetime if you're 80, it's about 4%. So yeah, TAVR makes sense because they're going to last about as long. 75, now you're going to live about 13 years by life table, less once you have a valve. Now it's about 6%. Still makes a lot of sense to get a TAVR. How about 65, which is the lower end? Now you're going to live about 20 years or so, and the risk is about 17%. Still not all that bad because not everybody's going to fail, but as you get down to 60 and 50, now you're going to live in the 30 years or longer, and we need to think very carefully about what valve we're going to put into these people. But these are kind of the data that I can share with my patients about who should and should not get TAVR. And leads us again to our guidelines. 65 or 20 years or more, probably still should consider surgery. 80 or above, good anatomy for transfemoral, get a TAVR anywhere between. Again, we discuss that with the patient and we look at the TAVR risk versus the surgical risk. So finally, TAVR is not right for every patient, but we have to remember it's really right for very many. That's why there's more TAVRs done right now in the US than all aortic surgical procedures combined. Thank you very much. It's been a pleasure talking to you this morning. I'm happy to answer any questions.
Thank you very much, Dr. Reardon. A great overview of where we are in TAVR and where we're heading. The amazing thing to me is also the recent presentation that you had at the ACC showing in the high risk that actually durability of the valve is better than the durability of the surgical valve, at least for some time. And we'll see what the data looks like, but it looks very, very, very important and very appealing from a patient's perspective. All right, from the aortic valve, we're going to go to the mitral valve with catheter-based procedures and the catheter-based mitral valve therapies. Where are we? Are they a good option? And it's great to have Dr. Sachin Goel, who is the director of our structural heart intervention program at Houston Methodist, who will address that. And he's our major mitral valve interventionalist. Sachin.
Hi, I'm Sachin Goel, Interventional Cardiologist here at Houston Methodist. My task today is to discuss catheter-based mitral valve therapies. Is this a good option? Here are my disclosures. Catheter-based therapies for mitral valve disease originated with percutaneous transvenous mitral commissurotomy, also referred to as balloon mitral valvuloplasty for rheumatic mitral stenosis decades ago. In patients with rheumatic mitral stenosis, as you can see here, the echo images demonstrate a thickened, restricted stenotic mitral valve with a very small mitral valve area. Here is a mitral valvuloplasty being performed via transcatheter transvenous access after obtaining transseptal access with the Inouye balloon, which leads to splitting of the commissures and relief from mitral stenosis with a concomitant increase in the mitral valve area from 0.9 to 1.4, as you can see in these 3D echo images. This procedure really has laid the foundation for transcatheter mitral valve therapy. Structural heart disease, in terms of the epidemiology, is increasing as our population is getting older. The prevalence of mitral valve disease is almost 10%. Moderate to severe mitral valve disease is almost 10% in patients older than 75 years of age. And a lot of these patients are high surgical risk candidates and are not being treated surgically due to the risk. So if you look at the recent statistics, there are more than 4.6 million patients with mitral regurgitation grade 2 or more in the United States, out of which only about 55,000 mitral valve surgeries are performed in the United States annually. So there is a huge unmet clinical need, which is large and growing for other therapies for mitral regurgitation, non-surgical treatment options, or transcatheter therapies. Here are the Cleveland Clinic data. When I was in training, we looked at over 5,000 patients with severe MR, out of which over 1,000 had significant mitral regurgitation, and vast majority of functional patients and a significant proportion of degenerative mitral regurgitation patients were managed medically. And as you can see over time, this is associated with significant mortality and morbidity in terms of proportion of surviving patients hospitalized for heart failure. So this is a huge problem. The mitral valve anatomy, briefly, the mitral valve is much more complex compared to aortic valve, since it's not only involves the leaflets, but also the entire mitral valve apparatus, which includes chordae tendineae, the papillary muscles, and the attached ventricular myocardium. Briefly, the anterior and the posterior mitral valve leaflets are divided into scallops from medial to lateral, and these are labeled in this image, A3, A2, A1, and correspondingly P3, P2, P1. This becomes important when we talk about edge-to-edge repair or MitraClip. So briefly, what are the causes of MR? Broadly speaking, MR causes are divided into primary MR and secondary. Primary means MR related to intrinsic involvement of the mitral valve leaflets and the chordae, meaning there's something wrong with the mitral valve leaflets or the chordae themselves. Secondary MR is also known as functional MR. In this cases, there's nothing wrong with the leaflets or the chordae themselves, but the MR results from left ventricular pathology. And I will demonstrate some examples. So here is an example of primary MR or degenerative MR. This is a patient with mitral valve prolapse and in fact flail of the posterior leaflet of the mitral valve, as you can see in the transesophageal echo images. There is a lot of tissue which is redundant and prolapsing and into the left atrium up here with resultant severe mitral regurgitation, and the corresponding 3D TEE image showing a large posterior leaflet flail. This is an example of primary MR where chordae have ruptured and posterior leaflet is flail. In contrast, on the next image here, you will see a case of functional or secondary mitral regurgitation where the leaflets themselves really have no problem, but they fail to coapt because of LV enlargement, LV systolic dysfunction, apical tethering of these leaflets, and displacement of the papillary muscles, resulting in severe mitral regurgitation. This is seen in patients who have ischemic cardiomyopathy or non-ischemic cardiomyopathy with resultant LV dysfunction and LV enlargement. So the edge-to-edge repair or MitraClip is a technique which is based on the surgical edge-to-edge repair, which was pioneered by Dr. Alfieri, an Italian surgeon. And the technique involves sewing the A2 and the P2 scallop of the mitral valve. This has been pioneered by Dr. Alfieri, and the edge-to-edge or the MitraClip technique is a transcatheter technique by which this edge-to-edge repair is mimicked. The procedure is performed via transfemoral venous access and transseptal access, whereby a catheter is advanced from the femoral vein into the right atrium, across the septum into the left atrium, and the scallops of the mitral valve, anterior and posterior, are grasped, as you can see, achieving coaptation and reducing MR. MitraClip, this is the timeline or the evolution of the MitraClip. The first case was performed in 2003. The landmark Everest trial was performed and published in 2011. Followed by FDA approval for primary or degenerative MR, followed by the COAP trial, which I will allude to subsequently, and then most recently the FDA approval for secondary or functional MR in 2019. There are anatomic criteria that define suitability for MitraClip. The most optimal cases are where the pathology is central in the middle of the mitral valve, in the A2-P2 scallop region, without any calcium, with large valve areas and long leaflets. There are other conditional and unsuitable anatomic features, which I won't get into a lot of detail for the purposes of this talk. So here's an example of posterior leaflet flail. You can see this is a TEE image. This is a posterior leaflet, which is flail, resulting in severe mitral regurgitation. And this was successfully clipped with 2 MitraClips. And you can see on the bottom left image here, there is trivial mitral regurgitation, with the help of 2 clips, which were placed in the center of the valve. We can also treat non-central pathology. Here is an example of A1 flail, which is the anterior leaflet of the mitral valve, all the way in the lateral commissure. You can appreciate it on the 3D image here. This is the lateral commissure, this is the medial commissure, and all the way in the lateral commissure, there is a flail segment resulting in severe MR. And this was successfully treated with MitraClip, as you can see, with complete resolution of mitral regurgitation. Similarly, medial commissural flails have been treated successfully. Here an example of A3 flail, which is on the other side of the valve, on the medial commissure, and this was successfully treated with 1 clip, resulting in severe, almost abolishment of the severe MR. Here is the left atrial waveform pre and post MitraClip. When we do these procedures, we measure the pressure in the left atrium, and this is a large V wave consistent with very severe mitral regurgitation. And you can see a significant reduction in the LAV wave, which is always very gratifying to see when we do these procedures. As when we see this, you know the patient is going to feel better symptomatically. What about next generation MitraClips? There are now 4 different varieties of MitraClips. These are the generation 4 devices. The old studies were done with the first generation clips, but now we have newer clips which have several features, including independent grasping ability, where we can grasp the anterior leaflet first, followed by the posterior, and vice versa. In addition, we have longer clips and wider clips. So this allows the ability to treat a wider range of pathology. We've also done some urgent emergent cases during the COVID pandemic last year, and one of our residents published this. Moving on to the secondary or functional MR, the COAP trial is the landmark trial, which evaluated the safety and efficacy of MitraClip on top of guideline-directed medical therapy in patients with heart failure and secondary MR who remained symptomatic despite maximally tolerated guideline-directed medical therapy. About 600 patients were randomized 1-to-1. Here are the baseline characteristics: 300 patients in each group. Mean age was about 72 years. Usual host of comorbidities. The etiology of heart failure was ischemic in about 2/3 and non-ischemic in about 1/3. Most of these had NYHA class 2 or 3 heart failure, and about 50% had 3+ and 50% had about 4+ mitral regurgitation. The mean left ventricular ejection fraction, important to note in these two groups, was about 30%. Procedure was successfully performed in 98% patients, and mean number of clips implanted was 1.7. In about half of these patients, we can get a good result, which is less than equal to mild MR with 1 clip, and in the others, more than 1 clip needed. Here's the echo at discharge. Almost 95% patients had reduction to grade 2 or less MR, with more than 80% patients with 1+ or less MR. Remember, this was done with the older generation clip, and we have data now with the newer generation clip to say that the proportion of patients with less than equal to 1+ MR is upwards of 90%. 90 to 95% patients, we can achieve grade 1+ or less mitral regurgitation with the newer generation clip. So here are the data from the COAP trial. The primary effectiveness endpoint, which was all hospitalizations for heart failure within 24 months, was significantly in favor of the Mitra clip on top of guideline-directed medical therapy compared to GDMT alone, with a hazard ratio of 0.53 and a highly statistically significant p-value, and a number needed to treat of about 3 to prevent 1 heart failure hospitalization. What about all-cause mortality? Again, similar separation of the Kaplan-Meier curves with hazard ratio of 0.62 in favor of the Mitra clip on top of GDMT, with number needed to treat of about 6 to prevent 1 death. So these are very impressive data in favor of Mitra clip. Death or heart failure hospitalization, same story, hazard ratio of 0.57, number needed to treat is 4.5. So just to give you a sort of a perspective for heart failure patients, the number needed to treat, these are the standard heart failure medical therapy, or the GDMT that we talk about. And when you look at the cumulative data over the last few decades, the number needed to treat for all-cause mortality to prevent 1 death is about 22 for an ACE inhibitor or ARB, 28 for beta blocker, 9 for aldosterone antagonist, 36 for sacubitril valsartan or Entresto. However, for Mitra clip, on top of these medical therapies, is about 6. So again, these are highly statistically significant and impressive data, which led to guideline changes, which I will allude to shortly. Here is a quick example of an FMR case that we treated recently. Patient with cardiomyopathy and severe MR, successfully treated with 1 clip, with reduction from very severe mitral regurgitation to trace mitral regurgitation. And equally impressive is the LA V-wave waveform, which was the pressure in the left atrium, 64 millimeters of mercury. And post-Mitra clip, the V-wave reduced, as you can see here, to 20 millimeters of mercury. So a huge reduction in left atrial pressure, which correlates nicely with clinical improvement in these patients. So based on the data from the COAP trial, the FDA approved Mitra clip for functional mitral regurgitation back in 2019. And the most recent version of the guidelines, the valve guidelines in 2020, has included Mitra clip for both primary as well as secondary mitral regurgitation. And Mitra clip is now referred to as transcatheter edge-to-edge repair, or TEER, according to the most recent nomenclature. This is a quick timeline of the cumulative data on Mitra clip over the last 10 years. Everest True was the study looking at Mitra clip for primary MR, published in the New England Journal in 2011. The FDA approved it for primary MR in 2013. The COAP results were published in the New England Journal of Medicine in 2018, and FDA approved this for this indication in 2019. And I will briefly go over the most recent guidelines. So transcatheter edge-to-edge repair, or Mitra clip, is upgraded to a Class 2A recommendation for high or prohibitive risk primary MR patients. This is a Class 2A indications if the anatomy is favorable and patient's life expectancy is at least a year or more. It is a Class 2 indication for primary or degenerative MR. The surgical risk, of course, is established based on the STS risk, frailty, and other comorbidities. For secondary MR or functional MR, Mitra clip or transcatheter edge-to-edge repair also has a Class 2A indication in patients who have persistent NYHA Class 2 to 4 symptoms while on optimal GDMT for heart failure. It is considered to be a reasonable approach in patients with appropriate anatomy, with LV ejection fraction between 20 to 50%, left ventricular end systolic dimension less than equal to 7 centimeters, and pulmonary systolic pressure less than equal to 70 millimeters of mercury. These are criteria based on the COAP trial data. In 2014, there was no recommendations for transcatheter edge-to-edge repair for functional MR, whereas now it is a Class 2A indication. What about other approaches other than MitraClip? Well, there are several other transcatheter-based approaches that I will briefly go over in the next few slides. There are coronary sinus-based approaches where a device such as the Carillon device can be implanted via transcatheter route into the coronary sinus, which runs right behind the mitral valve annulus. And by cinching this annulus, reduction in mitral regurgitation can be achieved. This is an ongoing study. CT plays an important role in assessing suitability for the annuloplasty-based devices. What about neocords? There are neocords which are being studied, which can be implanted via both transapical approach as well as transseptal, transfemoral approach for cases with flail and degenerative MR with reduction in mitral regurgitation. And we are a site for one of these new devices by Pipeline, which is now acquired by Gore for transfemoral transseptal mitral valve chordal repair. Pascal device is another form of transcatheter edge-to-edge repair by Edwards Life Sciences. It has a slightly different mechanism compared to MitraClip, but the end result is very similar, and we are participating in the CLASP study, which is evaluating safety and efficacy of this device compared to the MitraClip. There are other annuloplasty-based devices, such as the Edwards Cardioband Mitral Valve Reconstruction System, which is a transseptal transfemoral system whereby anchors are implanted around the mitral annulus. And here is an image demonstrating the mitral regurgitation before these anchors are cinched or adjusted. And after the anchors are cinched, there is near resolution of mitral regurgitation. This is acquired CE mark in Europe and is currently being studied. Moving on, the next horizon is transcatheter mitral valve replacement. You all have heard success stories of transcatheter aortic valve replacement. This is the next field, the next broad field in the world of transcatheter valvular intervention. And there are various devices that are being studied as we speak. Apollo trial is evaluating the role of the safety and efficacy of the Intrepid transcatheter heart valve, which is a Medtronic valve. It is a dual stent design with an atrial rim. We are studying the valve in patients with primary or secondary MR. In addition to a MACC cohort whereby we are evaluating patients who have significant mitral annular calcification. So who are candidates for TMVR? Well, transcatheter mitral valve replacement patients are usually those who are non-candidates or poor candidates for edge-to-edge repair or MitraClip due to anatomic reasons, or they are not surgical candidates or high surgical risk candidates due to frailty and comorbidities. So how do we do this? So the Apollo's trial is looking at transapical primarily, and now there is a transfemoral transseptal access as well. But extensive planning is done by way of echo as well as CT. And here is an example of a case we did recently. This patient was not a candidate for MitraClip. And as you can see on these echo images, there is very severe mitral regurgitation originating from the medial part of the valve. So this procedure, the transcatheter mitral valve replacement, was performed via transapical access. There's a big catheter inserted through the apex of the heart. This procedure is performed, of course, with fluoroscopy and echo guidance. And the valve, the Intrepid valve, is slowly extruded in the mitral position. And here is the final fluoroscopic image demonstrating well-positioned device, which is confirmed by echocardiogram in the next slide. So here's the echo image of the Intrepid valve, resulting in resolution of mitral regurgitation, and a nice 3D image and fast view from the left atrium of the Intrepid valve implanted successfully in this patient who's doing very well. Here's the color Doppler, again demonstrating no residual mitral regurgitation and acceptable mitral valve gradient. The Apollo study also has a transfemoral early feasibility study that is ongoing, which is evaluating the same valve via transseptal transfemoral approach. And there's a lot of excitement in the field regarding this approach because this avoids transapical access and transseptal transfemoral is obviously less invasive. There are other devices such as the Alta valve, which consists of a large spherical nitinol ball with a supraannular valve that can be implanted via transapical and now also transseptal access. We published this case last year, the first in the United States. and we are enrolling in the early feasibility study currently in the United States. There are other approaches for TMVR with the TAVR transcatheter heart valve system, the SAPIEN valve, and we have done transcatheter mitral valve replacement for failed prosthetic rings or failed prosthetic valves, and even in cases with severe mitral annular calcification. And there is growing data to suggest safety and efficacy in these carefully selected patients, of course, with suitable anatomy. As you can see, this can be performed via transeptal access into the mitral position. Here is an example of transcatheter mitral valve replacement in a patient with severe mitral annular calcification. Of note, this patient has had TAVR previously, and transcatheter mitral valve replacement was successfully performed in this high surgical risk patient with a good result. So there are various approaches for transcatheter mitral valve replacement, and multimodality imaging really plays a key role in assessing suitability for these patients. Lastly, paravalvular leak closure is another tool in our armamentarium where we can put plugs in patients who have paravalvular leak after surgical or now transcatheter valve replacements. This is an example where patient had surgical valve several years ago and now presented with severe paravalvular leak and hemolysis. And with the help of fusion imaging, transesophageal echo, and fluoro, we were able to place plugs with resultant resolution of the paravalvular leak, as you can see in this image. So in conclusion, transcatheter mitral valve interventions are a therapeutic breakthrough, providing treatment options for high or prohibitive surgical risk patients. MitraClip or transcatheter edge-to-edge repair is a good option for prohibitive and high surgical risk patients with degenerative or primary MR, and also for optimally medically managed patients with FMR who continue to be symptomatic and have severe MR. Multimodality imaging is key for patient selection. Echo, CT, and MRI are used for pre-procedural assessment. Echo and fluoroscopy, of course, are key for intra-procedural guidance, and fusion imaging has potential role. Transcatheter mitral valve replacement is, of course, the next horizon and is being studied actively and has a huge potential role over the next few years. Thank you very much for your attention.
Thank you very much, Dr. Goel, for this overview of transcatheter mitral valve interventions. And I think this is a major area of advancement in catheter-based therapies in patients that are really in need of such, particularly those at high risk of open heart surgery. We wanted in this section to add in structural heart disease a primer for adult congenital heart disease, which I think is important because many of you will be either treating or facing a new diagnosis of patients with adult congenital heart disease, and we know they're surviving well, actually, and living well with adult congenital heart disease into adulthood. So who best to give us this primer than Dr. Valeria Duarte? She's our expert in adult congenital heart disease program here at Houston Methodist. Amazing background at MGH and Boston Children's Hospital with interest and expertise in cardiovascular imaging in the adult congenital heart disease population and high-risk pregnancies. Valeria, look forward to your presentation.
Good morning. Welcome to another edition of Cardiology for the Non-Cardiologist. My name is Valeria Duarte. I'm one of the adult congenital cardiologists at the Houston Methodist. We're going to spend the next 15 minutes talking about congenital heart disease for the non-cardiologist. So without further ado, let's get started. How frequent is adult congenital heart disease? So 1 in 100 newborns have some kind of congenital heart disease. So it's quite frequent. There are currently 1 million children in the US with congenital heart disease. And more importantly for this lecture, there is a greater population of adults with congenital heart disease, estimated at 1.4 million. This is a growing population. Looking at the trend from 1985 to 2000, there was a 22% increase in the number of children with congenital heart disease, and an 85% increase in the number of adults. This is a cumulative effect. And the main reason is because cardiac surgery and pediatric cardiology have advanced so much that patients that in the 40s and 50s and 60s would die shortly after birth now survive into adulthood. So the great majority of patients now born with congenital heart disease survive into adulthood, and we will see them in our clinics. So when do we suspect that an adult patient that we meet in clinic has congenital heart disease? So there are a few hints, and there are more, but these are some important ones that I want to share with you. So first, patients who, when you're doing the past medical history, tell you that they had a murmur or a hole in their heart in childhood. Even those patients that tell you, but I was told it was closed, it closed on its own, or they closed it surgically. Those patients need follow-up. Once we see them, we image them, we make sure they don't have residual defects. Then we may space out their follow-ups to once a year, once every 2 years. But first we need to study them. Patients who have a sternotomy or a thoracotomy scar, or who tell you that they had surgery during childhood. Some patients won't know what surgery they have, what was the problem, because some of them may have had it when they were infants. Sometimes the parents will be with them and then we'll have more history, but patients that are living far away from their parents, or the parents are no longer alive, then we need to start from scratch. Patients with arrhythmias at a young age. Some of them may not have congenital heart disease, but these are patients that need a closer look. So we are always happy to evaluate them in our clinic and perform a congenital echocardiogram to rule out defects. Patients with right ventricular enlargement, that it's not explained for a known reason. So those need to be evaluated. Shunts need to be ruled out in these patients, and they will need a dedicated congenital echocardiogram. In a large proportion may also need a congenital MRI. Patients with pulmonary hypertension. These patients, just like the patients with right ventricular enlargement of unknown cause, shunts and congenital defects, some complex congenital defects, need to be ruled out in patients who are being evaluated for newly diagnosed pulmonary hypertension. Patients with cyanosis, chronic O2 saturations lower than 92% at baseline or with exercise, or patients who have clogging. Those patients need to be seen in our clinic. Patients with syndromes that are associated with congenital heart disease, such as Down syndrome, those patients may have AV canal defects, or patients with Noonan syndrome that may have pulmonary stenosis, or patients with Turner that may have bicuspid aortic valve or coarctation of the aorta. Patients with hypertension are at young age, especially those with that are refractory to treatment. In these patients, we need to rule out secondary causes, and one of them is coarctation. So they should be evaluated with an echocardiogram and cross-sectional imaging, with an MRI, cardiac MRI, or a cardiac CT. So we see these patients in our clinic, and we perform a thorough evaluation to rule out this. Why do patients with ACHD need follow-up at an ACHD center? This is a very heterogeneous population. You can have a patient with a repair tetralogy of Fallot who who doesn't have any limitations and no residual defect and good exercise capacity. And you may have a patient with repaired atrial FALO who has right ventricular failure, severe pulmonary regurgitation, and that may need evaluation for and recurrent arrhythmias that may need evaluation for transplant. So there are two ends of the spectrum in the same condition here. So these patients need to see specialists with congenital expertise. So they need a congenital cardiologist, a congenital cardiac imager, a congenital interventionalist, and a congenital surgeon, because they have better outcomes when they're seen by providers with expertise. It's important, even in those with repaired congenital heart disease, to have surveillance, to undergo surveillance for residual defects or long-term complications. And these tests need to be focused and specific to each condition. We have imaging protocols that are specific to each condition, looking for the known residual defects, the known long-term complications. Patients with congenital heart disease may have tests that lead to wrong diagnosis because of their unusual anatomy and unusual post-surgical anatomy. For example, patients with single ventricle may be diagnosed with a PE because the pulmonary blood flow is very slow in these patients, and they may not have one. It just may be the result of slow flow, and the imaging should be delayed in these patients. So that's important to know. So in ACHD, Comprehensive Care Center has a large amount of providers that are trained to treat their specific defects, including anesthesiologists. Patients with congenital heart disease may have a high pressure right ventricles, and they may decompensate it with anesthesia induction. So the anesthesiologists need to have all the information of their baseline hemodynamics. They need to be prepared to handle their response to anesthesia. They need a multidisciplinary team, OB, MFM, to help them when they get pregnant. Some patients may have liver complications and they need a hepatology evaluation. And some of these patients have undergone many surgeries and through their lifetime, and they may need social work support and counseling. The electrophysiologist may need to be familiar with the anatomy and so forth. So the ACHD guidelines from 2018 classify this congenital heart disease in simple, moderate, and great complexity. In the simple group, we have the septal defects, small septal defects that are unrepaired, or larger septal defects that are repaired. In the moderate complexity, we have anomalous pulmonary vein connections, anomalous coronary artery origins, atrioventricular septal defects, coarctation of the aorta, Epstein anomaly of the tricuspid valve, ostium primum ASD, subvalvular aortic stenosis, repaired atrial FALO, larger VSDs. And in the great complexity group, we will have, for example, patients with cyanosis, patients who undergone the Fontan procedure, that is a palliative surgery for patients who live with a single ventricle, transposition of the great arteries, truncus. So those are some examples of the defects that you may see in your clinic, because these patients now survive into adulthood and they're very functional. So let's review some examples of congenital heart disease that you may find in your practice. So this is a 29-year-old patient with atrial flutter. And on echo and cardiac MRI, we found an undiagnosed till then and primum ASD. And it's important, you can see here, if you look, this is a cardiac MRI, this is anterior, posterior, left atrium, right atrium, left ventricle, right ventricle, and you can see the atrial septum here, and that there is a piece of it missing, the piece that is close to the mitral valve and the tricuspid valve. So this is a surgical type of defect. It cannot be repaired percutaneously, and the surgeon needs to be a congenital surgeon, know how close the defect is to the valve, so that needs to be addressed with utmost care. And also the primum ASD can be associated with cleft mitral valve that also has mitral regurgitation, and the mechanism is different from the usual mitral regurgitation. So needs to be repaired carefully. You can see here, this is the mitral valve, and the anterior leaflet is divided into two. There is like a piece missing. That needs to be sutured by the surgeon at the time of the repair. This is another patient I want to share with you. It's a 38-year-old man who presented with palpitation and dyspnea on exertion. No prior cardiac history. The echocardiogram demonstrated a dilated RV. The cause was unknown, so he was referred to us. We performed a cardiac MRI. You can see here, this is a 4-chamber view. This is the left ventricle. This is the right ventricle. You can see how the right ventricle is severely dilated. It's usually smaller than the left ventricle, and here you can see that it's roughly double the size of the left ventricle. We confirm this in short axis view. This is the left ventricle in short axis, the right ventricle in short axis. Severe RV dilation. And then in our axial right blood stat, we can see here, this is a SVC, very close to the SVC-RA junction. This is the left atrium. These are the pulmonary veins coming into the left atrium. You can see how as the right upper pulmonary vein courses towards the left atrium, there is a defect between the pulmonary vein and the SVC. This is called right there. This is called a sinus venosus defect. Has a very similar physiology to all the atrial septal defects, causes RA, right atrial enlargement, right ventricular enlargement, and dysfunction. And this needs to be addressed surgically by a congenital surgeon. This is another patient I wanted to share with you. She's a 33-year-old woman who, with refractory hypertension since she was in her 20s, on multiple medications. She presented with stroke, unfortunately. As you can see here, this is a CTA of the aorta. This is the aortic arch, and you can see how there is a discrete coarctation, severe coarctation here, and you can see some enlarged vessels. Those are the collaterals. Coarctation of the aorta is a known cause of secondary hypertension, so this patient needs to be evaluated. This is the same patient in 3D reconstruction. You can see the aortic arch here with a discrete coarctation, and if you pay attention, you will see all these collaterals from the mammaries bypassing the obstruction. And this patient was intervened on. She recovered nicely from her stroke, thankfully. You can see here, this is an angiogram, or aortic angiogram. This is the coarctation site here, and this is the stent that was placed, and you can see how nice the result. This needs to be done by a congenital interventionalist. We won't talk very much about complex conditions because it exceeds the purpose of this talk, but I just wanted to share with you some images of a single ventricle physiology. So the first patient is a patient with double inlet left ventricle. You can see here, this is the left ventricle here, and anterior to it, this is the right ventricle, which is hypoplastic. And you can see how both the tricuspid and the mitral valve drain into the same ventricle, the left ventricle. So this is a patient with single ventricle physiology. And this is another patient with tricuspid atresia. You can see here, this is the left atrium, the mitral valve, and this is the right atrium and the tricuspid valve here. And you can see how the tricuspid valve did not develop So this is tricuspid atresia, and this patient also has a hypoplastic right ventricle with a large VSD, and this is the left ventricle. So this is another anatomy with a single ventricle physiology. These patients now surviving to adulthood thanks to an operation called the Fontan procedure. It's a palliative operation, and you can see here, this is the Fontan conduit, and I'll show it to you here. The Fontan conduit connects the IVC and the SVC directly to the pulmonary arteries, bypassing the heart, and the single ventricle pumps to the aorta only, since we haven't just one pump, that pump pumps to the aorta and not to the pulmonary circulation. So the pulmonary blood flow is passive. These patients can survive into their 20s, 30s, 40s, 50s even, but not without complications. They have chronic hepatic congestion, they can develop cirrhosis, they may develop AVMs, arteriovenous malformation, they can develop collaterals, they can be cyanotic, they can have renal failure, recurrent admissions with ascites requiring paracentesis. So they can have protein-losing enteropathy. So many complications. So they need to be seen often at an ACHD center. So if you run into any of these patients, feel free to connect with us. We're always happy to collaborate with other teams, anesthesia team, pulmonary, surgical teams, to optimize the outcomes and to plan. So with that, I'm going to close because I'm running out of time. If you have questions, please stick around for our question and answers session, or connect with me via email or social media. And just remember that patients with ACHD need care for life. Thank you so much.
Thank you very much, Dr. Duarte, for this comprehensive overview, a primer in adult congenital heart disease. And let me tell you what I take from this primer is that if somebody has adult congenital heart disease, it is not always so simple, even for us who are trained in cardiology, and we need experts like you and your team who can take care of that and really help navigate. Not only from a diagnostic point of view, because MRI, echo, I think are crucial, and CT are crucial in this, but also the whole team, because if something is needed, you need the interventionalist, you need the surgeon, you need the anesthesiologist, the electrophysiologist. And to me, as chair of cardiology here, it is probably the most complex things, with all due respect to Dr. Goel. So great to have you.
Thank you, Dr. Zoghbi.
No, I'm glad you put also your information, because another thing that's important, I think we have to recognize this, is your first two slides were also very important, which is the growth of this population in the United States and probably beyond too. Increase in 25% or so of adult patients with adult congenital heart disease surviving and being among us to be taken care of. So, and again, these patients also have adult diseases, diabetes, coronary disease, other things as they survive adulthood. So they need to be taken care of with specialists in an adult population, adult hospitals or whatever facilities. So,
yeah.
Thank you.
They get pregnant. They want to play sports in college. They need adult surgeries, general surgeries like gallstone surgeries, and yes, GYN surgeries, and
very true.
Things like that. Yeah.
Well, thank you both for joining us. We have just few minutes for questions. Dr. Goel, you may be in an airport or somewhere. I don't know where you are now. But
I'm at the airport here in Atlanta, about to board a plane.
I know.
But, very happy to join. I enjoyed Dr. Duarte's talk. Every time I listen to it, I learn something new. This is fantastic. Thank you. Thank you for inviting me.
A question to you, Dr. Goel, is with all these catheter-based procedures for the mitral valve, is the selection still for patients who have high risk for surgery? Or is there a more expanded meaning view to intervene in such patients?
Yes, that's a great question. So, first of all, MitraClip or TEER is approved for primary MR in high or prohibitive risk patients. In functional MR patients, the surgical risk really doesn't play a significant role. These patients really have to be, optimally medically managed. And if they still have significant MR, then it's a class 2A indication now for the recent ACC/AHA guidelines. Now, in terms of the expansion of therapies, there are two trials actually, which are ongoing, looking at the role of transcatheter edge-to-edge repair for primary MR. The first trial is called the Repair MR trial, which is a intermediate risk trial. So meaning patients that are at intermediate risk for surgery and have good anatomy for both surgical and transcatheter mitral valve repair are being randomized to the MitraClip versus surgical repair. Concurrently, recently, there is a new trial that has been launched by the CTS-NET, which is called the Primary RCT. And it's an interesting trial. They are enrolling patients across all surgical risk strata, ranging from low risk, intermediate risk to high risk. And they are randomizing these patients to surgical valve repair. So it's a bit controversial. There's several debates that are ongoing as to, which trial should you enroll in. But I think the message is, the therapy is proven in the high-risk patients with good anatomy. It has been proven to be extremely safe. It has upwards of 90-95% chance of success. And, this therapy is expanding into the lower risk population, of course, currently in the trials. And we are going to learn a lot more in the next few years.
I think this is all very important from a patient's perspective, particularly if I think of, we know the benefits of surgery in primary MR, particularly in the younger individual, et cetera, et cetera. But I think the challenge has always been in our secondary MR, particularly the ischemic ones, or meaning that surgery has really not made a dent with an acute increase in mortality and morbidity, if you will, that conceivably is taken out by catheter-based procedure. And this is maybe part of the reason that we see an effect. That is really great in secondary MR. So I think for our audience, I think this is really very exciting, the catheter-based procedures for valvular heart disease. And whenever you have any questions, reach out to, the experts in this, you, Dr. Goel, Dr. Kleiman, Dr. Reardon, and the others. And the beauty is for both, have you here on, for adult congenital as well as structural heart. A team approach is great because you need all these experts to come up with a best decision for patient. So with that, I want to thank you both for joining us for your presentations. Dr. Reardon is in France now and participating in the celebration for 20 years of TAVR. And we will take a break. Here it's noontime, but you could be on any time zone. Just take a break and we'll be back in 15 minutes. Thanks again.
Thank you.
Thank you.
Okay, good afternoon here in Houston. Welcome back. I hope you've all had a great lunch. Quick, but hopefully it was great. We're going to start our afternoon session. The first sub-session is going to be called Ischemic Heart Disease, Evolving Therapies. So I'm going to start the session with my own talk. And again, I'm Dr. Alpesh R. I'm an interventional cardiologist and the director of coronary interventions here at Houston Methodist Hospital. So my talk is about stents, which is a backbone of interventional cardiology. It all started with coronary balloon angioplasty. This is the very first therapy we all started with, where we would go into an artery, open up the balloon, and deflate the balloon, and you basically have a better luminal gain in this particular vessel. And that's all we had for years and years, almost a decade. But there were problems, there were limitations. First and foremost, abrupt closure was a massive problem. Almost 4 to 8% of those patients, the artery would completely shut down right away, where almost 20% would require emergency bypass surgery. But even if they survived, eventually we would have to worry about restenosis, where 30 to 50% of those patients developed at least 50% restenosis, which led to 20 to 30% of revascularization rates. And those are the days our surgeons used to say, you guys don't do procedures, you do stunts in there. And this was happening because even in spite of good luminal gain after an angioplasty, or a POBA as we would call it, there was an immediate elastic recoil. And then eventually there was neo-intimal formation, which limited all these outcomes. In 1993 in USA, we came out with bare metal stents, which was revolutionary. It was made out of stainless steel, and it created a bigger luminal gain post-stent implantation, plus it reduced the elastic recoil of this vessel. However, as you can imagine, neo-intimal formation or scar tissue formation, creating restenosis, remained as a problem, but it was reduced to about 20 to 30%. But this necessitated the next generation of evolution of drug-eluting stents, where again the stent was deployed, but the drug elution prevented the fibroblast from activation and created very minimal amount of neo-intimal formation, which created this prevention of cellular response, leading to reduction of restenosis. And this was introduced in the US in year 2003. Effect of DES has been very interesting. If we chart this over time, and again I'm kind of stopping at the last decade, but basically ever since drug-eluting stents have been introduced, we have device failure rates or angiographic failure rates have substantially reduced. So has been there a reduction of emergency bypass surgery, restenosis has dramatically reduced, stent thrombosis has gone down, as well as very late stent thrombosis. So a lot of benefits of drug-eluting stents. So what are the indications as we stand today in a patient coming to the cath lab where a stenting is performed? Obviously, STEMI is a classic indication, but non-ST elevation MI, patient with unstable angina. Now, what to do with patient with stable angina, and I'll talk to you about this a little bit later in my talk, but again, medical therapy is recommended as first-line therapy. Angina equivalent, a lot of patients have dyspnea or arrhythmias, low ejection fraction, but also high-risk stress findings. In an asymptomatic patient or mildly symptomatic patients, objective evidence of moderate large area of viable myocardium or moderate to severe ischemia by non-invasive testing is an indication possibly of PCI revascularization. We also recommend a heart team approach involving interventional cardiologists and cardiac surgeons in patients with diabetes, multivessel CAD, low ejection fraction patients, severe left main patients, or high syntax score, which is just multi-vessel disease. Because there are complications which are associated with stenting, MI, death, and stroke, excess site bleeding complications, especially in the femoral side, which has reduced substantially ever since we have been getting into the radial access site. Non-access site bleeding still gets reported, whether it's GI, GU, pericardial tamponades, or even intracranial hemorrhages. Again, patient selection becomes very vital to that. Contrast-induced nephropathy is reported, especially in patients with pre-existing chronic kidney disease or diabetics or women. Allergic reactions, sometimes the knowledge of it can be very important, and those patients can be pre-treated with prednisone or steroids. Radiation exposure, if it goes more than 5 grays, it gets very concerning. And obviously, stent-related procedural complications such as perforation and also stent thrombosis, where there's a clot formed inside this brand new stent. So let's get to this current stent design. I think it's very vital for you all to understand what exactly is a stent. You all have patients and friends and family who've gone through stents. So how do we create a drug-eluting stent? If you're a biomedical engineer, you first and foremost are going to require a stent metal, a design to that. Then you're going to add some drug to that. And to combine these two, you require to coat the stent with a polymer. It's like putting a primer before you can put the paint. Drug-eluting stents have gone through their own itinerations. The first generation were called Cypher, Taxus, Endeavor, which is on the left of this slide. And then on the right are the second generation, or sometimes you can call it third generation, but they are Resolute, Xience, and Synergy. These are commercially available stents in the USA. On the bottom, I've shown you kind of a columns of what the evolution is all about. So there are 5 fundamental things where things have changed. Stent design, the metal has gone away from stainless steel and we have moved into cobalt-based metal alloys because we can maintain radial strength, and this allows us to make thinner struts. The strut thickness, as you can see, has significantly reduced from anywhere from 140 to 100 to almost standard in the 80 microns. We even have below 70 micron thin stent struts. Polymer thickness has gone from 10 millimeters to 15 millimeters to 4 to 8 millimeters at the max. Drug, we have moved away from paclitaxel, especially in the coronary stent field, and moved towards Limus group of drugs, whether it's everolimus or zotyrolimus. And the elution time frame, we struggle with this for us to find too long, too short, but the Goldilocks zone has reached out to be anywhere from 90 to 120 days, and that's where most of the drug elution is happening. We also have come up with biodegradable polymer stents because the concern is, well, you have this polymer which is nothing but a plastic layer on top of the stent to give the drug, but after the drug has been delivered, why do we still need the polymer? Can it avulse? Can it crack? And can it be a source of constant inflammation and possible thrombosis? So these kind of stents have been created where there is only abluminal polymer coating, and also those polymer tends to be derived from PLGA, which is a bioabsorbable material, so it is completely gone by the time drug elution is performed. This also allows for thinner stent struts and better results long term. We also have dabbed and continue to work on our research on bioabsorbable stents. They are called absorbs. They are completely bioabsorbable. So you put in a stent in a 50-year-old person, by the time he's 52, there is no more skeleton of the stent left. It is made out of PLLA backbone, which is polylactic acid. It is semi-crystalline. There is circumferential sinusoidal rings connected by linear links. The strut thickness was a problem. It is 150 microns. The newer generation will be thinner. And there are platinum markers at the end of each rings to visualize those stents, because you normally cannot see that on a regular cath images. The drug is everolimus on a PDLLA matrix coating, 1:1, which is 7 microns in thickness. It is conformal, and there is controlled drug release similar to Xience, cobalt chromium EES, or everolimus eluting stent. The phases of absorb is very fascinating. So the drug elutes in the first 3 months, because we have learned that you don't need the drug beyond that, because all the scar tissue formation has been already inhibited. But the mechanical support continues to diminish, and it pretty much goes away by the end of 12 months. But the complete mass loss, complete resorption takes up to about 2 years or 24 months. So I've got a question for you all. Think about this. The patient undergoes a stress testing and is found to have moderate ischemia in the RCA territory. Because he develops moderate symptoms, class 2 or 3, on medical therapy, a coronary angiogram is performed, and the angiogram shows a 50 to 60% stenosis in the mid-RCA. Well, what would be the best next step? Do nothing? Maybe the stress test was probably false positive, because you rely on what you see on the angiogram and it does not look very critical. Consider stenting the lesion, because a 50% stenosis is expected to be ischemia causing. Consider performing FFR assessment, or consider performing intravascular ultrasound assessment. This is the new revolution. Over the last 5 years, last 10 years, this has become very popular in how we treat our patients. Because one thing is to see the lesion, the second is to understand the physiologic impact of the lesion on the coronary artery and the ischemia it is responsible for. So we have this wire which we drop down into the coronary vessel, and we are able to measure FFR. To measure FFR, we have to give intracoronary or intravenous adenosine, which causes maximum hyperemia. And FFR is derived as distal coronary pressure divided by proximal coronary pressure, which is what the wire information is given to us. To allow us to do similar measurements without giving adenosine, there has been mathematical computational models which have derived IFR, which is very user-friendly, and that allows us to decide if the lesion, whether it is 50 or 70%, whether it is hemodynamically significant, and if it is ischemia causing, maybe we should consider revascularizing it. This is a trial. This is the data from FAME-2 trial, which is a fraction flow reserve FFR-guided PCI versus medical therapy in stable CAD patients. So patients with FFR less than 0.80 were randomized to medical therapy versus PCI and medical therapy, and patients with FFR more than 0.8 were followed in registry. The primary endpoint was death, MI, or urgent revascularization, and after enrolling 1,220 patients, further recruitment was stopped due to significant difference between the treatment groups. 4.3% in the PCI group and 12.7% in the medical therapy group, with a hazard ratio with PCI of 0.32 and 95% confidence interval 0.19 to 0.53 with a p-value of less than 0.001, which established FFR-guided PCI as a mainstay. Intravascular imaging, this is a grayscale on the left, and OCT or optical coherence tomography is very good for definition of endothelium, stent, as well as restenosis and features such as calcium buildup. Atherectomy devices, these are rotational atherectomy, orbital atherectomy, and they are usually done in preparation of delivery of the stent. So they are adjunctive procedures when there is severe amount of calcification in those vessels. There are other devices used for thrombus aspiration, especially in patients who have primary PCI. Distal embolic protection has been used in patients who have saphenous vein graft, so that you can create complete prevent any no flow downstream in those vein graft interventions. CTO is a very specialized category where we have developed wires which will go through these occluded parts of the coronary vessel, which is not always easy. So we have also started doing antegrade dissection re-entry, where the crossing is done in the subintimal space. We advance across the occlusion and re-enter into the distal true lumen. There are also retrograde techniques where we use septal collaterals, whether it's RCA to LAD or LAD to RCA, to perform this kind of treatments. Patient continues to do well after the stenting at 6 months. He remains compliant with his medications. What are the recommendations on how long the DAP should be? 1 month, 3 months, 6 months, 12 months. So this is a algorithm for the duration of P2Y12 inhibitor therapy in patients treated with PCI. Again, this is for your reference, but I'll get the bottom line is if you had a patient who had a stent performed during ACS, it is recommended at least for 12 months. If it is done with stable ischemic heart disease, somebody has an abnormal stress test, we recommend it for 6 months if it is drug-eluting stent, and 1 month if it's bare metal stent. But to be honest, friends, we hardly use bare metal stents. There are appropriateness criteria, which are key variables, as you can imagine: clinical presentations, Canadian classification of angina, high risk imaging or coexisting conditions, medical therapy, whether it's none to max, and obviously significance of multivessel coronary artery disease. As you go up more and more on it, this revascularization becomes more appropriate. Ischemia trial was this major trial which was done to assess patients who are not symptomatic or mildly symptomatic but have moderate to severe amount of ischemia on their stress test. A CTA was performed to rule out all high-risk anatomy, and then they were randomized to conservative medical therapy or invasive therapy, which included bypass surgery or coronary stenting. The ischemia primary outcome up to 5 years actually showed that there was no major difference in outcomes, but there was clearly a trend towards higher periprocedural events up front in invasive therapy, but there was a late catch-up in a medical therapy group. The quality of life outcome, which is very interesting and is shown here by the Seattle Angina Questionnaire, shows that there is a continuing benefit of revascularization in those patients. Thank you very much. I hope you have enjoyed this presentation on coronary stents. Now, to continue to our next presentation, this will be done by Dr. Ramchandani. Dr. Ramchandani is one of our cardiac surgeons. He's the chief section of cardiac surgery at Houston Methodist Hospital System. and he's part of the Houston Methodist Cardiovascular Surgery Associates. He's an expert, world-renowned expert at coronary artery bypass surgery, especially off-pump surgery, minimally invasive surgery, and we are excited to share with you the presentation by Dr. Ramchandani.
Good morning. I'm going to speak to you about coronary artery bypass for stable coronary artery disease. So the first coronary bypass operation that was done successfully was done here in 1964 by Dr. DeBakey and his colleagues. Prior to this, there had been some developments which made it possible, such as the heart-lung machine that was developed in the early 1950s by James Gibbon with a grant from IBM, and the serendipitous discovery of selective coronary angiography by Mason Sones in 1962 at the Cleveland Clinic. Cardioplegia, which allowed one to safely stop the heart to perform complex surgery on the coronaries or inside the heart, was developed in the early 1970s by Brainbridge and Brettschneider in London and Germany, respectively. And in the 90s and 2000s, we saw the development of off-pump coronary bypass surgery and minimally invasive techniques, such as sternal sparing methods for doing coronary bypass surgery. Now, the evidence basis for coronary bypass surgery really rests in three large trials that were performed in the 70s and the 80s. And the conclusions that they arrived at are as true today as they were then. They compared CABG to medical therapy. Interestingly, less than 10% of the patients received a LIMA graft, which is not the case today, and we know that the LIMA graft contributes greatly to survival, and medical therapy was not what it is today. In spite of this, these three trials showed that CABG was superior to medical therapy in selected subgroups. And broadly speaking, these were patients with left main disease or extensive coronary disease, and in two of the trials, patients with reduced LV function. This evidence basis for CABG was updated by Yusuf in a meta-analysis in Lancet in 1994, where he looked at 7 randomized controlled trials of CABG versus medical therapy at almost 3,000 patients followed for 10 years, and showed that CABG improved survival and symptoms, and the benefits were seen most in patients with triple vessel disease, left main stenosis, impaired left ventricular function, and severe symptoms. Now, the major morbidity of CABG lies in stroke, which is multifactorial. The heart-lung machine, or CPB, was a major contributing factor, but this is much less the case nowadays because of great improvements in circuit design. The aorta, which is frequently diseased in these patients, was a source for embolic stroke and continues to be, and there are ways that have evolved to mitigate this very successfully. And of course, pre-existing cerebrovascular disease that the patient frequently has is also a contributing factor. Myocardial infarction is another potential complication, as well as lung and kidney complications. And you can calculate the specific risk of any of these complications or death for any individual patients in your office in about 5 minutes using the online STS risk calculator. It draws from information on over 1.5 million patients that are stored in the STS database. And overall, the mortality is about 2% for all comers. A low risk group would be 0.5, 4% or greater mortality risk would be a high risk group. There are various types of conduits that are used also for coronary bypass surgery. Both internal mammary arteries are frequently used now, the saphenous vein graft. Radial arteries are also used when appropriate. The procedure can be done on pump, can be done off pump. Minimally invasive sternal sparing techniques have evolved, and we have a robust program of that here at this institution. And increasingly, hybrid approaches are being explored for patients with multi-vessel disease, where a LIMA to the LAD is placed using a sternal sparing technique, and then PCI is used in a staged fashion for a non-LAD lesion. Now, with regard to off-pump coronary bypass surgery, there is a difference as the risk of the patient or the predicted risk of mortality of the patient gets higher. So in this graph here, where you can see an increasing predicted risk of mortality represented by this diagonal line, the solid line shows the actual mortality of patients who have undergone on-pump coronary bypass surgery, and the broken line, those for patients who have undergone off-pump coronary bypass surgery. And you can see that in the lower risk patients, up to about 4% risk, up to this point here, there isn't a significant difference between on-pump and off-pump coronary bypass surgery. And this represents the majority of patients that we operate on. But as the predicted mortality of the patient gets higher and higher, you can see that as long as the surgeon is competent in doing off-pump coronary bypass surgery, the actual mortality of patients undergoing off-pump surgery more or less flattens out, whereas it continues to increase in patients who've got who have on-pump coronary bypass surgery. This was drawn from data from the SDS database and published several years ago. PCI and coronary artery disease. PCI claims equivalence to coronary bypass surgery and therefore claims parallel benefit over medical therapy. There were early signs that this might not be the case. These data from the New York State Registry that were published in 2005 showed that at 3 years, one was already seeing a very significant difference in survival, with improved survival in patients who had coronary artery bypass graft if they had triple vessel disease versus PCI. Now, the COURAGE trial tested PCI versus medical treatment, and this was published in 2007. 2,500 patients were randomized to PCI with optimal medical therapy versus optimal medical therapy alone. And this showed that there was no difference in death or MI up to 7 years follow-up. And PCI, excuse me, was better at relieving angina, but not myocardial infarction or death. The FREEDOM trial that was published in 2012 looked at CABG versus PCI in diabetic patients, a very specific group of patients. They had a great variety of syntax scores, and it was found that all-cause death, myocardial infarction, or revascularization was lower in CABG versus PCI in this group of diabetic patients. It was noted, however, that the stroke rate was higher in CABG patients at 5.2% versus 2.4% in PCI patients. Now, along came fractional flow reserve, and this was a way to determine the functional significance of a coronary lesion. So angiography gives you a sense of the anatomy of a lesion, but it can frequently be difficult to tell in an intermediate lesion whether or not it's functionally significant or not. And without going into the details of how it's done, fractional flow reserve, or FFR, and its later evolution or instantaneous flow reserve are used now frequently to determine the functional significance of a lesion. And it was theorized that if you only treated lesions that were functionally significant with PCI, you might get better outcomes. The FAME2 trial was designed to test this, where FFR-guided PCI was tested versus medical treatment. Unlike the COURAGE trial, where PCI without FFR was tested against medical therapy. In this trial, there was a dramatic difference between the two groups, and the trial, in fact, had to be stopped early because there was a very marked difference of 4.3% versus 12.7% in the composite endpoint of death, myocardial infarction, or urgent revascularization at 2 years. P-value 0.001, so highly significant at 2 years. Interestingly, the 5-year results showed that there was no significant difference in rate of death or myocardial infarction between the two groups. However, if you look at the medical treatment group, 21% of them needed to have some kind of revascularization, presumably because they developed symptoms and needed to have something done about it. So there again, the implication is that PCI was the driving force behind this. Very important trial that was done, published first in 2013, 5-year follow-up with 10-year follow-up, more or less confirming this, looked at, which was a randomized controlled trial of drug-eluting stents versus CABG at 85 centers in Europe and the US, which looked at all comers to mimic the real world. Astonishingly, 71% of them were enrolled, and 58% of these were randomized, with the remainder being placed in a registry. All of these were screened by a heart team, a concept that was created by this trial and which continues to endure today and has been incorporated as a central tenet in decision-making for patients with coronary artery disease. They also developed the syntax score, which was a way to assess the complexity of coronary artery disease. And many people feel that this was a major contribution of this trial because it allows you to dissect out with greater granularity patients who might benefit from PCI versus CABG versus medical treatment. So broadly speaking, a low syntax score patients would be somebody who had less complex disease, and somebody with multiple lesions in many different vessels with diffuse disease would have a high syntax score. And the syntax trial showed that in all comers, the survival advantage was much higher at 5 years in patients who underwent CABG versus PCI. And when you broke this down into the high complexity patients, the advantage of CABG was even greater, but interestingly diminished considerably, with no significance seen at 5 years in patients with very low syntax scores, providing a clue as to which patients might benefit just as well from PCI as they would from CABG. Now, the FAME-3 trial was designed to test FFR-guided PCI versus CABG. FAME-2, you'll remember, showed FFR-guided PCI versus optimal medical therapy. And broadly speaking, what they showed at 1 year was that there was no significance in the composite endpoint of PCI versus CABG, and it was not significant. We know, however, from previous trials that early results often show similarity between PCI and CABG, and we'll be interested to see what continued follow-up of these patients show. Now, why is CABG better than PCI? Well, PCI treats an isolated lesion in the proximal vessel. The complexity of the lesion affects the outcome. CABG bypasses the proximal 2/3 of the vessel where the current lesion and future threatening lesions occur, lesions that may not be significant now, but may become significant in the future. So the complexity of the lesion is irrelevant. This advantage of CABG will persist even if stent restenosis is 0. Now, the left internal memory artery was first recognized as being a remarkable graft and having a significant impact on survival by this seminal paper by Dr. Luke from the Cleveland Clinic in 1986, where he showed that there was a marked improvement in survival with patients who had a lima versus those who had only vein grafts when they had their CABG done. A follow-up from the Cleveland Clinic in 2009 showed that in patients who had previous coronary bypass surgery and had a lima graft who presented with recurrent symptoms, another intervention, PCI or redo coronary bypass surgery, may help symptoms, but there was no survival benefit for intervention if the lima is patent. In other words, the lima will keep you alive even if you develop symptoms because of progression of disease in other vessels or other grafts. We don't know why it's protected from atherosclerosis. There's a greater than 95% long-term patency of the Lima to LAD graft. It is now an important metric in the STS rating of institution and has a 10 to 15% weight in the star rating of institution. And for these reasons is used in more than 97% of coronary artery bypass grafts performed worldwide. As opposed to that, vein graft failure rates are 15 to 25% at 1 year, and the patency rate of the radial artery is somewhere between these two, with about an 80% long-term long-term patency of radial artery grafts. By contrast, PCI outcomes have continued to improve, and this paper that was published in JACC in 2020 shows that that there's been a steady improvement in the major adverse cardiovascular events at 1 year follow-up, with bare metal stents showing 17.9% and the current generation of drug-eluting stents showing a 5.1% rate of issues, whether it's restenosis or any other problem at 1 year. So significantly better than vein grafts. Now, let's jump a little bit now to the recommendations that are introduced in the guidelines for CABG versus PCI. And these come from the 2014 guidelines by the European Society of Cardiology and the European Association of Cardiothoracic Surgeons. And you'll see that, broadly speaking, for patients with low complexity disease, there is a class 1 recommendation for patients to have CABG or PCI. But as you get into patients with higher syntax scores and more complex disease, you'll see that the recommendation for CABG remains at class 1, whereas for PCI, it's a 2A. In some cases, it's not even recommended, with this exception, with 3-vessel disease with a low syntax score. Remember that the syntax trial showed that at 5 years, there wasn't much difference. With this singular recommendation, providing a class 1 recommendation for PCI. There are various factors which favor PCI, and I won't go into all of these patient characteristics and anatomical and technical characteristics, both for PCI and CAB. And these are factors that are looked at by the heart team in deciding the appropriate treatment strategy for patients. The latest guidelines for the management of coronary artery disease that were introduced by the ACC and the American Heart Association and the Society for, SCAI, were updated from their 2011 and 2015 guidelines. These have not been endorsed by the SDS and AATS, and this has led to a little bit of a spat between the societies because the surgical societies feel that CABG for triple vessel disease to improve survival was unjustly downgraded from level 1 to level 2B, when the evidence strongly indicates that it should remain a level 1 indication. And for reduced LV function has been reduced from level 1 to level 2A. This was a fact that was established back in the 80s as being a factor that favored CABG for survival. The use of the radial artery was elevated by the cardiology societies from 2A to 1, and we don't agree with that, as we feel that the radial artery should be used in a more nuanced fashion than was indicated by these guidelines. And the ischemia trial, which we won't go into, but which was published recently, was used as a partial justification for this, but there are multiple reasons why we feel that this trial was a flawed basis for changing the recommendations. So the management of coronary artery disease today is complicated. It's like cancer. It's about disease management. There's a convergence of best medical therapy, PCI, and coronary bypass surgery, and often all three may be used in any particular patient. The syntax score is a major contribution to this, and hybrid procedures have a role which is as yet undefined. A heart team approach is absolutely essential for optimum care, and shared decision-making with the patient has become more and more important, where you have to take into consideration what the patient wants. Your job is to explain to them what the evidence indicates, and then share that decision-making with the patient. Thank you all.
Thank you very much, Dr. Ramchandani, for that fantastic talk. Great points that you have made and juxtapose CABG versus PCI. The next talk, we're going to invite Dr. Neil Kleiman. Dr. Neil Kleiman is the Davis Centennial Chair in Cardiology here at Houston Methodist Hospital. He's the director of the Cardiac Cath Lab. He's the director of our program director of our fellowship, Interventional Cardiology Fellowship Program, my own mentor, and no man better in this world who knows more about antiplatelet therapy. So I would like to invite Dr. Kleiman to talk about antiplatelet therapy, which one and for how long. Dr. Kleiman.
Hi, my name is Neil Kleiman. I'm reputed to know something about antiplatelet therapy, and I'm going to talk to you for the next few minutes about which meds to choose and for how long. So brace yourselves. So here are my disclosure. As of 2022, I have no overt conflicts of interest. And although this is a very important question, I don't know the answer, nor does anyone else. We're all searching here. The literature in most spheres is fairly confusing. And as we talk about this, it's important to remember that we haven't yet found a medication that prevents clotting, at least adverse clotting, and doesn't cause bleeding. That's our holy grail. By the way, that's not me in the picture trying to grasp it. So let's start with aspirin. Aspirin is about 120 years old, and we still aren't sure about the optimal dose, although I think we're getting pretty close. The mechanism of action was worked out by Roth and Majerus in 1973. And basically what occurs is, as acetylsalicylic acid is dissociated, it leads to permanent acetylation of serine moiety 529 on prostaglandin GH synthase 1, which is more popularly known as cyclooxygenase, and prevents thromboxane A2 formation, thromboxane A2 being a potent vasoconstrictor and procoagulant. Its effect is saturable at low doses, and in the 1980s, several large studies cemented its clinical role for use in unstable angina. So here are the clinical data and the doses that were studied. Acute MI, we know from the ISIS-1 study, 162 milligrams per day prevented 40 major vascular events in 1,000 patients. For acute ischemic stroke, 160 to 300 milligrams daily prevented 9 deaths and 7 poor neurologic recoveries. For secondary prevention, the number gets lower, 10 to 15 events per 1,000 high-risk patients treated. And for primary event prevention, the drug doesn't work. The number needed to treat is less than the number needed to harm. So Carlo Petrono put this nice graph together, comparing the annual risk of a serious vascular event in a variety of trials with the number of vascular events prevented and the number of major bleeding episodes that occurred. And the take-home message here is that if a patient is low risk, then the risk of bleeding is greater than the likelihood of preventing an ischemic event. Whereas if the number needed to treat is, if the risk is higher, then the number needed to treat falls dramatically from somewhere between 500 and 1,000 to fewer than 100. The number needed to harm remains about the same. So little difference observed in the risk, tremendous difference in the need for benefit. The bottom line is this drug isn't helpful in low-risk patients. Now, we don't really know about newer modalities of interrogation, such as the calcium score. But this is primary prevention. This is secondary prevention. And just this last year, the U.S. Preventive Services Task Force released a draft recommendation that said pretty clearly people aged 40 to 59 who are at higher risk for cardiovascular disease should decide with their clinician whether to take aspirin. So this means higher risk. People aged 60 or older should not start taking aspirin for heart disease and stroke prevention. So for primary prevention, aspirin's out. What about dosing? Well, we've never been really sure. This is a very large study, the adaptable trial done as a so-called pragmatic trial with internet interrogation in 14,000 patients with established atherosclerotic heart disease. Basically, patients were randomized to either aspirin 81 or 325 milligrams daily with a superiority design. And this was a good mix of patients with known heart disease, the sort you and I would see today. Note that during follow-up, patients taking the higher dose were about 3.5 times more likely to switch the dose when all is said and done. I don't know if the screen magnification is big enough to show you the difference between these two curves, but basically there isn't one. No difference between 81 and 325 milligrams, even out at 36 months from randomization, and a trivial difference in the risk of bleeding. That said, same effect, speaks to lower dose, tie goes to the runner. So there's always more to come on this. Okay, let's switch gears. Phenylpyridines, clopidogrel, and then two newer drugs, prasugrel and ticagrelor. Clopidogrel and prasugrel are phenylpyridines. Ticagrelor is not a phenylpyridine, it's a CPTP. These are all antagonists of the platelet P2Y12 receptor. If you're not familiar with this, remember P2Y12. Clopidogrel is a prodrug, oxidized in 2 stages by hepatic cytochromes to an active metabolite. Activation is bottlenecked in the liver and subject to interference from other CYP active drugs. You cannot overdose someone with clopidogrel because they won't be able to activate most of it. Dose activity, 75 milligrams, takes 24 hours to peak, 300 about 6 hours, 600 about 2 hours. That's why when we do PCI, we dose everyone with 600 milligrams as a loading dose. The absorption is questionable in acute MI and is probably affected by narcotics. They slow GI motility, they slow absorption. Prasugrel and ticagrelor are third-generation P2Y12 antagonists. They're more potent than clopidogrel with less biologic variability. In the 2 pivotal trials, they were more effective than clopidogrel but caused more bleeding. So far, these 2 drugs are indicated only during and after ACS. Prasugrel only following PCI for ACS. Ticagrelor for all ACS can be started upstream, although most data suggest that that's not necessary. But for all ACS, ticagrelor is indicated, prasugrel only following PCI. They are not indicated for stable coronary artery disease. The evidence for their efficacy goes way back to about the year 2000 when these 5 trials were put together, and actually these trials were done in the late 90s. This is the beginning of dual antiplatelet therapy, which henceforth we will refer to as DAPT. And in fact, that's what drove the development of stents. No ticagrelor, no clopidogrel, no P2Y12 antagonists, no stents. Back in the early days, we put stents in only 10% of PCIs. Now we're up in the very high 90s for the last 20 years. And very early on, it appeared that premature discontinuation of antiplatelet therapy was a very potent risk factor for stent thrombosis. Premature, meaning stopped for cause before the indicated, that is in the instructions for use brochure that came with the individual stent. This was the strongest of the risk factors for stent thrombosis. So we got into debates about the necessary duration of DAPT. And that always seemed to be a silly question because everyone knew the answer. Problem is that no one could agree on what it was. This was published in the heart.org 2 years after the large DAPT trial. We're still debating. And every time I give this talk, I get to update this to 3, then 5, now 6 years later. We are still debating. There are now approximately 25 randomized clinical trials and probably now well over 200 meta-analyses of short versus long-term DAPT. Anytime you see this number of trials and this number of meta-analyses, you know that nobody knows what the hell's going on. They aren't concordant. In fact, they aren't even close. And truthfully, I don't know what the precise numbers is. All of us in the field have lost count. These are the current guidelines from the ACC/AHA, basically that tell you in an elective procedure with a bare metal stent, you need 1 month of DAPT. An elective procedure with a drug-eluting stent, you need probably 6 months of DAPT. In patients at high bleeding risk or with significant overt bleeding, you can and should shorten that. In patients with an acute coronary syndrome, the guidelines call for at least 12 months of dual antiplatelet therapy. The European Society of Cardiology guidelines are almost the same. Now, it's always said patients with high bleeding but low thrombotic risks and patients with low thrombotic risks but high bleeding risks should be treated differently. But the problem is there aren't very many such patients who've got one risk for bleeding and a different risk for thrombosis. High risk is high risk. Most patients at high bleeding risk are also at high thrombotic risk and vice versa. So when we pontificate, turn the page, turn your speaker off, surf the net instead. There are very few patients at low risk for one event, but high risk for another, and vice versa. So here's where the fun begins. We've been wedded to dual antiplatelet therapy, or DAPT, for a long time, and our 120th anniversary with aspirin was this year. And let me give you some advice. As a married guy, some anniversaries you can forget. I recommend that you not forget your 120th anniversary. And aspirin has been in our cardiology blood, both literally and figuratively, since the early 1970s. But now we're entering a new era. And I like this cartoon. In the word scent, is the letter S or is it the letter C that's silent? So in the abbreviation SAPT, what does S refer to? Which is the single medication. So as background, there's been a lot of work in definition of high-risk bleeding patients. I'll show you this slide. You don't need to remember it, but you ought to be able to look it up. Very simply, need for oral anticoagulant, non-access site bleeding requiring medical attention within the last year, et cetera, patients over 75, systemic illness, pre-existing anemia, recent bleeding, high-risk malignancy, recent stroke or TIA, or a precise DAPT score exceeding 25. And in the Master DAPT trial, which was published recently, nearly 4,500 high-risk bleeding patients who underwent implantation here of a biodegradable polymer stent 30 to 44 days previously. We don't have this particular stent in the US, but we do have 2 other biodegradable polymer that are frequently used. Randomized open label to immediate discontinuation of DAPT. Among the SAPT patients, 54% received clopidogrel only rather than aspirin only, versus continued DAPT for at least 5 more months. About half of these patients had acute coronary syndromes. Follow-up in the trial was 1 year. This was designed as a non-inferiority trial, and again, you could magnify this slide all you want. The event rates were no different, and non-inferiority was achieved. So again, this is major adverse cardiac. Actually, this is net adverse cardiac clinical events. So death, stroke, myocardial infarction, or major bleeding. Major adverse cardiac or cerebral events, no difference. However, in this high-risk bleeding population, major or clinically relevant non-major bleeding, so major or clinically relevant non-major bleeding, lower with shorter DAPT duration. So this is one of several trials that I'll show you in a second that indicate that in high bleeding risk patients, you can and probably should get away with shorter duration DAPT. On the other hand, the Stop DAPT ACS trial, published earlier this year, was a trial in all comers, not just high bleeding risk, 1 to 2, investigators' discretion versus 12-month randomized comparison of DAPT, aspirin and clopidogrel, or low-dose prasugrel in 4,169 patients treated with cobalt chromium DES. The primary endpoint occurred in 3.2% of short duration and 2.8% of long duration DAPT, and did not meet a non-inferiority requirement. Major bleeding was lower, 0.54 versus 1.17, with a hazard ratio of 0.6. But MI, so major bleeding about 50% lower, but MI about 50% higher with short duration versus standard duration DAPT. The implication is that in all-comer populations with ACS, you really shouldn't stop DAPT prematurely. You should go a full 12 months unless there's a good reason. So probably in high-risk patients, shorter duration. In high bleeding risk patients, shorter duration. In patients who aren't at high bleeding risk, full 12 months if ACS is present. And in fact, there have been a large number of short duration trials, largely in high-risk bleeding patients, most notable the Global Leaders trial with a fairly complex design. The Twilight trial, which has done multiple sub-analyses and has been through multiple interrogations, 3 months of DAPT, then ticagrelor monotherapy. The Tycho trial, 3-month DAPT, then ticagrelor monotherapy versus ticagrelor dual therapy, and recently the ASCET trial, prasugrel alone with no aspirin versus DAPT for 1 month. The bottom line here is that if you're switching to DAPT, things look very acceptable if you use a P2Y12 antagonist, clopidogrel, prasugrel, or ticagrelor, rather than aspirin, once you've completed a course of DAPT. In high-risk bleeding patients, the course probably should be short rather than long. In patients who have stable coronary artery disease, you probably should use a short duration of DAPT. In patients with ACS, I think the standard is likely still 12 months of DAPT. Finally, there's the atrial fibrillation issue. If a patient has atrial fib, there just isn't any getting around anticoagulation. We know that from a variety of trials. You've got to have an oral anticoagulant on board, no way around it. And reducing the dose of the oral anticoagulant doesn't seem to provide any stroke protection, even if bleed risk is lower. And we know that from studies of warfarin. We know that from plasma level secondary analyses with direct oral anticoagulants. So if you're going to treat atrial fibrillation, go ahead and treat it. This is what I call the 7% solution, because in DAPT studies, about 7% of patients have had an indication for oral anticoagulant. So in multiple studies, it turns out that if you're going to use an oral anticoagulant, you are best off using a full dose oral anticoagulant, and that was tested in most notably in the REDUAL trial using full dose dabigatran plus a P2Y12 antagonist, and the Augustus trial using full dose apixaban and a P2Y12 antagonist. Both of them beat vitamin K dependent antagonists, and both beat triple therapy. So there isn't an indication for long-term triple therapy in some stent patients. A 2 to 4 week course of triple therapy may be indicated, and I say may, but by and large, in patients who require an oral anticoagulant, you're looking at the oral anticoagulant at full dose plus a P2Y12 antagonist. No long-term aspirin in these patients. But again, one could argue that all these trials are somewhat underpowered. There is no adequately powered trial, so be a little cautious. But by and large, they're all concordant in recommending a new or direct oral anticoagulant with a P2Y12 antagonist and ditching the aspirin. So the take-home points haven't changed since last year. I apologize for not updating this slide. Currently, aspirin is indicated in secondary but not primary prevention. DAPT is indicated for intracoronary stenting, although we still haven't completely agreed for how long, probably in patients with acute coronary syndromes. Unless they're high bleeding risk, you ought to go for a full year. Aspirin will probably end up being used for short term after stenting. If an oral anticoagulant is required, aspirin is useful only for the very short term. And the third generation P2Y12 and oral antagonists are useful only for acute coronary syndromes. Thank you.
Thank you very much, Dr. Kleiman. That was one of the most thorough presentations one can ever get on a virtual symposium. This is something which can take almost a day-long symposium. So please keep these slides in your slide deck and review this every time you have a question regarding antiplatelets. Again, we continue to encourage questions. We already have several questions, but just to remind our audience, one way is to text DeBakey to 37607 and then text your question. Other is pollev.com and then enter DeBakey and then submit your question. I promise to try to get to each and every one of them, and even if we can't get it right now, we will ask our specialists to follow those up down the road. So to start off, I see we have Dr. Kleiman join us. Hello.
Hi, guys.
Yeah,
So first of all, I apologize for not fixing the date on my last slide. I updated everything except the title, so I know it's 2022. I'm not that disoriented.
No, I think.
Forgive me.
I think, as I said, it was such a beautiful talk. So much to learn from in this topic. I have a few questions, so let's get to them. And first and foremost, if you can just scroll down a little bit, what are your thoughts on supplemental oxygen administration for patients with no respiratory distress and good oxygen saturations with good pulse ox waveforms in emergent patients suffering acute MI before PCI? Are there any negative effects pertaining to reperfusion injury due to free radicals? What a fantastic question this is. This is almost like revisiting good old methods such as aspirin in primary prevention and oxygen in STEMI. And I'll give you my quick answer, and then I'll have Dr. Kleiman add to that. But about 4 or 5 years ago, there was a New England Journal of Medicine article which actually reviewed this very question. It was a Swedish registry, if I remember, or some European registry, which concluded that there was no beneficial effect of supplemental oxygen on non-MACC patients coming in with a acute MI. Beyond that, I think there were some randomized control trial. One of them, if I'm not wrong, is called AVOID, smaller trial, but they actually randomized patients who had not already received oxygen on arrival. And again, they did not show any benefit of giving supplemental oxygen in patients whose saturations were more than 90%, but possible harm, whether it is larger MI or larger troponin release. But we continue to do this, Neil. What do you think about free radical injury?
I think that's probably something that we're more likely to think about than actually occurs. And I think largely we put oxygen on patients to treat the physician or other provider. The one thing I would say, though, is if we're going to the cath lab, we are likely looking at sedation. So we're likely looking at treating patients with respiratory depressants. So if we're going to give patients morphine, fentanyl, and benzodiazepine, we're running a risk of making them hypoxic iatrogenically. So for that reason, I don't have an objection to starting patients on oxygen if they've got a procedure coming up. I do think, though, if a patient is normoxemic and they're not going to the cath lab, they're going to an intermediate care unit or to a CCU, and they're just going to sit there and check their email or read their computer or answer a lot of questions that we're going to pose to them, then I think there's not much point putting oxygen on them.
Thank you. I have a question for you, Dr. Kleiman, and this is there any antithrombotic therapy combination to prefer in STEMI or non-STEMI occurring shortly after a non-cardiac surgery? So I guess, let's say a patient goes through a total hip replacement in the morning, you get called out at 2 a.m., patient is having a STEMI. What do you recommend on antithrombotic therapy there?
Yeah, then I think it's so assuming that, I guess two situations, and actually they're not too different. Patient who's going to the cath lab, presumably for an intervention, and again, as interventionalists, recent surgery makes us think twice about whether we should do it or not, because then we're going to be more aggressive about anticoagulation if we do an intervention. The downside is certainly higher too. And so the balance between risk and benefit becomes a little bit altered. I think we're then talking about dual antiplatelet therapy and almost zero anticoagulant. Okay. And truthfully, if we're not looking at intervention, I would probably give a single dose of dual antiplatelet therapy and then stick to the P2Y12 antagonist only after that.
Do you have any particular choice amongst the P2Y12 antagonist?
Well, most of the data there would tell us if we're doing a PCI, it's going to be ticagrelor, whereas if we're not, it's dealer's choice.
Okay. That actually does lead to the next question. What are your thoughts about prasugrel or ticagrelor for ACS getting PCIs? Any personal preference? And the questioner asks and relates to the ISAR REACT 5 trial showing superiority of prasugrel and the fact that prasugrel is once daily and cheaper for patients. Very valid and interesting question.
And I think, again, prasugrel makes good sense in that setting, assuming that you're going to go ahead and do a PCI. On the other hand, we try not to complicate things a lot. And if we've got, for example, our emergency room in the habit of giving patients ticagrelor up front, I'm perfectly okay with that. So yes, ISAR REACT 5 speaks favorably for prasugrel, but remember that is also a trial that sits in isolation, and it's not a terribly large event-rich trial.
Okay. Maybe we can squeeze in one more question. For non-urgent revascularization, do you think that using a short, I guess they meant short of a trial period of DAP with oral anticoagulation, if indicated, can be useful to better assess the bleeding risk of a patient before stenting and to permit their stopping with lower risk than in a recent stenting. I think it talks about maybe preloading those patients.
Okay, well, so preloading always made great sense until it was studied and found not to add very much. And, you know, the basic premise there is with modern P2Y12 antagonists, particularly the third generation antagonists, they become effective very early. So you probably don't get much extra bang for the buck by preloading. And if you're not doing an intervention, then the patient probably gets no added benefit out of it. That said, if you're looking at this as a stress test, I think it does make good sense in cases where you're debating whether an intervention should be done or not. And frankly, if a patient doesn't tolerate a short course of DAPT prior to intervention, then, you know, in equivocal cases, that's good reason to back off and not perform an intervention.
Correct. Stable lesions remain stable. Whenever we do stents, we make them unstable. We increase the risk of thrombosis. So yeah, you can always stop the antiplatelets before you're done the stent. It becomes really hard to stop it afterwards. So that being said and done, I'd like to thank Dr. Kleiman for a wonderful presentation and participating in our Q&A. Thank you. And thank you also to Dr. Ramchandani for his wonderful presentation. Thank you, and we'll move on to the next session. And this is going to focus on advanced heart failure, diagnosis and management. And we would like to start this session with a talk on medical therapy in advanced heart failure. This will be presented by Dr. Imad Hussain, who is the Assistant Professor of Cardiology here at Houston Methodist Hospital.
Good afternoon, and thank you very much to the organizers, Dr. Zoghbi as well as Dr. Shah, for inviting me to give this talk. So the title of my talk today is Identification and Management of Advanced Heart Failure. I'm going to start off with a case presentation. This is a patient that we saw back in October of 2017. This is a 65 years old male with a long-standing history of non-ischemic cardiomyopathy. However, over the past year and a half, he's been having progressive dyspnea on exertion, currently with NYHA class 3 symptoms. In the past year, he's been hospitalized for heart failure twice. He also has a history of hypertension, diabetes, and CKD stage 3. He has chronic atrial fibrillation, for which he's also on beta blockers as well as warfarin for stroke prophylaxis. His physical examination shows a blood pressure of 94/60 on the lower side. BMI is 34. He has elevated neck veins to the angle of the jaw. Does not have a S3 that is audible. 1+ pitting edema in the lower extremities, and the extremities are cool to touch. Looking at some pertinent labs, he has an NT-proBNP that is elevated at 5,130. Creatinine is elevated at 1.4, and he has a hemoglobin of 10.4. Pertinent medications, he is on Lasix 80 milligrams twice a day, and despite that, his physical exam shows significant decompensation in terms of volume status. Per his outside cardiologist, he used to be on Entresto about a year ago, but currently has been switched over to losartan at a very low dose at 12.5 milligrams daily due to intolerability. He is on metoprolol XL 25 milligrams per day, but at the time that we evaluated, he was not taking it because it was making him more tired and fatigued. His EKG shows atrial fibrillation that is rate controlled, and he has a right bundle branch block. Of note, because of that, he only has a dual chamber ICD in place and not a CRTD device. Now, as part of his evaluation at our transplant center, he underwent something called a cardiopulmonary exercise testing. And by the way, you can use cardiopulmonary exercise testing to prognosticate patients who have heart failure, but it can also be used as a tool, especially in patients who have multiple comorbidities like lung disease and obesity, where you can try to use this test to differentiate what is the exact limitation in terms of their shortness of breath. Is it related to the heart, a lungs, combination of the two? Is it deconditioning? You can actually tease that out pretty well with the cardiopulmonary exercise test. Anyway, his peak VO2 was 10.8 mLs per kilogram per minute, which is a function of his aerobic capacity. And anything less than 12, if you're on beta blockers, is bad enough that you should be considered for advanced heart failure therapies. And another number that we look at is VE/VCO2, which, if greater than 34, is a bad prognostic sign in heart failure, in which case for him it was 39 millimeters of mercury. His peak systolic blood pressure actually dropped with exercise to 102/80. It was higher at rest. This is his transthoracic, some representative images of his transthoracic echocardiogram. As you can see, he has a pretty low ejection fraction. He has a quite enlarged left ventricle. In summary, he has an LV end diastolic dimension of 74 millimeters. His EF was estimated at 20 to 24%. He has mild RV dysfunction, moderate mitral regurgitation, and his LV relaxation is impaired. And based on non-invasively, he has elevated filling pressures. This is his coronary angiogram, because after his echo and cardiopulmonary exercise test, he proceeded with a left and right heart catheterization, just to see if he has now developed coronary artery disease over the number of years that he has had non-ischemic cardiomyopathy. But as you can see, his arteries are still clean. And his right heart catheterization shows a mean RA pressure of 15 millimeters of mercury, which is considered severely elevated. His wedge pressure was also moderate to severely elevated at 23 millimeters of mercury. Mean PA pressure was 50 millimeters of mercury, and anything over 45 is considered severe. Now, there is some pertinent numbers when we are evaluating patients for advanced heart failure therapies that are important. One is called the transpulmonary gradient, which is the differential mean PA pressure minus your mean wedge pressure. So 15 minus 23, which will give you 27. His cardiac output was low at 3.9. His cardiac index was actually 1.8. Less than 2.2 cardiac index is considered low. His pulmonary vascular resistance, which is your transpulmonary gradient divided by your cardiac output, 27 divided by 3.9 was 6.9 Wood units. And a PVR of greater than 3 Wood units is considerably abnormal, suggesting that there is a precapillary component of pulmonary hypertension, which is a relative contraindication when we're considering patients for heart transplant. Now, when you're talking about ACC stage D heart failure, on average, there are 5.7 million people in the United States, per figure statistically, that have heart failure. Amongst them, we feel like about 250,000 have ACC stage D heart failure, which is advanced heart failure. And a conservative estimate, even if you were to give a conservative estimate, like 10% of those patients would be appropriate candidates for heart transplant. Well, there are only 3,000 donor hearts available in the United States. So every year, 3,000 to 4,000. So basically you can see already, even for appropriate candidates, this is a scarce resource. So we have to be very vigilant when we're selecting people for heart transplantation. So how do you identify someone who has stage D heart failure? What are some of the signs? So this is an algorithm you'll find very helpful. It's called I Need Help. And basically, let's just go over some of these attributes. If you start seeing this in your patients, this is a sign that they're progressing to end-stage heart failure or advanced heart failure, stage D heart failure. So I stands for IV inotropes. If someone comes in and they're in need of IV inotropes, and I'll give you some of the examples a little later on, but who are the people that actually need to be on IV inotropic support, then that is a sign that they need to be considered for advanced heart failure therapies. Number 2, N. If they have persistent NYHA class 3B symptoms, they are very limited in their quality of life, despite your addition and up titration of guideline-directed medical therapy. This should raise a flag. E stands, the next E, first E stands for end organ dysfunction. So if you start seeing that as you're seeing your patient in clinic, they're progressively having worsening renal function and they have heart failure, you should at least consider that this might be due to end organ dysfunction from either low cardiac output state or congested state. Worsening hyponatremia is another example. Once your ejection fraction drops below 25%, although this is a weaker signal, but that is another thing to keep in mind. If your patient has a defibrillator and they had it say for 10 years, and for the past year they've had 2 or 3 defibrillator shocks, and now they're beginning to have ICD shocks, this is a sign of progressive heart failure, and this should raise a flag that this patient is progressing to end-stage heart failure. The H stands for hospitalizations for heart failure, and if someone is having multiple heart failure hospitalizations, they definitely need to be considered for advanced heart failure therapies. E stands for edema, and these are patients that, like for example, our patient was on 80 milligrams twice a day of Lasix. Still with that, he has ongoing signs of edema and volume overload. So it's something people who are refractory to diuretics, that would be the people who are also probably progressing to heart failure. Low blood pressure, L stands for low blood pressure. So if your patients can not maintain, they're hypotensive, they're symptomatic, and they're not able to tolerate guideline-directed medical therapy, which is the P, prognostic medication. So for example, you have patients who've been on good guideline-directed medical therapy, they're on Entresto, they're on carvedilol, and all of a sudden you're starting to see that they're switching. Now they are having low blood pressures, more fatigue, and they're having to go down on their doses of blood pressure or guideline-directed medical therapy. And this is a signal that they can be presenting with they're progressing to stage D heart failure. So I need help is a very important, useful algorithm. Now, most patients, a lot of clinics out there, in particular, even internal medicine clinics, use something called a Seattle Heart Failure Model Score, where you can just go on the website and plug in what medications and doses of diuretics, and they have some questions that you can answer. Long story short, it'll give you a prognostication. For example, I did this for our patient that I just presented, and it shows that the 1-year survival is 74%. So when your Seattle Heart Failure Model Score predicts a less than 80% 1-year survival, this will also guide you that this patient has developed or has progressed to end-stage heart failure and needs consideration for advanced heart failure therapies. Now, in terms of moving the gear to what is medical therapy in advanced heart failure, so you have to understand that I just told you that these are people who are typically not tolerating previously tolerated GDMT. So there's a very limited role of guideline-directed medical therapy once you progress to heart failure. So, and just to comment and make it clear that most heart failure drug trials that have been done have either excluded patients with stage D heart failure, or they had very small numbers represented. So hence, it's not, guideline-directed medical therapy has a limited role in medical therapy for advanced heart failure. However, I would like to make a few comments of the use of digoxin in advanced heart failure and use of inotropic therapy in advanced heart failure therapy. Let's start with digoxin therapy in heart failure. So one important thing is that all DIGS trials and the studies that were done, they predate the contemporary guideline-directed medical therapy. So hence, anything that we extrapolate is going to be based on indirect evidence, because there have been no new trials of digoxin in the contemporary guideline-directed medical therapy era. It's notable that digoxin is the only heart failure medication that can raise blood pressure, and the only major randomized controlled trial that we can derive some knowledge from is the DIGS trial that was performed and published in New England Journal of Medicine back in 1997. It does need therapeutic monitoring, and an ideal goal to keep in mind is to keep the digoxin level between 0.5 to 0.9. Now, I'm showing you some data from pre-specified secondary analysis of the DIGS trial, and the people who benefited the most in terms of reducing the cardiovascular death or hospitalization due to worsening heart failure. It was the patients who had the lowest ejection fraction, less than 25%. They had the greatest benefit, or patients who had NYHA class 3 to 4 symptoms. So even in the DIGS trial, the patients who had more advanced heart failure were actually the patients who benefited the most, giving you a signal that this may be used in patients who are symptomatic or intolerant of guideline-directed medical therapy. The other thing is that when you look at a secondary endpoint and looking at death and hospitalization due to worsening heart failure alone, digoxin was better than placebo. And then in a post-hoc analysis, when they looked at serum digoxin concentrations, and that's why I've said the ideal goal is between 0.5 to 0.9 or 0.5 to 0.8, you can see that compared to placebo, there was an improvement in mortality if you had the dig level between the serum concentration. And the increased mortality signal was only when your serum drug concentration went like greater than 1.2 nanograms per ml. So, and then just to add to this, and again, this predates contemporary guideline directed therapy. However, it's important that people who were on digoxin had significant improvement in their peak VO2 or functional aerobic capacity. So what I mean to say is if there is a medication that, if monitored appropriately and kept in a therapeutic level, short of considering someone for advanced heart failure therapies like heart transplant or LVAD, with no signal that if it's in therapeutic drug level range, that there is no signal for worse mortality. In fact, there's a signal for improved mortality that can improve functional capacity, as the data as I'm showing you, and can reduce heart failure hospitalization. And it remains in the 2022 guidelines to be used in patients who are symptomatic despite the proven guideline-directed medical therapy. I see no harm in attempting this in advanced heart failure patients, especially because digoxin can raise your blood pressure by a few points. It can improve their fatigue, improve their quality of life. And so I think this is the medication that you should be considered for use in advanced heart failure. Now, what about inotropes in advanced heart failure? So when you talk about inotropic agents in advanced heart failure, there are three classes. One are the PDE3 or phosphodiesterase 3 inhibitors, and example of that is milrinone. Then there are beta agonists, for example, dobutamine, and then there are calcium sensitizing agents, for example, ivsamendin, which is not available for use in the United States. So predominantly the inotropes that we use in the United States are either dobutamine or milrinone. Now, this can be used as an intent for short-term therapy. Now, you may have heard that inotropes increase mortality. This was studied in a bunch of trials, including Optime, CHF. You have to understand that there's a differentiation between decompensated heart failure with low cardiac output state or cardiogenic shock versus just acute decompensated heart failure. So, of course, inotropic agents will not be recommended in patients who have acute decompensated heart failure alone and without signs of low cardiac output state, because there is a concern for increased mortality in these patients, most likely due to the proarrhythmic effect. However, if you have hypotension or clear evidence of end organ hyperperfusion, what do I mean by that? Well, an easy one is altered mentation. What if they have worsening renal function acutely? They have cool extremities. They have evidence of shock liver with elevated LFTs. These are all signs that your patient has end organ hyperperfusion, and especially if they're hypotensive, then inotropic agents will in fact be, at least in the short term, life-saving drug rather than increasing mortality. So please make this differentiation that acute decompensated heart failure with hypotension or evidence of low cardiac output state and organ hyperperfusion is actually an indication for inotropic support, and versus just acute decompensated heart failure, where yes, if you use that just for assisting diuresis, for example, then yes, you are at a risk of proarrhythmia and potential ventricular arrhythmias that can lead to adverse outcomes. Now, if you have a right heart cath, and we do it frequently here, and the hemodynamics suggest cardiogenic shock, low cardiac output state, then it's a clear indication, at least in the short term, for inotropic support. So when it gets into the intermediate term, you have to understand that once we deem someone inotrope dependent, we need to consider them as inotropes as a bridge to something, either as a bridge to heart transplant or a bridge to an LVAD if they are not candidates for a heart transplant, or as a bridge to recovery. For example, someone comes with acute myocarditis, they go home on milrinone, and after 3 months, potentially could be weaned off once they have recovery in their LV function. And then long-term therapy would be reserved for patients who are not candidate for advanced heart failure therapy. So it has a palliative intent to improve quality of life in patients who are approaching end of life and not candidates for transplant or LVAD. So what are the indications for advanced heart failure therapy? So as an inpatient setting, patients who present with cardiogenic shock and they are requiring either inotropic support or temporary MCS, and you're unable to wean them off this, and they're on balloon pump or Impella support to maintain adequate end organ perfusion, then they will undergo an expedited inpatient evaluation for consideration of advanced heart failure therapies like transplant or heart transplant or LVAD. However, for patients who are outpatient and they meet more of the criteria that I shared with you in the I need help algorithm, then you should proceed with cardiopulmonary exercise testing. Now, if for patients who are not on beta blocker therapy, our peak VO2 cutoff that we typically use is less than 14 mLs per kilogram per minute. However, for patients on beta blocker, our peak VO2 cutoff typically is less than 12 mLs per kilogram per minute. Now, this may not be applicable to all patients, but we have some prediction models of what is predicted for a particular age and gender, what is the predicted peak VO2, and if you are less than 50% of predicted, that can be used as an alternative criteria for referring for consideration of advanced heart failure therapies. And then lastly, VE VCO2 slope, and if that's greater than 34 to 35, if it's more than that, that is a criteria that can be used for consideration of heart transplant or heart transplant listing. Now, briefly, I would like to go over some of the contraindications for heart transplant for a better understanding when you refer these patients to a heart transplant center. Typically, if you're age greater than 70 years, most programs in the United States will probably not consider heart transplant. A BMI of greater than 35, the 5-year mortality can double in these patients who are obese, especially when you go on steroids after heart transplant, they gain even more weight. So a BMI of 35 is generally considered a contraindication for heart transplant. However, that does not apply to LVAD. So if you have an obese patient, they may not be a transplant candidate, but still be an LVAD candidate. However, a BMI of greater than 45 has not been studied well in even the LVAD populations. Someone who has extreme frailty, that would be considered a relative or at times an absolute contraindication for heart transplant. Pulmonary hypertension, like I mentioned to you, if your pulmonary vascular resistance is over 3.5 Wood units, if you remember that our patient had a pulmonary vascular resistance 6.9 Wood units, it would be considered a contraindication for heart transplant. But however, if you're able to modulate that with vasodilator therapy like sildenafil and bring it down, then you can have a good outcome and they become transplant eligible. Active or recent malignancy within the past 5 years is generally considered contraindication for heart transplant. If they have an active infection, it's a contraindication, but it's often a temporary contraindication because that can be treated. Now, if you truly have uncontrolled diabetes, and especially with end organ damage, then that is a red flag when you're considering patients for heart transplant. Severe cerebrovascular disease, and by that I mean if you have had a large stroke and you have a permanent neurological deficit, then yes, I mean, that is considered a relative contraindication for heart transplant. Now, if you have evidence of end organ dysfunction, for example, if you have GFR less than 30 and you have chronic kidney disease, because sometimes this could be cardiorenal syndrome, your estimated GFR is less than 30, but when you support the heart better with either inotropic support or temporary MCS like balloon pump, you can get the renal function to improve. So you have to differentiate it from intrinsic renal disease versus cardiorenal syndrome. But if it is truly GFR is less than 30, they can't be a candidate for heart transplant alone, but certainly, and we do this frequently, they can be candidate for combined heart kidney transplant. Same thing goes for liver dysfunction. If you have to differentiate between congestive hepatopathy, if they have elevated liver enzymes, versus chronic liver disease, because people who have long-standing decompensated heart failure may develop cardiac cirrhosis. So sometimes the only way to differentiate that is to do a liver biopsy. And if they have liver cirrhosis, and especially if it's cardiac related, we can still consider them for a combined heart liver transplant, and we do this often at our center. However, if they're not a candidate for a dual organ transplant, then that would be considered a contraindication for heart transplant. Patients who have established pulmonary long-term chronic lung disease and they have a home O2 requirement, that would be a contraindication for heart transplant alone. But when we talk about combined heart lung transplant or heart double lung transplant, is typically reserved for patients who have adult congenital heart disease with pulmonary arterial hypertension, or a single etiology for both their heart and lung disease. And typically the cutoff we use for them is 65 years, at least at our center. And this is not frequently done throughout the nation. So heart lung transplant a bigger deal than what we have talked about previously. Surgical considerations, if someone has had, say, for example, Hodgkin's disease and they've had mediastinal radiation, sometimes that is considered relative. These are all relative contraindications. They become higher risk in terms of surgical candidacy, but not necessarily preclusive. Psychosocial concerns are important. Someone is smoking in the past 6 months, generally speaking, it's a contraindication. Active illicit drug use or excessive alcohol use is a contraindication. Definitely, if they have demonstrated medical non-compliance, they need a lack of adequate care plan. They need a 24/7 caregiver, at least early on over the first 3 months. And then sometimes insurance becomes a limitation. So these are contraindications for heart transplant. Now, contraindications for LVAD, generally speaking, just to keep in mind that LVAD is a left ventricular assist device. It's a durable device that people go home with, but it does not support the right side of the heart. So you want to make sure before doing an LVAD, the patient does not have significant RV failure that would be preclusive for an LVAD alone. There are multiple risk prediction models, and this is not the forum to go over them, but generally speaking, on echo, people who have some familiarity, if the right ventricle is severely dysfunctional and as enlarged as the LV, something called RV-LV ratio on echo, if it's close to 1, or there are some right heart cath hemodynamic parameters that can predict how bad the right ventricle is performing, we put these together and calculate what we think the risk of RV failure after an LVAD would be. And if we think this is preclusive, then we don't proceed with LVAD implantation. If someone has a small LV cavity size, typical patients are like amyloidosis patients, hypertrophic cardiomyopathy patients, or even patients with ischemic cardiomyopathy due to prior CABG, and they don't typically have a large cavity size. But if your cavity is not big enough, you have to have an enlarged LV cavity in order to be an LVAD candidate. Someone has a high VT burden, like they're having recurrent shocks and they've had VT storm requiring multiple ablations. So if it's uncontrolled ventricular tachycardia, is a clear contraindication for an LVAD implantation because it gets worse after LVAD. Definitely, if you have a contraindication for long-term anticoagulation, like a bleeding disorder, you would be considered a contraindication for LVAD. Coming back to our patient, as you know, our patient had elevated pulmonary vascular resistance. So we started that patient on sildenafil. Due to his end-stage profile, he underwent a HeartMate 2 LVAD implantation in November 2017. 6 months later, his right heart cath showed normalization of pulmonary vascular resistance, and his care plan was verified, and BMI at the time was 33. He was listed for heart transplant in August 2018 and transplanted in May 2019. He's currently still with us, doing well, although he does now have worsening renal function, approaching CKD stage 4, but not on dialysis, and overall doing very well. In conclusion, timely referral is key for optimal outcome in patients with end-stage heart failure. Identification of ACC stage D heart failure is very important. The I Need Help algorithm implementing the Seattle heart failure model will be helpful in that regard. Sending patients early for cardiopulmonary exercise testing, especially when you're seeing that they're symptomatic in terms of their heart failure, to prognosticate where do they stand is an important part of the puzzle. There's a limited role of guideline-directed medical therapy. I believe digoxin can be used in advanced heart failure with minimal risk if monitored appropriately. Inotropes are usually used as a bridge to some definitive therapy or recovery, otherwise with a palliative intent. And transplant LVAD is considered more definitive therapy for this group of patients. And I tried to go over some of the contraindications for VAD and transplant with you. With that, thank you very much for your time, and we will take any questions. Thank you very much.
Thank you very much, Dr. Hussain, for such a wonderful, comprehensive talk on medical therapy in such a difficult subset of patients. We'll try to fill the questions at the end of this session. So without further ado, let's move on to Dr. Mawaz Kashi. She's an assistant professor and a heart failure expert and specializes in infiltrative cardiomyopathy. And she will discuss heart failure therapy devices and surgical therapy for advanced heart failure. Dr. Kasi.
Good morning. I'm Mawaz Kasi, and I'm one of the advanced heart failure transplant cardiologists at Houston Methodist, and I'll be talking about devices and surgical therapy for advanced heart failure. So before I go into describing what are currently devices and surgeries available for patients who have advanced heart failure, I want to talk a little bit about advanced heart failure and what that really means. So advanced heart failure by definition describes a clinical syndrome characterized by persistent or progressive symptoms and ventricular dysfunction despite guideline-directed medical therapy. Again, that's a really important point because I don't think that until we've tried to optimize guideline-directed medical therapy can we really define advanced heart failure. So before moving on to further clarification on advanced heart failure, I want to talk about a few facts about heart failure. So currently in the United States, 6.2 million American adults are affected by heart failure, and the incidence approaching about 21 per thousand population after the age of 65. Projections estimate that by 2030, more than 8 million people over the age of 18 will be affected by heart failure. Data from the ATHERE registry, which is an acutely compensated heart failure national registry, suggests a prevalence about 5% among hospitalized patients. And with the global burden of heart failure increasing, advanced disease will undoubtedly increase in tandem. In last year alone, more than 3,000 patients were treated with an LVAD, more than 3,000 patients received a heart transplant, and an additional 3,500 patients are awaiting transplantation. So again, how do we define advanced heart failure? This is a really nice classification that was introduced by ACC/AHA, which dichotomizes heart failure in stages A to D. The focus of my talk, of course, is stage D, which is the end-stage disease, and it requires specialized treatment. So how do we recognize these patients? Usually by recognizing their clinical class, which is fairly easy. Of course, if a patient has marked limitation in physical activity, and they are unable to carry out their daily activities, they're skipping work, they're getting readmitted. Those are, of course, red flags. So, of course, numerous societies have come up with different ways to describe it, but there's, of course, a lot of overlap. I mean, clearly patients who are intolerant to GDMT and they have end organ dysfunction or persistent hyponatremia, they're getting frequent ICD shocks, frequent hospitalizations, their blood pressure is persistently below 90, they're not able to tolerate any medical therapy. And then you can get really objective about your assessment as well by doing cardiopulmonary exercise test, where if their peak VO2 is less than 12, with a good effort, they're clearly advanced. If they have, they walk less than 300 meters at 6-minute walk distance, if they have a lot of heart failure admissions, I mean, these are clearly poor prognosticators. And then in addition to that, if you have right heart cath data or imaging data to support that they truly are advanced. The trouble, however, also with advanced heart failure is that while end-stage cancer, you have a clear trajectory to how the patient's not doing well and they may not live past 3 months or 2 months. Patients with end-stage heart failure have a variable trajectory. So they can have progressive symptoms and then they may get better, then they may have progressive symptoms again, and then sometimes unexpectedly they will present with cardiogenic shock. And so I always explain to my patients that the trajectory can be unpredictable, but typically if they do have advanced symptoms, their survival past a year is less than 50%. But timing is very important in recognizing these patients early because the way I explain this to patients is that as you progress in advanced heart failure, you're really coming close to a cliff. And if you fall from the cliff, then I really cannot help you. I cannot do anything more than that. And at that time, of course, failure to recognize leads to a lot of issues, and unfortunately, people can pass. However, if you do recognize early, then you can at least prepare them in advance for therapies like transplant or LVAD. Now, what are device and surgical options that are available in heart failure? So currently, devices that are available are usually either remote monitoring or devices that can allow some cardiac restoration and reverse remodeling. And then, of course, the cardiac replacement being the LVAD or transplant. But the real question you have to ask yourself is that whether how it will help my patient. Will this strategy prolong their survival? Will it improve their quality of life? Will they prevent people from getting admitted? And is my patient truly a candidate for such therapies? And what does the data suggest whether these strategies are truly helpful or not? In terms of device development, there's truly been a hiatus since 2000, since ICD, CRT, LVAD have become streamlined. Since then, the device development has been, although much has been put into it, but none of the devices are so far accepted for patients with advanced heart failure. And I'll talk a little bit about some of the various devices that are looked into and are being evaluated for this patient population. So I'll start off with the case. This is a 74-year-old who had non-ischemic cardiomyopathy, who was on low doses of metoprolol and cilopril, was unable to tolerate higher dosages of medications because of hypotension. The patient was upgraded to CRT-D in the last 1 year, however, continued to deteriorate and had 5 hospitalizations with them since the CRT-D. The LVF was less than 20%, with LV and diastolic dimension of 8.2 with moderate mitral regurgitation. If you look at, we did a right heart cath. The right atrial pressure was 15, the bench was 24, and the cardiac index was 1.6. So all of these are, of course, as I had alluded to earlier, 5 hospitalizations, unable to tolerate medications, low EF, dilated LV, poor hemodynamics are all well put together, and we can all recognize that this patient has advanced heart failure. So what would you do next? I mean, this patient, of course, the options that are available, either we consider transplant or LVAD, or ICD, or the other options are cardiac contractility modulation, some of the restorative devices, or mitral clip. So in our patient, if you look at the patient profile again, this is a 74-year-old, so clearly transplant is not an option. However, this patient was then considered for a left ventricular assist device and was evaluated and was a good candidate for an LVAD. Clearly, the patient had failed CRT, and there's in this strategy at least no role for cardiac contractility modulation. Being moderate mitral regurgitation, this was not a clippable option. So basically, you have all these options. You have to just figure out what your patient would benefit from and what they are a candidate for. So talking about heart transplantation, of course, this is the preferred therapy for select patients, and the survival is up to 90% with a conditional half-life of about 13 years. Now, survival has definitely improved in the last 5 decades. However, the challenges continue to be that there's limited donor pool, patients with complex medical problems and other end organs being affected are usually not candidate for transplant. And of course, geographic constraints with ischemic time is an important consideration. And we have to clearly accept that not everyone is a transplant candidate. However, maybe this is the best strategy for patients who have advanced heart failure. And of course, definitely, we're also dealing with a lot of waiting time in these patients. However, in the last, since 2018, with the upgraded criteria, some of these wait time issues are being addressed with a newer classification system. But clearly, if you're at imminent risk of a decompensation or death, then you don't have enough time to wait for a transplant to happen. So in those patients, left ventricular assist device seemed to be a very reasonable option. This was evaluated in the rematch trial and in the first randomized study to describe the benefit of LVAD support. And LVAD therapy has really evolved with each subsequent generation with improvement in durability, device complications, survival. So we went from HeartMate 2 to the HVAD to HeartMate 3. But it's important to recognize, again, that patient selection is crucial. It should be considered in patients who have NHI class 3 to B to 4 symptoms with LVF less than 25% with a peak VO2 of less than 12 to 14. And definitely, we've seen with device evolution, there has been an improvement in outcomes. As you can see with the newer generation centrifugal flow pumps, the survival has clearly improved compared to the older generation axial flow pump, which is a HeartMate 2. Now, the next question is there a role for remote monitoring in these advanced heart failure patients? Typically, if these patients are at risk of imminent death or if their survival is less than 50%, really, remote monitoring may not be helpful, but it may be helpful in those ambulatory class 4, 3 to 4 patients who are getting readmitted in the hospital, and CardioMEMS is maybe helpful in monitoring these patients closely and preventing further hospitalizations. And we've seen that with a lot of remote monitoring and optimizing their medications, we have been able to get them out of that stage D heart failure, and people have improved. So, so definitely is an option, but it is not an option for very, very advanced heart failure patients. Now we'll talk about another case, which is a 66-year-old with newly diagnosed heart failure. The prior history was only positive for hypertension. Patient was on Coreg. 12.5 in losartan, 75. That was the peak dosages that he could achieve. His NHI class 3 symptoms improved to NHI class 2. EF remained 25 to 30% with moderate to severe mitral regurgitation. This is his EKG, where you should see a left frontal branch block sinus rhythm. So what would you do next? In this patient, Of course, the important consideration here was persistent low EF despite optimization of medical therapy. So, of course, now is the time to consider him for an ICD. So, indications for ICD with patients with heart failure, usually class 1 indication if you've already had an event like VT or VF, and 3 randomized trials have shown benefit. And in patients where they have persistent low EF, ICD is class 1 indication if they are in NHI class 2 to 3, despite being on medical therapy. But the caveat being here that if you're expected to live more than 12 months in really advanced heart failure patients, then ICD may not be a suitable option. And it has been shown beneficial in 2 large randomized trials. And demonstrated a statistically significant relative risk reduction in overall mortality in patients who didn't received an ICD compared to those who were treated with medical therapy alone. And highest risk reduction is achieved in patients with ischemic cardiomyopathy. Now, other important consideration here is the CRT, which is a cardiac resynchronization therapy, which this patient was a really good candidate for since they had a left bundle branch block, and it has been shown to improve symptoms, exercise capacity, and reverse remodeling and ejection fraction. So again, CRT is it can be used in advanced heart failure who have LVF less than 35% and have a QRS above 120. And there's a 3-lead system that's placed right atrial, right ventricular, and the coronary sinus. And those patients who benefit from CRT are usually those with very wide QRSs, above 150, and those with left bundle branch morphology. So again, you have to recognize appropriateness. So if the patient has left bundle branch block and if they have a QRS greater than 120, then of course they're suitable candidates for this. It can be even beneficial in some patients who have less advanced symptoms, such as NHI class 1. But it is also important to recognize there's a good number of patients who feel worse after the CRT placement, and a good proportion of patients who actually have gain no benefit from CRT. So that is usually how I counsel my patients when I offer them this therapy. So our patient received CRT, and as you can see now, his QRS is nice and narrow, and with appropriate CRT, the patient's ejection fraction actually normalized with a reduction in mitral regurgitation severity. So this is a very good example of how the patient was appropriate for this therapy. The device was appropriately placed, and with left bundle branch block, we know that it has the most benefit. And thereafter, of course, we saw that his ejection fraction improved and the MR severity improved. But there's definitely a hiatus in patients who do not meet criteria for the CRT. So then FDA has approved the Optimizer smart implantable pulse generator for heart failure, which is basically cardiac contractility modulation, and is indicated in patients who are chronic heart failure who are not eligible for CRT. So this approval was in March of 2019. So what this really does is that it has a similar mechanism. It has an implanted pulse generator, and the CCM signal basically is applied to the absolute refractory period to the RV septum via a standard pacing system. And what we've seen in this patient population is that there's improved peak VO2 and there's symptoms and reduced heart failure hospitalization. So definitely there's a role for this in patients who are not candidate for CRT but have persistent symptoms and still are and have not gained full benefit from medical therapy. What this really does is this cardiac contractility modulation is that it upregulates the circular activity, and it normalizes the sodium-calcium exchanger. And basically, all these mechanisms at the molecular level are causing reverse pathological remodeling. Now, LV remodeling, which means that, once you have heart failure, you have a dilated left ventricle with mitral regurgitation. You have what are ways to basically reduce the size of the left ventricle in an effort to actually improve the heart failure. This concept has been in literature since the 1990s, where they first developed a surgical technique to reduce the size of the enlarged left ventricle. The idea behind this is that, we understand that if you do have an enlarged left ventricle volume, this is associated with increased mortality. And if you reduce the left ventricular size, you're basically reducing the wall tension, increasing survival by increasing the left ventricular ejection fraction and decreasing the left ventricular end systolic volume index. So we went from the original DOOR procedure, which was a restoration procedure, to the restore to stitch trial, and essentially, different ways to basically reduce the LV size. For in this example, where we see a patch is placed at the LV septum, and so that reduces the LV size. So the idea is beautiful, but unfortunately, despite all the initial enthusiasm, the mid to long-term results of these studies were disappointing, and the concept was finally basically abandoned. And the reason for failure, if you look at back at these studies and dichotomize them, it's really because there was improper site or scar selection, there was improper or inadequate volume reduction, and improper patient selection a lot. And I'm not going to go into details of all these trials, but now, what I really want to hone on is that there is room for re-innovation in this area. There's a new device that we are also a center for, is the Biventrix, where there's an anchoring system that reduces LV size. So, and this is only for patients with ischemic cardiomyopathy. So definitely there is room for innovation, and I think with the newer imaging modalities, better recognition of scar, our better understanding of the patient's profile, I think there could be room for these therapies in the future, but currently are still under exploration. Lastly, I think if any conversation about advanced heart failure therapies and devices should not be complete without talking about the mitral clip. So this is basically, as the LV dilates, patients develop more mitral regurgitation, which is as a result of essentially the valve just stretching out. And in these patients, particularly those with moderate to severe secondary mitral regurgitation who remain symptomatic, again, despite medical therapy, mitral clip may be a good option to lower their symptoms and improve all-cause mortality. And it is becoming more and more streamlined. But again, this therapy is best suited for patients who, one, truly have significant mitral regurgitation and are not advanced or extreme advanced heart failure patients who are at imminent risk of death. These mostly patients who benefit from this are usually, again, those intermax 4 or 5 patients who are still ambulatory and could benefit from this additional therapy. And we've seen a lot of benefit in these patients. And certainly, again, suitability of the patient, and if your patient is really good candidate for these therapies, it's are important considerations. So in this, I will end my talk, and thank you for listening to me. And if there are any questions, I'll be happy to take them.
Thank you so much, Dr. Kasi. That was such a comprehensive review of so many devices. It just, the list keeps on growing as to how we can help. We will like to invite our next speaker, Dr. Ashrit Guha. He's our assistant professor here at Houston Methodist Hospital and a very key member of the heart failure, heart transplant program. But his passion and his subspecialty is pulmonary hypertension. So I would like to invite Dr. Guha to talk about pulmonary hypertension, diagnosis, and therapeutic approach. Dr. Guha.
Good afternoon, everyone. I'm Dr. Ashrit Guha, one of the heart failure transplant cardiologists here at Methodist, and also the director of the pulmonary hypertension program for the Methodist DeBakey Heart and Vascular Center. I'll be talking to you all today about pulmonary hypertension. These are my disclosures. And during this talk, we'll be talking over the new definition of pulmonary hypertension and pulmonary arterial hypertension, evaluation of a patient with suspected PH, the current medications which are being used for the treatment of pulmonary hypertension, and the treatment algorithm and risk stratification tools. So pulmonary hypertension is defined as mean PA pressure greater than 20 millimeters of mercury. And pulmonary arterial hypertension is defined as mean PA pressure greater than 20 millimeters with a mean pulmonary artery occlusion pressure or pulmonary capillary wedge pressure less than 15 with and a pulmonary vascular resistance of 3 Woods units. Now, pulmonary vascular resistance is defined as mean PA pressure minus the wedge pressure divided by cardiac output. And all of these have to be measured by a right heart catheterization, which is really the gold standard to diagnose patients with pulmonary hypertension. So just to sort of reiterate what we just talked about, so this is the right side of the heart, and all the systemic blood flow comes back to the right side and then gets pumped through the pulmonary artery. And these are the capillaries, and then the blood gets oxygenated and then goes into the left side to be pumped out through the aorta. So in patients with pulmonary hypertension, the blood pressure here in the pulmonary arteries are high. However, in a pulmonary arterial hypertension, the wedge pressure or the pressure on the venous side is entirely normal. So this will segue into the classification of pulmonary hypertension, where group 1 or PAH is really where the wedge pressure is normal, and this is subdivided into based on etiology into idiopathic, heritable, drug-induced, and PH associated with connective tissue disease, HIV infection, portal hypertension, congenital heart disease. And in group 2 are those patients who have left heart disease or in whom the wedge pressure is high. And these are patients with valvular disease or systolic and diastolic dysfunction. And patients due to lung disease and or hypoxia, such as COPD, interstitial lung disease, fall into group 3. Group 4 is chronic thromboembolic pulmonary hypertension. And these are patients who have had blood clots and then eventually go on to develop CTEPH. And group 5 are those with unclear multifactorial mechanisms, such as dialysis and those patients with other systemic disorders. So in whom should you suspect pulmonary hypertension? Those patients in who have exertional dyspnea, syncope, angina, and progressive limitation of exercise capacity. This is something that we see in a lot of patients. And in whom should we really think about PH? And in PH, I think that's the bigger question. So this is the usual sort of diagnostic algorithm that we use in patients with pulmonary hypertension. So once you have a patient who presents to you with shortness of breath, echocardiography is really sort of the kingpin investigation, which will help us diagnose somebody has pulmonary hypertension. So echocardiography can give us signs of elevation of right ventricular systolic pressure, which oftentimes is the same as the PA systolic pressure in the absence of pulmonary valvular lesions. And that is one of the ways in which we can see if patients have pulmonary hypertension or not. Another way using echo that you can also kind of get a sense of whether a patient has pulmonary hypertension is by looking at the downstream effects on the right ventricle or on the right atrium. So if you have patients who have tricuspid regurgitation or enlargement of the right ventricle, then that can give us a clue that patient could have pulmonary hypertension. Because a lot of times, because the echo's sensitivity to pick up the high PA pressures are about 80%. So in about 20% of the patients, we might not be able to pick up if patients have high pressures. So in which case, we should also look to see if there are downstream effects, and that could help sort of delineate if patients have pulmonary hypertension. And then in addition, you always look at the company it keeps. If these patients have connective tissue disease, if they have left heart disease, so if they have other conditions which can lead to shortness of breath, it can help differentiate what group of pulmonary hypertension they could belong to. So then, based on the history, risk factors, and pulmonary function test, then you can decide if they have, lung disease, heart disease, and if there are no signs of pulmonary hypertension or RV dysfunction on echo, then you can attribute it to those other conditions. Otherwise, you can go down this algorithm, and then, especially if the VQ scan is a very important test that we do in patients with pulmonary hypertension, and I'll talk to you all about it later on. But once you have a high suspicion of pulmonary hypertension, really you have to get the gold standard test done, which is the right heart cath. It can help tell you what group of pulmonary hypertension the patient belongs to, so that they can be treated appropriately. The other things, once you diagnose that somebody has pulmonary arterial hypertension, like we talked about in 2 slides ago, you kind of look at all the other causes, whether patients have connective tissue disease, whether they've had a history of drugs and toxins or ongoing use of these drugs and toxins, HIV, PVOD, portopulmonary, and congenital heart disease. So you go through all of these in a stepwise manner to see why that patient could have had pulmonary arterial hypertension. So this again reiterates, what to look for on echocardiogram. If you have a high velocity on the tricuspid regurgitation jet, that will help us diagnose or estimate the RV systolic pressure, which will then help us diagnose pulmonary hypertension. So once we diagnose pulmonary hypertension and do the right heart cath to confirm pulmonary arterial hypertension, the next thing we have to do is, talk about treatment. So, 20 years ago, there were barely any treatments. Now we have almost 13, 14 drugs which have been approved for pulmonary hypertension. But let's talk about some of the general measures we do. As we looked in slide 2, pulmonary artery, the downstream to pulmonary artery is the right ventricle, which is what really bears the brunt of the pressures on the pulmonary artery go up. So a lot of our general measures are geared towards managing right heart failure. So you look at diuretics, then digoxin. Both of these, help in decreasing the preload of the RV and in helping in contractility. Oxygen, not only addresses hypoxia, but also helps with RV dysfunction by decreasing by increasing the oxygen being delivered to the right ventricle. And oral anticoagulants, the role is controversial. Currently, it is accepted that in patients who have idiopathic pulmonary hypertension or connective tissue disease-related pulmonary hypertension who receive IV therapies, that is something that you can consider doing. Now, PAH specific treatments, which have been developed in the last 20 years, there are really sort of 3 pathways that these target, but there are 5 drug classes. So the endothelin receptor antagonists target the endothelin pathway. They work on endothelin receptor A and or B, depending on the drug. And again, they lead to vasodilation in the pulmonary artery and decreases the fibrosis. The phosphodiesterase 5 inhibitor or PDE5 inhibitor, which is sildenafil, tadalafil, and the SGC stimulator, which is riociguat, all of them work on the nitric oxide pathway. The prostacyclin receptor agonist and prostacyclin analogs, both of these work on the prostacyclin pathway. And so these are the 3 big pathways. And of these, the first 7 drugs you see here, they are all orals, as you can see here. And treprostinil is available in all the forms, and epoprostenol is available really in IV form. So let's just briefly go over some of the features of these therapies. The ERAs are very effective in early form of PAH. They really decrease the fibrosis and the remodeling. It has a big side effect of causing edema. So you've got to be careful in advanced patients who already are in decompensated RV failure. Now, the problem with liver toxicity was present in the earlier generation of ERAs, which is no longer present. Now, in terms of PDE5 inhibitors, they're probably the most commonly used and well-tolerated pulmonary hypertension therapies, especially in some of these elderly patients and patients with a lot of secondary issues. It is much well-tolerated. The only thing is that over time, it loses kind of its efficacy, because as the disease progresses, your nitric oxide levels go down, and without endogenous nitric oxide, it is really difficult for these medications to work very well. Now, very, very rarely, these patients with PDE5 inhibitors can get something called NAION, which is optic neuritis, which is ischemic in nature, and these patients can present with seeing altered colors or blurriness of vision, in which case you should really stop it and refer to a ophthalmologist. Again, you cannot use it with nitrates. And the same thing with SGC stimulators, since they work in the nitric oxide pathway, cannot use it with nitrates or with sildenafil. They're just more potent than PDE5 inhibitors, and mechanistically, they work kind of independent of the nitric oxide or endogenous nitric oxide production. So it can be used a little bit later in the disease. In terms of prostanoids and prostacyclins, these were some of the first developed therapies for pulmonary hypertension. But unfortunately, because of their IV use and because they have so many side effects, such as, jaw pain, flushing, nausea, headache, thrombocytopenia, diarrhea, it is used, really in class 4 patients. In other patients who present with shock and RV failure, it is very useful as well. Off late, there are oral, agents which work in the prostacyclin pathways, which have come into market and have made the use of prostacyclins a lot, or prostacyclin analogs and oral prostacyclins a lot more easier. So I wanted to talk to you about one sort of paradigm change which happened in pulmonary hypertension treatment a few years ago. And this was the AMBITION trial, which looked at upfront combination therapy versus monotherapy, really combining the ERAs along with PDE5 inhibitors. And as you can see here, there was a clear difference in outcomes at 3 years, where there was a 10% difference in a combined endpoint of clinical worsening and at 3 years. So at this point in time, it is our new accepted paradigm that we have to start these patients on dual therapy. So this is sort of the treatment algorithm. Once PAH is confirmed, then they undergo vasoreactivity testing. And this is again in the cath lab using nitric oxide, Flolan, or adenosine. And if they're not reactive, then they get traditional therapies. If they are, then they get calcium channel blockers. And in those patients who are low to intermediate risk by some risk stratification tools that I'm going to talk about, then you start upfront dual therapy. If they're high risk, you go directly to IV therapies and including prostacyclins. But after 3 to 6 months of treatment with dual agents, you reassess their risk, and then decide, how to augment therapies. This is a risk stratification tool, which is predominantly looking at a lot of RV-related parameters, or right ventricular parameters. And this is available online, and we use it often in clinic, once at initial diagnosis and also at follow-ups to see how patients are responding to treatment. Now, so I just want to quickly talk about a little bit about the CTEPH. It's a potentially curable type of pulmonary hypertension, which in which by doing a pulmonary thromboendarterectomy, you can cure this in about 60% of the patient. In rest of them, even though they have residual disease, can be very well managed with medications. And the key here is doing a VQ scan in patients who you suspect pulmonary hypertension, especially in those patients who've had splenectomy, who had a history of PE, ESRD, or those patients with thrombophilia to diagnose CTEPH. So again, tremendous advances have been made in the field of pulmonary arterial hypertension. The prognosis is vastly better compared to the last 30 years. However, it is still a progressive disease. We have to diagnose this early. Currently in the United States, there is almost a 2-year lag from the onset of symptoms to when patients are being recognized. So if we diagnose them early, we can treat them better and potentially even reverse all the changes in this disease. And again, always keep in mind CTEPH whenever you're thinking of patients with PH. And we are a large CTEPH center and offer all therapies for CTEPH, including surgery. So happy to take questions. And thank you, Dr. Shah and Dr. Zoghbi, for giving me the opportunity to talk in this conference.
Okay, that was an excellent overview of pulmonary hypertension, which is such a subspecialized field. So thank you, Dr. Guha. We have certain questions and we have a little bit of time to address that. So if you can help us get to those. I see Dr. Kasi and Dr. Guha has joined. I do not know if Dr. Hussain is going to be able to make it. Again, thank you guys. So let me get to the questions. First question, in the same way digoxin could be used in stage D heart failure, what are your thoughts about digoxin used after LVAD implantation? Would there ever be a need for digoxin after LVAD?
I think I think there is a role, mostly, since, LVADs are univentricular support devices, the right ventricle is still unsupported. So, and early and late RV failure is seen almost in, late RV failure is seen in almost 25 to 50% of our patients. So in them, I think there is a role. However, there's no systematic studies to show that digoxin helps with RV failure. But however, we know, and Dr. Kasi has done some work on it, that digoxin has been shown to decrease GI bleeding in patients with LVADs. And again, GI bleeding occurs in, almost 20% of our LVAD patients. So we do use digoxin pretty much in all of our LVAD patients. Even if they have kidney disease, we use it in lower doses.
Dr. Kasi?
Yeah, I agree with that. So we generally keep our patients on digoxin in the long term to prevent chronic RV failure, which is again a big problem in patients who have LVAD. So there's acute RV failure, but there's also chronic RV failure. And there's a thought that the role of digoxin to prevent GI bleeding is partly related to the fact that it is important in preventing chronic RV failure. So for us, we keep them on it. It's also a good way to maybe control AFib in some patients. So there's no systematic reviews or formal studies, but there is some evidence to support the GI bleeding notion.
Thank you. The second question is, help us compare and contrast LVAD versus transplant. It seems like that, I can understand the question. Sometimes patients with advanced heart failure, one ends up getting LVAD and second one gets listed as transplant. And even for us physicians, we are sometimes get confused. And how do you guys decide who gets, and what long term, where is the current standard? Which one is better?
So that's a very good question, and probably take up an hour to answer that. But I'll try my best. So in the current, paradigm with HeartMate 3, our survival at about 2 years is comparable to a transplant. So 2 years survival is about 87, 88%, which is very similar to transplant. However, long-term survival with an LVAD is unknown. In terms of whether it's comparable to transplant. We have 5-year data from the older generation LVAD, but not with the newer generation. So in terms of how to make a decision, I think it is difficult because I think there are multiple things which go into decision making. Since transplant is a known entity, and we have long-term data supporting median survival after a transplant is now about 13 and a half years. So we know that 50% are alive at 13 and a half years. So we have that long-term data with transplant. So compared to LVAD, we do not have that. But in terms of how to make the decision, a lot of things go into making that decision. One, whether they are going to be able to take, be very compliant with all the rejection medications. LVAD is a little more forgiving than a transplant because you can miss rejection medication. Secondly, social support. Thirdly, presence of pulmonary hypertension or irreversible pulmonary hypertension, which I think is going to be an issue with transplantation. Fourth, again, if patients have a lot of antibodies, which will make them a poor transplant candidate because it's just hard to find a donor. So there are multiple things which go into decision making, but these were sort of the top ones that we take into account. And of course, age, right? I think as heart failure doctors, we have to be good stewards of the limited resources of organs available. So if there is, let's say, a 75-year-old patient whom is conditional survival, even after any of the end organ interventions is not that high, offering a transplant to that patient, then, you're potentially taking it away from somebody else who is younger and potentially could have used the organ later. So I hope I was able to answer this, but, it's complex. And, again, I think that's where, a multidisciplinary team with surgeons, multiple cardiologists, and also social workers and other specialists, because whether other end organ function is present and whether it's reversible, all of this goes into decision.
The answer is good enough because it allows our listeners to understand that it is just not a simple pick and choose. There are so many factors which go into this decision making as our listeners are going in. Dr. Kasi, would you like to add to that?
Yeah, so I think just the only thing I kind of want to add to that is that whenever we're counseling patients on what their options are, the way I counsel patients is that each therapy has its own baggage, so to speak, right? So the complications and the care associated with each of them is important to understand so that they can understand what their choices are and how they're making an informed decision. They also need to understand that this is a big lifestyle change in terms of even if you're getting a transplant or an LVAD, so it's a lifestyle change and it's a big endorsement to undergo such changes in life. Yet both of them are associated with a survival benefit, and the current HeartMate 3 has a lot of reduction in overall complications that were associated with the previous HeartMate 2 trials. Rather, it has now been endorsed as a class 1 indication for patients with end-stage heart failure, which is kind of like a recent endorsement by our guidelines. And so that's one thing to understand. The flip side of one thing is that for younger patients, sometimes it might be beneficial. There's that to do an LVAD first and then use it as a bridge and then do transplant later, and that would provide them maybe some additional years. Because if you're younger and you get transplanted, you get 13 years, then after those 13 years, what is going to happen? That's also an area of uncertainty for those patients. And then on the flip end, on the older end patient side, I also maybe want to reiterate that older patients are still candidates for LVADs. So, they shouldn't automatically rule themselves out, or we shouldn't rule them out just because of their age. That's where the other criteria is whether they're robust enough and whether they have good end organ function, and if they can undergo a big surgery. LVAD should be considered in older patients and can provide them with, I was looking at an article by another center where somebody who got implanted with an LVAD at 80, they're celebrating their 90th birthday now.
Wow.
So to me, that's important to understand.
No, and we implanted somebody at 83 who turned 90 as well. So he's still.
So soon the other center will be telling this center is doing now 93. That would be awesome. I got a couple of quick questions, guys. We are sorry we are running a little bit behind because these questions keep on coming. Maybe, Mamash, I'll start with you on a quick answer, if you may. On role of spironolactone, do you give it to everyone with systolic dysfunction or not always? Should it not be standard of care on everyone?
Well, it should be. I would say that I try to find a reason to put it on. I mean, it's generally when you put on other medical therapy, it's considered one of the foundation drugs. I will reiterate that, when patients who have systolic heart failure, they're needing Lasix and we're putting them on potassium. It's really hard to swallow that pill, practically speaking. It's better to just put them on a little bit of spironolactone once you start the Lasix, rather than giving them potassium to go home with. And it's considered foundation drug therapy, so it's, I think, it should be whatever you can put, find an excuse.
I cannot see the question, because I see way more Lasix prescribed than spironolactone. Is that because spironolactone is not considered frontline therapy in heart failure patients?
It definitely is. I mean, I think it's one of
It is one of the 4 pillars. I think there's no doubt every heart failure patient should be on it. Okay. Now, it's not a potent diuretic now, but I think the mechanisms of benefit of aldactone is, again, not as a diuretic, but more as a anti-mineralocorticoid, which helps with its antifibrotic effects and other effects. So every systolic heart failure patient should be on.
Okay. And one last question, Ash. After pulmonary embolism, how quickly does pulmonary hypertension develop? Is it something we should start looking? I mean, it's a good question. Should we start looking within a week or 6 months?
There is some heterogeneity in the studies in terms of how many patients develop chronic thromboembolic pulmonary hypertension. So it's between 3 and 7% patients who develop pulmonary hypertension after a PE. And to evaluate that, you have to wait at least 6 months on therapeutic anticoagulation, so 3 to 6 months. So if somebody is persistently short of breath, after being on, say, therapeutic anticoagulation for 3 to 6 months, then I think they should be evaluated.
Excellent.
Chronic thromboembolic.
Well, thank you both very much, and Dr. Kasi, Dr. Guha, and also thank you for Dr. Hussain for a wonderful presentation. With this, we will move on to the next session. We do have a short break announced in our program, but if forgive me, but in interest of time, if you guys don't mind, to our listeners, we'll continue through, or are we taking a 5-minute break? Okay, let's do that. Let's take a 5-minute break. And in that break, I just want to remind everybody to please keep on sending us those questions. They are wonderful, and we love those questions. So whether you can text it to DeBakey at 37607 or website polev.com and then enter DeBakey. We'll see you in 5 minutes. Thank you. Welcome back. We are about to start our second to last session, and this will focus on cardiac electrophysiology and arrhythmias, diagnosis, and management. Our first speaker is Dr. Paul Sherman, and he's going to talk about something core to cardiology, which is EKG interpretation, must know, one of the hottest topics for today. And I'd like to invite Dr. Sherman, who's our associate professor in electrophysiology at Houston Methodist Hospital. Dr. Sherman.
Hello, everybody. My name is Paul Sherman, and I'm here to give you a lecture about EKGs. So these are the EKGs you must know. And this lecture has been prepared for the non-cardiologist. In order to really understand the EKGs, I have put it in groups. The first group, we're going to call it the sudden cardiac arrest group. And these are basically the EKGs or the patterns that you need to recognize on an EKGs in able to provide the right diagnosis and the correct treatment in an expedite manner. So this is the first case. This is a young person with sudden cardiac arrest, and you're called to evaluate this patient. As you can see, the first thing that should strike you is how long the QT is in this. You can see the QT is prolonged. It's by far more than 50% at the RR interval. So you should be considering a case of long QT syndrome, okay? And long QT syndrome, it's when the QT prolongs more than 460 to 470 milliseconds. More than 500 milliseconds is considered risky, and more than 550 high risk. There are three different patterns: long QT type 1, 2, 3. These are the three most common. The type 1, as you can see, is the example that I show you. And basically, it's the broad-based T wave. A type 2 is more like a notch in the T wave, as you can visualize over there. It usually is the cardiac arrest is induced by noise. Instead, the type 1 is usually induced by exercise. The type 3 is the one that has the ST segment elevated. And the ST segment is the one that is the major contribution for the prolonged QT. The first line of therapy, beta blockers. You need to avoid competitive sport. Genetic testing is usually recommended and usually detected in 70% of the patients. If the patient has sudden cardiac arrest or syncopal episode, you should consider the defibrillator. If the patient has symptoms on beta blockers, the patient should have also defibrillators. Or any QTC more than 500, which is considered high risk, should consider the defibrillator. Here's the opposite. When a young person might present with a syncopal event or atrial fibrillation, they can also present with cardiac arrest. It's the short QT syndrome. As you can see, this EKG should strike you to be very, very short. So again, young age, individual presenting with atrial fibrillation, ventricular fibrillation, polymorphic ventricular tachycardia. It's usually a mutation of the potassium channels, which is gaining function, or a loss of function of the calcium channels. What it means is that the repolarization is extremely efficient. So another beat or any other arrhythmia can easily be triggered. And the QTC is less than 350, or on females is considered short when it's less than 360 milliseconds. Many times under EKGs, you can find early repolarizations in their baseline EKG. We recommend the treatment with quinidine or a defibrillator implantation, especially if they have history of sudden cardiac arrest. Here's another important EKG that you must know. These are very rare, but it's what we call pathognomonic, which means that you identify this pattern and you may identify a congenital disorder called Brugada. This is what, if you don't have the symptoms, we call Brugada pattern. If you have the symptoms of palpitation, syncope, or cardiac arrest with this, we call Brugada syndrome, okay? You have the classic sailboat appearance in R1. Again, you can see it in B1, B2. That's classic, like a sailboat appearance. and this is pretty pathognomonic. So it's an autosomal dominant. It's usually a sodium channel blocker mutation. The genetic testing is usually not very helpful. It's only detected by 18 to 30% of the time. It's most common in men and Asian population. And as you can see again, this is the classic EKG pattern that you need to recognize, this triangular shape on the ST elevations. I can also present in polymorphic PT. If you encounter polymorphic ventricular tachycardia, you should consider Brugada syndrome as the etiology. The treatment, especially if it's young and with no strong other heart conditions that could precipitate such an event. The treatment of this is the defibrillator when you have symptoms, and it's very controversial, the asymptomatic. But at the moment, any asymptomatic with a type 1 Brugada parent needs a positive electrophysiology study to consider implantation of a defibrillator. Here we have another important one, and this is a key one. This, you can recognize many things are abnormal with this EKG, but the things that you need to particularly put attention is the marked T-wave depressions. That is, this EKG is showing it to you. And also there's voltage criteria for left ventricular hypertrophy. So when all this happen is we're dealing with a case of hypertrophic cardiomyopathy. These are the most common mutation, the myosin change and the protein CT3 myosin. This EKG could be in your screening at your office. So it's very important that you have the skills that you might recognize and prevent sudden cardiac death in young athletes. This abnormality is very frequent. It's present in 1 in every 200 and 1 in every 500 individual. It's the most common cause of sudden cardiac death in young athletes. And not everybody requires a defibrillator. ICD implantation requires a risk assessment where we re-stratify, and the individuals with high risk are the one that requires a defibrillator. This is another EKG that you need to screen when you have a patient with sudden cardiac arrest. This EKG, you can notice there's a subtle changes on the T wave, much less pronounced than prior EKGs with hypertrophic cardiomyopathy. But in this EKG, you can see there are T wave all across on the precordial leads. And then here in V1, you can see this notch. This is what we call an epsilon wave. They are rare, but there is a major criteria for ARVD, also known as arrhythmogenic cardiomyopathy. So again, epsilon wave, you will have that low amplitude signal between the QRS and the T wave. Here you have it again, okay? And the T wave inversions also is a minor criteria for ARVD. The presence of non-sustained and sustained ventricular tachycardia with a left bundle branch block, which meaning coming from the right side of the heart, the right ventricle, with a superior axis are suggestive of ARVD. Okay, with this, we have concluded the sudden cardiac arrest. Those are the particular things that we need to put attention to is the QT prolongation. If it's too short, make sure we don't have a presence of hypertrophic cardiomyopathy, arrhythmogenic right ventricular dysplasia. Those are the usual EKGs that we need to put attention. Now, we're going to talk about EKGs that are time sensitive to make the diagnosis. This is a clinical scenario where the patient did not have a cardiac arrest, but his life might be in danger, and you need to make that decision based on the EKG. You cannot miss. So here's the first one. And I chose this one. It has some ST elevations here, but you don't have the Q wave. So it's early on, okay? And you have ST elevations in the inferior wall of the heart. So that's as STEMI. However, I brought you this part also because this is the one that is mostly missed. Even for cardiologists, we might miss it because there are ST depression, which are usually less important. But this is what we call a mirror image. So if you invert the ST elevations, it turns out to be ST depressions, and the Q wave will look like an R wave. So this is an infraposterior STEMI. So it's very important to activate the cath lab, and the time is muscle. The earlier you act, the more muscle you save, and the better the prognosis of the patient. And you have to be very careful, particularly with this type, because it's very sensitive to sedation and morphine, and it can precipitate hypotension. Very important to maintain him with a proper hydration. prior to the activation. Here's another important EKG that is time sensitive for you to recognize. As you can see, this is a patient with a tachycardia, narrow complex, with our typical right bundle branch morphology. If you look at closely, there are P waves right there before it. So this is sinus tachycardia with a right bundle branch block, okay? Any patient with sinus tachycardia with right bundle branch block that has symptoms like syncope, shortness of breath, you should consider pulmonary embolism. Again, sinus tachycardia, right bundle branch block. And then we have this also, is not very sensitive, but it tends to be more specific, what we call S1, which is here, this depreciation right here, Q3, which is a Q wave in the lead 3, and T3, which is T wave inversions in lead 3. That's the S1, Q3, T3 pattern. Very important to recognize, identify the diagnosis of pulmonary embolism, and apply treatment, right? It can be life-saving treatment that you can apply. Another EKG like this, you may see, well, this is SVT with aberrancy, or this is Y complex tachycardia, how to referencia. I can give you easy tools. The wider you get, the most likely is ventricular tachycardia. Also, if you can see here, if you see P wave presence, and they do not match out with the ventricular, with the QRSs, then that is most likely ventricular tachycardia. You have what we call VA dissociation or AV dissociation. You have more V's than A's. That is most likely ventricular tachycardia. Also, ventricular tachycardia increases the likelihood significance if you in the history present with a heart attack, heart failure, or CAD. If you encounter a Y complex tachycardia like this and you're not sure, and you have that on the history only by considering to be ventricular tachycardia, you're 80% correct. Okay, so ventricular tachycardia, what about the treatment? Well, depends on the, if you have a stable patient, you might sedate him and give him a synchronized shock. You can consider the use of amiodarone or catheter ablation as a treatment options, okay? These are all time sensitive EKG. This is another EKG that I'd like to share with you because many times it's missed even by cardiologists, and it's very tricky, and I like to train your eyes to recognize this. This is what we normally call supraventricular tachycardia. So people may even consider this as a sinus tachycardia, but it's not. You have to be special attention in all the leads. We always like to look P wave in lead B1. And if you can see here, you can see a nice P there, a nice P there. So in a 2-to-1 pattern that he's going to. And those P, they marches with this negative deflection here. So this is the presence of atrial flutter. Atrial flutter sometimes is very challenging to diagnose, but the bottom line, it usually occurs at a short circuit in the atrium. The preferred treatment for this type of arrhythmia is catheter ablation because you can cure them and they can no longer continue anticoagulation when they have been cured for a typical flutter. So it's very important that you yield the diagnosis, that you refer for the treatment, and you need the skills to identify that. And it's time sensitive because they can produce a stroke. So it's very important that you identify them and correct it if they have a high chest VAS score that could predispose them for stroke. You should anticoagulate them. Here's another EKG that I need to train you to do a pattern recognition here. So basically, this is somebody with bradycardia, but it's very important if it's sinus bradycardia or a bradycardia from the AV node. Here, it looks like it's sinus bradycardia, but in reality, it's not. Like the flutter wave that I show you can be masked. The P wave can also be masked by the T wave. So put attention again here in B1 and lead 2. Lead 2 shows the perfect match right here with here. So it's likely again 2-to-1 conduction, which is not the same as a sinus bradycardia. So this patient is sinus rhythm with 2-to-1 block. However, AV blocks, they're different type. They're vagal blocks, which are benign and they have a very good prognosis, and they usually don't require the presence of a pacemaker. However, this is the malignant type, and this is the one that I want you to know. This is the one that is triggered by PVCs. As you can see, patients is in sinus rhythm, a PVC comes by and creates a high degree AV block. This is usually triggered by PVCs or PACs and are considered malignant. These require immediately attention and treatment. You need to consider putting a temp wire pacemaker in these individuals because they can really pass out or injure themselves. Well, with this, I hope you have granted all the skills you need to treat all those 10 time-sensitive EKGs and also to not miss those important diagnoses in the presence of a sudden cardiac arrest. Thank you very much.
Well, thank you, Dr. Sherman. I know your EKG lectures are very popular amongst our fellows, and I hope our attendees are learning a lot from those as well. I'd like to next invite Dr. Adi Lador. She's our new faculty in our electrophysiology team and makes it stronger. Dr. Lador will discuss atrial fibrillation, medications, and devices to prevent stroke, a hugely important topic. Dr. Lador.
Hello, everybody. I'm Adi Lador, and I'm a cardiac electrophysiologist here in Houston Methodist. I will talk about the atrial fibrillation treatment and the prevention of stroke. Atrial fibrillation is the most common sustained cardiac arrhythmia in adult and especially in the elderly population. It possesses significant burden to patient, physician, and healthcare system globally. In addition, there are many patients with undiagnosed AFib who often may be first detected after a stroke or developing a left ventricular dysfunction. What is AFib? AFib is a disorganized rhythm that starts in the atrium and travels to the ventricle through the AV node in different times. In the EKG, we'll see a different spacing between the QRS, which will look like irregular RR interval, and no distinct P wave. As I mentioned, AF is a common cardiac arrhythmia in adults. The prevalence of AF is increasing over the years. A previous lifetime AF risk estimate of 1 in 4 individuals was recently revised to 1 in 3 individuals at index age of 55 years. In African American, the incidence of AF appeared to be lower. The AF lifetime risk depends on age, genetic, and other clinical risk factors. And that suggests that an early intervention and control of modifiable risk factor control could reduce the incidence of AFib. There are multiple clinical risk factors. Grossly, there are 2 categories, one cardiac and non-cardiac. Most of them can be modified and by that prevent some cases of atrial fibrillation. As you can see here, the most common cardiac are hypertension, coronary artery disease, valvular heart disease, heart failure, surgery, increased pulse pressure, and pericarditis. The non-cardiac that we can modify are diabetes mellitus, obesity, obstructive sleep apnea, smoking, alcohol use, hypothyroidism, and acute infection. Things that we cannot change, of course, is age, family history, and genetic variants. The most common classification of AFib is by duration. Paroxysmal AFib is the AFib that terminates spontaneously or with intervention within 7 days of onset. Episode may recur with variable frequency. Persistent AFib is continuous AFib that is sustained more than 7 days. Long-standing persistent AFib is AFib that contains more than 12 months. And permanent AFib is AFib that's sustained, and there is a joint decision between the patient and the clinician, to continue in AFib and treat only rate control. Non-valvular AFib, this is a revised definition, is AFib in the absence of moderate to severe mitral stenosis or a mechanical heart valve. Symptoms of AFib range from non-existing for some patients or severe. AF is associated with sustained mortality and morbidity, which possess a significant burden to patients and healthcare services. AF is associated with a 5-fold increased risk of stroke. AF is also associated with a 3-fold risk of heart failure and a 2-fold increased risk of dementia, mortality, and hospitalization. Once you have the diagnosis, you want to have a documentation of AFib in EKG. Every patient should have at least one-time echo to evaluate the structural heart disease and assess cardiac function and evaluation of atrial size. And then it's recommended to do a further evaluation as serum electrolytes, thyroid function, renal function, hepatic function, and blood counts. Rate control, and then we need to decide what to do with the AFib, and we have two big options, one rate versus rhythm control. Rate control is trying to control the resting heart rate at least than 80 beats per minute, or for linear strategy, less than 110 beat per minute. Rate control sometimes is sufficient to improve AF-related symptoms. Rhythm control is the attempt to restore and maintain sinus rhythm using cardioversion, antiarrhythmic drug, and or cardiac ablation in the setting of appropriate anticoagulation and rate control. The other important thing we need to manage is stroke prevention and bleeding prevention, and I will talk about it later. I will elaborate now first regarding the rate versus rhythm control strategy. A very important paper that was published in 2020 is the East AF-NET 4 study, Early Rhythm Control Therapy in Patients with Atrial Fibrillation. The trial included patients with AF diagnosed within 12 months before randomization who were at risk for stroke and has recently been published in support of early rhythm treatment. That was a change in our view on early rhythm control as a general treatment concept. In the past, we taught to believe that rate control and rhythm control will have the same outcome to our patients, mainly based on the AFFIRM and the AF-CHF trial. However, recently we have the CASTLE trial, which have shown a decrease in adverse outcomes with ablation versus medical therapy in patients with AF and heart failure. Also, Athena, with the use of dronedarone, showed a reduce of the composite primary outcome with rhythm control. The East AF was a randomized multi-center trial. It intended to compare head-to-head early rhythm control in patients with paroxysmal AFib. Patients were randomized in 1-to-1 ratio to usual guideline recommended care, primary rate control, plus oral anticoagulation, with rhythm control, added to the control symptoms as per the guidelines. As you can see here, the different treatment the different group got. Overall, there was 2,789 patients in the two groups, and they were randomized 1-to-1, and the follow-up was for about 5 years. The outcome assessment was blinded. Both groups in these trials were very similar. 46% were female, and the average age was 70 years in both groups. Half of the patients in both groups were in normal sinus rhythm at enrollment, and the CHAD VASC was on average 3.3. The differences were in the use of beta blocker and digoxin, both more in the rate control groups, and statins were slightly higher in the rhythm control. At the end of the 24 months, 80% of patients in early rhythm control group were in sinus rhythm compared to 60% in the usual care group, which means the rhythm control was successful generally. The outcome were defined as follows. First primary efficacy outcome was a composite of death from cardiovascular causes, stroke or hospitalization with worsening of heart failure or acute coronary syndrome. The second primary outcome was the number of nights spent in the hospital per year. And the secondary outcomes were individual components of the primary outcome, symptoms, rhythm, and LV function. And there was another outcome, which was the primary safety outcome, a composite of any death, stroke, or serious adverse events related to rhythm control therapy. The trial was stopped early for efficacy at third interim analysis after a median follow-up of 5.1 years per patient. The first primary outcome was reduced by 21% in patients assigned to early rhythm control compared with usual care. Each component of the first primary outcome was numerically less common in patients randomized to early rhythm control compared with the usual care, whereas there was no difference in the secondary primary outcome number of nights in the hospital per year between the strategies. Compared with those assigned to usual care, the occurrence of stroke was reduced by approximately 1/3, and the total mortality was 16% lower in the patient randomized to early rhythm control. There was also a trend that showed decrease in hospitalization for heart failure symptoms and hospitalization with acute coronary syndrome. That did not reach statistical significance. Sinus rhythm was significantly higher in the rhythm control strategy than in the rate control strategy. The primary safety outcome was not different between the randomized groups. I've mentioned mortality and stroke already, that mortality and stroke were both in favor in the early rhythm control. Serious adverse effects related to rhythm control therapy were more common in patients receiving early rhythm control treatment than usual care, but occurred infrequently. There was increase in bleeding in the rhythm control, but mostly related to the ablation procedure, and overall there was very low number of bleeding. The conclusion of EAST-AF was that early rhythm control therapy was associated with a lower risk of adverse cardiovascular outcome, which were death from cardiovascular causes, stroke or hospitalization for heart failure or ACS, than usual care among patients with early atrial fibrillation over a follow-up of more than 5 years. And how we explain the differences in the results from the older trials. When we compare the EAST and the AFFIRM trials, we had similar types of patients, the age was similar, and the percent of AFib and the percentage of achieved on normal sinus rhythm were the same. But the antiarrhythmic drugs were different. In the AFFIRM trial, we used more amiodarone and sotalol. In the EAST trial, we used more class 1 and dronedarone. Also, in the EAST trial, no one stopped anticoagulation regardless of achieving sinus rhythm, whereas in the AFFIRM trial, the old trial, in the protocol that was stated that if you achieve rhythm control, you're allowed to stop anticoagulation. A recent sub-analysis of the EAST-AF trial in patients with heart failure showed that the first primary outcome occurred less often in patients receiving early rhythm control therapy versus usual care, with the primary safety endpoint occurring in 70.9% of participants in the early rhythm control therapy group compared with the 21.6% in the usual care group. Also, analysis of the CASTLE-AF and CAMBANA and other studies supported early ablation in patients with AF and heart failure to prevent progression, as greater improvement in clinical outcome were observed for patients in lower function classes of heart failure. So the current conclusion is that timing matters. There are encouraging results that support rhythm control as a potential important strategy in the early stages of AFib. So get out of AFib and early. There is a paradigm shift well underway towards offering early rhythm control to all patients with recently diagnosed AFib, which is not yet reflected in the current guidelines. Also, we need to maintain anticoagulation despite rhythm control strategy. In patients with AF and heart failure, catheter ablation may be preferred to antiarrhythmic drugs due to challenges in the optimization of pharmacological strategy in this population. And AF ablation can improve quality of life and reduce dementia and stroke risk. This is a summary from the guidelines to show how we use antiarrhythmic drugs. For patients without structural disease, we can use any antiarrhythmic drugs. For patients with structural heart disease and coronary artery disease, we can use dofetilide, dronedarone, or sotalol, or ablation. And patients with heart failure, we can use amiodarone, dofetilide, or ablation. What about stroke? In patients with AFib, we need to calculate the CHA2DS2-VASc risk score to assess the risk of stroke. The higher the CHA2DS2-VASc score, the more likely you benefit from anticoagulation. In patients with CHA2-VASc 2 or greater in men and 3 or greater in women, anticoagulation medications are recommended, all class 1 recommendation. NOAC recommended over warfarin in NOAC-eligible patients, which are patients without moderate to severe MS or mechanical valve. Many people that need anticoagulation are also in a high risk of bleeding, and this is the HAS-BLED score that can help us to estimate the risk of bleeding. And generally, we need to make an important decision that requires individualization of risk and benefit. NOAC is the first choice for everything, and warfarin for patients with financial constraints, stable INR from before, no bleeding, good tolerance, they can continue to get NOAC. Patient that has high risk for bleeding, they have stroke on anticoagulation, poor tolerance to anticoagulation, hemorrhagic stroke, procedural candidacy, and a high appendage risk are more encouraging for the procedure of left atrial appendage occlusion. In the 2019 guidelines, we receive a focus update to the AF guideline, which include LAA occlusion devices with a class 2B recommendation for patients with non-valvular AFib and contraindication to long-term anticoagulation. While oral anticoagulation is still preferred therapy for stroke prevention, LAA closure device is recommended alternative for patients who are poor candidate for long-term anticoagulation. We have different kinds of devices. We have the endovascular devices as Watchman that you can see here, and I will elaborate in a second. And we have the epicardial devices, as you can see here, as Lariat. The Watchman is the most studied LAA closure device, and it was FDA approved in March 2015. At the beginning, there was shown significant safety event, but as the technology has progressed, we have less safety event, and now it is up even down to 0.5% with the Watchman Flex. When we look at the 5-year data of the Protect and Prevail trial, there was a comparable primary efficacy and all-cause stroke reduction, with additional reduction in major bleeding, particularly hemorrhagic stroke and fatal or disabling stroke. No statistical difference between Watchman and warfarin for efficacy and all-cause stroke prevention. There was a major differences in bleeding in favor of Watchman. There was a 71% reduction in major bleeding with Watchman compared to warfarin after stopping the anticoagulation. And with that, I will finish. Thank you very much for listening. Thank you.
Thank you, Dr. Lador, for such an excellent and a comprehensive review of such a important topic, one of the most common diagnoses we deal with today. Our next speaker I'd like to invite, who is going to join us live, is Dr. Miguel Valderrabano, who is the Davis Centennial Chair here at DeBakey Heart and Vascular Center, leads our EP division. He's a professor in cardiology, and he will share with us information about ablation. When do I refer, and how do you guys do that? Dr. Valderrabano.
Thank you, Dr. Shah. It's a pleasure to be back. And I will discuss some practical aspects as to when we should do AFib ablation. And you need to understand that AFib, as we have learned more about the mechanisms, we have learned that we can come up with new therapies based on those mechanisms. And now in 1998, so a long time ago, a French group demonstrated that AFib, in some cases, not all, could be caused by ectopic beats that arise from one of the 4 pulmonary veins. And this led to the coming up of a new therapy based on ablating or cauterizing or burning these areas where the first beat of atrial fibrillation starts. And the thing is, when we plan a therapeutic approach for anything, we have to look at what are the benefits of such approach and why should we do it. Atrial fibrillation is a complex disease that is not just a rhythm disorder with symptoms, but it's associated with an increased risk of stroke and mortality. So not just symptoms may be the driver for our therapeutic approaches, but the fact that we may improve prognosis by reducing stroke and mortality. More recently, it's been shown that atrial fibrillation is associated with an increased risk of dementia. So imagine we could have a therapy that could not only improve the quality of life of the patient by reducing the palpitations caused by AFib, but also reduce stroke, mortality, and dementia. That would be very, very attractive. Atrial fibrillation is a serious problem that is here to stay. Epidemiological studies support the idea that with the increasing aging population, we're going to see more and more patients with atrial fibrillation. This is a statistic from now 20 years ago that was predicted that up to 5% of the general population will have atrial fibrillation, non-paroxysmal forms of atrial fibrillation. And before we define the therapies, we need to, the audience has to understand the different kinds of atrial fibrillation. This might have been touched upon by previous speakers, but it's important to remind that there are different kinds of atrial fibrillation that they're not all created equal. Paroxysmal atrial fibrillation is that AFib that terminates spontaneously or with intervention like a cardioversion or drugs within 7 days of onset. Episodes may recur with variable frequency, and that's where we compute this parameter of AFib burden. We quantify how much atrial fibrillation patients have. Persistent atrial fibrillation is the kind of AFib that persists by itself in a sustained fashion more than 7 days. Long-standing persistent atrial fibrillation refers to atrial fibrillation that has been continuous, uninterrupted for at least 12 months in duration. You may hear in the literature or in papers the concept of permanent atrial fibrillation. Permanent atrial fibrillation is a term that refers to a decision that the patient and the physician make. It does not describe the characteristic of atrial fibrillation. When we call permanent atrial fibrillation, we refer to patients in whom we have decided that we're going to let the patient be in AFib. And we're not going to stop AFib by any way. So a permanent atrial fibrillation may be paroxysmal if we decide not to treat it. It may be persistent or long-standing persistent. But it refers to just the plan that physicians have made that they will not treat atrial fibrillation. And then in the literature, you will see the distinction between valvular AFib, which is typically referred to that of rheumatic origin when it's associated with mitral stenosis, typically an aortic stenosis, and non-valvular disease, non-valvular AFib that refers to AFib that occurs in the absence of valvular disease. So when we approach treatment goals for atrial fibrillation, we need to be clear as to what it is that we are seeking when we plan to treat AFib. Do we need to improve the symptoms? Not everybody has symptoms with AFib. That's very important to recognize. Some people may bug us continuously about every single episode of AFib they have, and some people may not have any symptoms and they may present with a stroke. So we have to be clear as to what is the expectation when it comes to symptom suppression. Number two, do we want to improve outcomes? And for that, as I alluded to earlier, do we want to prevent strokes or prevent tachycardia-induced cardiomyopathy, dementia, or even mortality? And depending on our goals, we may seek just a rhythm control strategy or a rate control anticoagulation. And I see that Dr. Dadore discussed earlier some of the trials regarding rhythm versus rate control. When it comes to rhythm control, antiarrhythmic drugs have been traditionally the first line of therapy, and antiarrhythmic drugs are tricky because they can cause trouble. They can cause more trouble than what they fix in some patients. So if you have no structural heart disease, you can use pretty much any drug. Dofetilide, dronedarone, flecainide, propafenone, and sotalol, and as a second line, amiodarone, because of its long-term side effects, are proposed for patients without structural heart disease. But when you have structural heart disease, it gets tricky because flecainide and class 1 drugs like propafenone and flecainide can lead to increased sudden cardiac death. So we don't want to get into that. In the presence of coronary artery disease, we know that dofetilide, dronedarone, and sotalol are safe. In the presence of heart failure, only amiodarone and dofetilide are safe. And that's as far as drugs. What's important is that catheter ablation applies to all groups. I won't dwell into this, but recent trials have shown that the earlier we treat the rhythm control, the better the patients do. Now, the EASE trial, which was described extensively by Dr. Lador earlier, showed that we can do a better job for patients reducing cardiovascular death, stroke, and hospitalization for heart failure or acute coronary syndromes if we implement a rhythm control strategy early. Mind you, this study was not an ablation study. It was simply a study looking at strategies for rhythm control, meaning trying to keep the patient in normal rhythm with antiarrhythmic drugs. Yes, some patients got ablation, only 19% of the patients. The bottom line is that patients do better when they are in sinus. The benefits of rhythm control not only lead to improved symptoms and quality of life, but even a possible mortality benefit as shown by several studies as shown here, and even a possibly reduced risk of stroke. So it is better to stay in sinus. How do we restore sinus when antiarrhythmic drugs don't work? How does ablation work? Well, the mainstay, the basis of ablation is pulmonary vein isolation, in which we create linear lesions leading to scar around the pulmonary vein antrum. So at the entrance of the pulmonary veins, in the posterior wall of the left atrium, we create these two circles around each pulmonary vein pair so as to create an insulation barrier so that electricity from the pulmonary veins cannot spread to the rest of the atria. There are other variations, including more linear lesions to prevent flutters and a mapping to add customized lesions. The bottom line is that the mechanistic paradigm is best established for pulmonary vein isolation, and that is the mainstay of any AFib ablation. As a first line of treatment, there are two recent clinical trials that use, in both cases, cryoablation, which is a specific technology using freezing in the pulmonary vein ostium to achieve isolation. And in these two trials published in the New England Journal last year, both of the trials showed that patients were more likely to be free from AFib recurrence if they underwent ablation. Now, these two trials have been hailed by the manufacturer of the cryoablation technique as indications for first line of treatment of atrial fibrillation. And I think that's totally wrong. And I think we should resist that interpretation, because the outcomes that they measure is freedom from atrial fibrillation. We know from many clinical trials that ablation is better than any drug at restoring and keeping normal rhythm. But that doesn't mean we should do it as a first line of therapy. Now, if you do a trial and your endpoint is rhythm control, you're setting up yourself for success. So it's impossible to have a negative trial. We know that ablation is better than antiarrhythmic drug therapy at staying in normal rhythm. The endpoint should not have been rhythm control. The endpoint should have been issues like survivals, freedom from stroke, freedom from heart failure, and quality of life, and other things that could justify ablation as first line. These two are not the only studies that have looked at ablation as first line. Other previous studies have shown that, yes, radiofrequency ablation is better than antiarrhythmic drugs as first line of treatment of symptomatic atrial fibrillation. But again, the primary endpoints were always atrial fibrillation burden or freedom from atrial fibrillation, and that's not the same thing. That's not enough in my book to justify ablation as a first line treatment, because we can always wait and ablate when the patient is ready for it. And I refuse to ablate a patient that just shows up with the first episodes of atrial fibrillation, maybe in the context of some reversible conditions. So just to reiterate, ablation does better than antiarrhythmic drugs in many things, in symptoms, in atrial fibrillation recurrence, and other things. But that doesn't mean, again, that ablation necessarily has to be first line. We know, of course, that if a patient has been on antiarrhythmic therapy and has failed antiarrhythmic therapy, ablation is even much better. Success rates can be 81 versus 7%, 70 versus 19. So when antiarrhythmic drugs have failed, definitely ablation is the way to go. And there's no point in waiting, trying more drugs. But as a first line of therapy, symptom control can be achieved in a substantial fraction of patients with drug therapy. Now, what is the price of ablation? Ablation doesn't come free. It's the risk of pericardial bleeding and tamponade. There's a risk of stroke. There's a risk of frightening atrial fistulas that can be lethal. Risk of frenulum paralysis that typically recovers. Pulmonary vein stenosis, it's very rare with the current approaches. Laryngeal nerve paralysis, vascular access complications, gastroparesis, and even death. So we need to make sure that all these risks are appropriate and acceptable for the patient in order to recommend ablation. Now, another thing is, does ablation improve survival? It's worth spending a few minutes talking about that. There's a couple of studies that showed that, particularly in patients with heart failure, like the ATAC study and the CASTLE-AFib studies, took patients with atrial fibrillation, randomized them to ablation versus amiodarone, which is the most common antiarrhythmic drug given in heart failure. And both of them showed lower death from all causes in the ablation group. The CASTLE-AF was particularly dramatic in that after follow-up of 5 years, less patients in the ablation group had died. Also, a large multi-center study, the Cabana trial, showed that a combined primary endpoint of death, disabling stroke, and serious bleeding or cardiac arrest in a large unselected population of patients maybe was not associated with reduced mortality. So in an unselected population outside the heart failure patients, it's hard to show that ablation improves survival, at least in a clinical trial. But especially in a large clinical trial like this that had a lot of issues with a lot of crossover between groups. But when you look at patients that got ablation versus patients that stayed on drugs, regardless of randomization, so on treatment or per protocol analysis, there seemed to be a reduction in the incidence of death, disabling stroke, serious bleeding, or cardiac arrest in the patients that underwent ablation. So what do we know from all I discussed? Ablation can improve symptoms better than any drug. Ablation may improve mortality in patients with heart failure, and ablation may reduce risk of stroke compared to any drugs. Does that mean that we need to ablate everybody? My take is that it does not mean that we have to ablate everybody, because AFib is a complex disease and it has its other associations. So obesity is one. Obesity increases the risk of atrial fibrillation risk and increases a bunch of other problems for your health, including sleep apnea, hypertension, diabetes. So we should treat obesity. We shouldn't just ablate AFib. We should manage the entire patient with the entire condition. If there is associated obesity, we should treat that as well, or even before treating atrial fibrillation. Sleep apnea is another problem that is very much uniquely associated with atrial fibrillation because of the acute stresses of apnea, plus the long-term associations of hypertension and other problems. We should treat that first before we jump into ablation. Other associations, most recently well known for a long time, was association with atrial fibrillation and alcohol use. It's well known that as little as just a glass of wine every night can increase the risk of atrial fibrillation. So the idea that alcohol or a glass of wine every night is good for your heart may apply to coronary artery disease, but certainly not to atrial fibrillation. There's a study randomizing patients with paroxysmal atrial fibrillation to either alcohol abstinence versus continuing the usual intake of alcohol. And there was a reduction of 45% in the recurrence of atrial fibrillation and the median percentage time of atrial fibrillation during 6 months of follow-up. So we need to manage the entire patient with the entire cohort of risk factors and comorbid conditions before we jump into ablation. So who is an appropriate ablation candidate? I always ask patients and myself 3 questions. What is the patient gain if reliable rhythm control was achieved, better than existing therapy? So if the patient is having symptomatic AFib and antiarrhythmic drugs are not doing the trick, symptom improvement is obviously a patient gain. Is ablation a valid stroke prevention strategy? In a very much selected fashion, for some patients, I will stop anticoagulation if the ablation works. And that is a better way to prevent stroke than any anticoagulation. If you are in normal rhythm, you don't have a risk for stroke, at least a risk of stroke coming from AFib. So occasionally, I would consider the potential stopping of anticoagulation and restoring normal rhythm as a stroke prevention strategy. Second question I ask myself, is the procedure safe? Can this patient tolerate a 2-hour procedure under general anesthesia? Some patients are too debilitated, and it may not be worth doing it. But that particularly applies to some patients with heart failure. We know AFib ablation works really well or can make a good impact in patients with heart failure. But not all of the patients with heart failure can tolerate a 2-hour procedure under general, an aggressive procedure like AFib is. And the third question I ask myself is there any technical issue that will compromise the procedure success or safety? Some patients may have massive left atrial enlargement or a thrombus or other issues that I would say, listen, it's not worth trying because it's going to be too hard technically to get the job done. So when is AFib ablation appropriate? When the benefits outweigh the risks. And that requires individualization. AFib is heterogeneous in terms of symptoms, burden, and structural disease, and the prognostic impact. Antiarrhythmic drugs may be a good choice for some patients if they're compliant. So if the patients are doing well on antiarrhythmic drugs, there's no reason to treat with ablation. We have to treat associated conditions, hypertension, obesity, sleep apnea, and alcohol use. And we have to balance that the ablation success is not equal for everybody, depending on paroxysmal versus persistent and the presence of structural heart disease. Also, the risks are not equal for everybody. So my last slide is when is ablation appropriate? Again, we will treat associated factors, obesity, sleep apnea, alcohol use, and then we need to partner with the patient, lay out the appropriate expectations in terms of freedom from symptoms, freedom from anticoagulation, improved heart failure, and if the risks are acceptable, then I definitely support ablation as a better treatment for atrial fibrillation. Thank you very much.
Thank you, Miguel, for such a wonderful talk. I think this field has evolved so much since my days of fellowship. It has become such a core to the practice of cardiology at large, given the density of this complicated issue known as atrial fibrillation. We will keep time in mind, but I do have a couple of questions I would like to for you, and I think Paul may be joining in soon to see if he can help address that. Can you elaborate a little bit more on sleep apnea? And so at what point are you deciding for patients to ablate, and how do you counsel in patients with sleep apnea?
You want to have a plan for the treatment of sleep apnea. That applies to AFib and applies to all the other bad consequences of sleep apnea for the patient. What I do is, number one, make sure the patients are screened for sleep apnea. If a patient shows up and they refer to me for ablation and you ask this, there's a questionnaire to screen for sleep apnea, and if they have a suspicion, you have a suspicion that they may have sleep apnea, then you need to have a sleep study and a plan for treatment. We know that untreated sleep apnea may increase the rate of recurrence after ablation by about 30%. So you need to have that taken care of. It doesn't mean that you have to absolutely have every treatment tried and apnea completely resolved before doing an ablation. But in parallel, I tell the patients, listen, we have to have a plan for sleep apnea treatment. In the meantime, we can plan for the ablation, and we will implement both things: ablation plus CPAP or whatever the treatment is required for sleep apnea. But sleep apnea has to be treated; otherwise, the ablation will fail with a greater probability than if you don't treat the sleep apnea.
Okay. The next question is, it goes to these watch monitors, I guess something like Cardia or something like that. Are you able to assess for recurrence of atrial fibrillation, and how reliable is that for your patients who have undergone ablation? I guess that goes to at large. What is the EP take on this?
I recommend patients to have some form of monitoring. I tell them, listen, I don't have any stocks in Apple, but either Apple or other wearable monitors, I think are a good idea for patients with AFib, because it gives them a sense of connection with their own body and their own rhythm. Are they reliable to detect recurrences? There are many false positives with watches that monitor rhythm, but as a screening tool, they're very valuable because it's near 24 hours a day monitoring of their pulse. And if the patient has symptoms, they can then get an EKG with their finger and then send them to me. So as a kind of low intensity but continuous monitoring, I think it's a very good idea to have wearable watches that can track your heart rhythm.
Dr. Sherman, would you like to add to that?
Oh, it was well said by Miguel. I mean, we always need a formal evaluation by the monitor. And that is actually the Apple Watch is actually an extra friendly for us because sometimes we can detect even AFib when we're not even looking at it. And there are some cases that the monitors are normal that you send, and then the Apple Watch comes with AFib, because it's a way more extended monitor.
Yeah. I guess the physicians who are asking, or the staff people who are asking us, is more regards to, is it worth patients wear watch monitors? But we'll move on to a couple of more questions since we are a little short on time. Do we have to continue anticoagulation in patients that convert to sinus rhythm? And if so, for how long? I think Adi did address that a little bit, but I'd like you two guys to chime in if possible.
So patients that get an ablation, they have to stay on anticoagulation for at least 3 months. That's mandatory. And I insist on patients that is not negotiable because they need to heal from the ablation lesions with anticoagulation on board. Some of the ablation lesions could be annulus for thrombus. So you want to prevent ablation-related strokes that way. Beyond 3 months, what the dogma says is that we should follow anticoagulation depending on the CHA2DS2-VASc score of the patient. Okay. That is kind of the standard dogma. However, I will conduct more or less intensive monitoring or periodic monitoring, more than the Apple Watch, but with rigorous monitoring, either at 3, 6, or 9 months. And then if the patient does not have AFib and the patient has reasonable profile of risk of stroke, I will stop anticoagulation. I think is a realistic goal of ablation that many patients can come off anticoagulation after a successful ablation.
So to carry on to kind of maybe the last question on that same theme, in patients with a low CHA2DS2-VASc score, or I guess the low risk of stroke, do you recommend aspirin? And also, do you recommend low dose or alternate day anticoagulation? Any of those options, good idea, bad idea?
Well, I think I'm curious to see what Dr. Sherman thinks about the low dose thing. Aspirin has no role in AFib-related stroke. Let's just be clear about that. If you have a vascular disease that can benefit from aspirin, of course, by all means, stay on aspirin. But it is unrealistic for any patient to expect improvement or protection in the risk of stroke with aspirin. That is just, we have to be clear about that. Okay. So what I do when I stop anticoagulation is I look at the overall kind of vascular risk of the patient. Many patients will have had a CT scan of the heart before the ablation, and if we detect coronary calcium, then I would recommend aspirin for that purpose, but not for the purpose of AFib-related stroke, okay? Because that requires full anticoagulation. If you have AFib-related stroke, you need anticoagulation.
As we say in the CAD field, aspirin has no friends. Sounds like even the EP guys are giving up on aspirin. But Paul, go ahead. You have the final word on this segment.
No, I agree with Miguel. I actually would like to complement that is the newest thing for us in our field is, like we always said, rhythm control has perhaps no meaningful prevention of stroke, but With the latest trial, we are seeing that if you apply rhythm control, perhaps you could prevent stroke by decreasing the AFib burden. So now we're seeing evidence in favor of rhythm control. So it's not only anticoagulation, which is, of course, the mainstream. Now we're seeing evidence that decreasing the AFib perhaps may decrease the risk of stroke.
Fantastic, guys. Thank you so very much. And also thank you to Dr. Lador for a wonderful presentation. Dr. Valderrama, Dr. Sherman, thank you both very much.
Thank you.
We will start our next session, and this will focus on endovascular disease and advances in therapies. We are almost on the home stretch, and I would like to invite our next speaker, who needs no introduction at all, Dr. Alan Lumsden, who is the chair of our cardiovascular institute here. He's an eminent vascular surgeon, the founder and presidential distinguished chair here, and professor in surgery. I would like to invite Dr. Lumsden to discuss aneurysm of the aorta. Is it going to kill me? Dr. Lumsden.
Well, thank you for the invitation. The topic that I'm going to speak on is aneurysm of the aorta. Is it going to kill me? And we'll try and address that sometime in the next 15 minutes. Here are my conflicts. When you look up at the roof of the Sistine Chapel, you see this God giving the spark of life to man. I used to give a presentation with a friend of mine, Jeff Marshall, who's an interventional cardiologist in Atlanta. I used to say, Jeff, you know, realize that's a surgeon that's up on that cloud. But he's very astute and observational, and he pointed out that stethoscope that was around his neck and said, no, you know, Alan, that's not a surgeon who's up there. That's an interventional cardiologist. So, you know, with that in mind, I'm going to do my best to try and persuade you about what we need to know about aneurysms today. Well, let's start off with some of the demographics. First of all, most aneurysms are detected by chance. The aorta lives at the posterior aspect of your abdomen, on top of your spine, and although most are asymptomatic, when they do cause symptoms, they often present as back pain. So it's not at all uncommon that we get referrals from a patient who's gone to the orthopedics. They may get a CAT scan, the spine's normal, but they see this calcified shell of the aneurysm, and then they're sent our way. You fix the aneurysm, and their back pain goes away. But again, to emphasize, probably 70-80% of them are completely asymptomatic. When they move into the symptomatic mode, when they are become symptomatic, either with back pain, the most common symptom, or abdominal pain, then there's some urgency in getting them fixed, because then they're in pre-rupture mode at that point. About a couple of 100,000 people in the United States are diagnosed with AAA annually. About 15,000 patients die each year from a ruptured aneurysm. The mortality has really not improved a whole heck of a lot from a rupture. If you have a free rupture, most of these patients don't get into the hospital. What I mean by a free rupture was it decompresses into the peritoneal cavity, patients just exsanguinate. So it's a very pre-selected group of patients that we see in the first place. Those whose abdomen ruptures retroperitoneally, is contained, they then stabilize, and that gives us a chance to go ahead basically and intervene on that patient. 45 to 50,000 patients undergo some sort of intervention. Used to be surgery, increasingly it's with an endograft. And AAA is more prevalent, the older you get, more common in men than they are in women. The Trivial Pursuits question, switch aneurysms are more common in women than men. Splenic artery aneurysms and renal artery aneurysms are the only ones more common in women and men. Everything else basically is more common in men. Where do aneurysms of the aorta occur? The most common location is in the infrarenal aorta. Okay, now why infrarenal? We really don't know. It's probably related to flow patterns in the infrarenal aorta, probably related to lack of elastin or degeneration of elastin in the wall of the aorta. The other location where you get aneurysms, of course, is descending thoracic aorta, much less common ascending aorta. We'll talk a little bit about descending thoracic aneurysms later. The definition of an aneurysm is about 1.5 times the adjacent normal aortic diameter. And so the other really valuable piece of information is to know that most aneurysms grow on average about 3 to 4 millimeters a year. But that's not basically linear progression. Sometimes aneurysms stay stable and expand more rapidly. And so you really once you make this diagnosis, you really have to follow those patients. Most are followed with ultrasound, some with CAT scans. So the annual risk of rupture, what are the numbers that you need to remember? So the numbers are small aneurysms. The definition of small aneurysm is probably less than 4.5 centimeters in diameter. The risk of rupture, as you can see, is remarkably low. The risk of intervention at that point in time is probably higher than the risk of leaving them alone. So by and large, there are a couple of exceptions. Aneurysms less than 4.5 centimeters should be left alone. Aneurysms 4.5 to 5 centimeters in small women, you start thinking about it. But the numbers that we typically think of are in the 5 to 5.5 centimeter range. 5.5 centimeters needs to be fixed. 5 to 5.5 centimeters, we individualize. How do we individualize? Again, it's relatively bigger in a smaller woman. If there's been recent expansion of the aneurysm, we lower that threshold down to 5. Some patients have a history of ruptured aortic aneurysm. They're just completely paranoid about this. And if they're incapacitated by knowing there's an aneurysm, it's another situation where it's very reasonable to actually take the threshold down a little bit in those patients. But once you start hitting that 5.5 centimeter diameter, then what you see is an exponential rise in the risk of rupture. So if you see a patient with an aneurysm of 7 centimeters, and we're really quoting them a rupture rate of 15 to 20% per year. Well, you got to be pretty sick in order not to have that aneurysm ruptured, because they are going to rupture if the patient survives more than, for example, up to about 5 years. Chances are that aneurysm is going to be ruptured. The mortality when the patient reaches the hospital is still in the order really of about 50%. So again, we're always weighing up the risk versus the benefits. And so when a patient says, what's going to kill me first, doc, is it the cigarettes, is it the booze, or is it that aneurysm? We're always judging the risk of leaving it alone and the benefit basically of intervention. And again, purely based on a size basis, we think about the 5 to 5.5 centimeter diameter, a little bit higher in the descending thoracic aorta or in the ascending aorta before we decide to go ahead and intervene them. So these numbers I'm quoting you are really for infrarenal abdominal aortic aneurysms. Okay, patient's got an aneurysm. Now what are we going to do with this? Well, let's say it's an aneurysm 4 centimeters in diameter. What are we going to do with that patient? By and large, we're going to ask them about their history, family history of aneurysms. Do they have any abdominal pain? Do they have any back pain? And I can tell you in a 4 centimeter aneurysm, if they've got back pain, because of course half the world has got back pain, it's probably not coming from the aneurysm. And we have to explain that to the patient. And so typically the diagnosis is usually in our world, usually made with ultrasound or a CAT scan. Sometimes it's made with a KUB because the wall calcification may be evident, and that might be one of the reasons that they are referred to you. It's not a reliable way of measuring the diameter. So typically, if we're going to follow these patients, and it really depends upon the body habitus, but if it's an aneurysm 4 centimeters in diameter, they don't need a CAT scan every year. CAT scan should be really thought of as the pre-interventional evaluation. We need a CAT scan before we're going to intervene on them, but in terms of routine follow-up, typically we get an ultrasound, on an annual basis. If it looks like it's suddenly getting bigger, we'd probably get a CAT scan at that point to evaluate it. So ultrasound yearly, non-contrast CT scans another way, particularly in patients with an elevated creatinine. But if we're going to intervene on them, we really need either a CT scan or an MR, perhaps done with Furhim. So once we've made that decision, the aneurysm has now gotten bigger. We're now up to 5 to 5.5 centimeters in diameter. Now's the time that we're going to go ahead and get that CAT scan. And that CAT scan really should be done with relatively thin slices, 1.5 to 2 millimeters. That has become increasingly important as we've moved into the world of branched and fenestrated grafts. What is a fenestrated graft? Is where there's a hole lined up, for example, with the renal arteries that we're going to go through and put little branches really out into the renal arteries. Some have other methods basically of putting branches in because there are a whole variety of these different devices that exist at the moment. They're the accuracy of planning where those fenestrations are going to be made, where those holes are going to be made that you're going to put a stent graft through a stent graft into a renal artery or a superior mesenteric artery is critically important. So if the diameter of the renal artery is only 5 millimeters in diameter and we've got 5 millimeter slices, then we can be miles off in terms of where we're going to put that fenestration, and that makes it very difficult to actually catheterize these. So for the imagers who are out there listening to this, we have gone from thinking of the CAT scan purely as a diagnostic planning tool, because we now import that and we fuse it. And I'll show you some examples of this on top of these patients. We're actually delivering these devices using your CAT scan, and so it is very important that what the quality of that scan is going to be. So we've made the decision we're actually going to intervene on the patient. First of all, there is no role for angiography in helping plan these. Angiography is really used at the time of planning, and we use a hybrid room. We use what's called a Siemens Pheno hybrid room. It's the latest and greatest. It allows us actually to make CAT scans called cone beam CT. It allows us to do angiography, and we can bring in every other imaging tool that we need. So we can think of ourselves as the ultimate multimodality imagers. We use ultrasound always to get access. We never stick a blood vessel without using ultrasound. We use fluoroscopy to guide the catheters and wires. We use a CT scan, which we fuse, and at the end of the procedure, particularly with fenestrated grafts, we make a non-contrast cone beam CT so we can evaluate whether the stent space are adequately deployed. Increasingly, because we're particularly interested in imaging, we're interested in dynamic and functional techniques. And I think of this, for example, you would never really think about determining how you're going to fix a mitral valve using a CT scan alone. We use ultrasound. Sometimes we use dynamic CT, dynamic MR, because it's very mobile. And yet, in things like aortic dissections where there's mobile flaps, we've traditionally used static imaging, and we're very interested in taking some of these dynamic images and using them. Juan Perotti was a guy who first of all took a Palmas stent, put it on a piece of Dacron, and really allowed the development of this entire generation of stent grafts. These are some of the early ones, introduced in 1999. They've undergone a variety basically of different modifications and improvements since then. And I think of this now as like TAVR. We went through this many years ago where there was a lot of opposition to this. There's the acceptance of it, and now 80-90% of aneurysms primarily are treated with intervention. And these is just a list really of some of the strengths and the weaknesses of these different types of modality that we talked about. We've largely covered really this table. And the other one we use is intravascular ultrasound, which is always used for dissections to make sure that we're actually in the true lumen. When we look really in planning for stent grafts, because this is where the imaging part of this piece is extraordinarily important, every different company has a different method really of using, of measuring off the CAT scan. The CAT scan, he who owns the CAT scan owns the case. And again, we measure and plan the CAT scan of the endograft off the CAT scan, and increasingly we're fusing these on top of the patient. The key issues that are important are the infrarenal neck. Typically, there's a relatively normal piece of aorta below the renal arteries that allows us to seal a stent graft really up against the walls of that aorta, and that's very important. There are new modifications in each stent grafts where we have what are called shorter necks. The degree of angulation is important. The diameter is only used for planning to proceed with an operation. It's irrelevant during the procedure. What is important to us is the iliac arteries, much like TAVR. What are the diameter of this? We have stent grafts that now come down to about 14 French, so we can handle pretty diseased arteries, but tortuous, small, iliac arteries that are heavily calcified remain a problem. And the other thing is a problem if you've got major branches like a patent inferior mesenteric artery coming off the middle. These are the sort of things that we want to know really off the imaging. So we talk about the neck, what's the length, what's the internal diameter, and what basically are the iliac arteries look like. Long, thin, parallel tubes, just like this ostrich basically is what we really like. And making sure that they work in a multiplanar reconstruction plane where you get the sagittals, coronals, and the axials optimized in the center line to make sure that we're actually measuring a true diameter is very important. What's also important on the right is demonstrated is what the quality of the neck looks like. For example, up here you're really looking at a lot of thrombus in the neck. Here we measure the inner wall to the inner wall. Some companies want outer wall to outer wall. You just kind of have to know that really in general before we can calculate this. And so this high resolution CAT scan, extraordinarily important. And again, as I just mentioned, stent graft companies have their own everyone's got a different way of actually measuring these, but it all is based upon getting an adequate quality CT scan. And when you look at these devices, then we basically translate those measurements into the device itself and selecting a device from this kind of portfolio of menus that you get here. And these are the kind of things that we're looking at basically from this. We then translate this into optimizing that imaging at the time that we're actually doing this procedure and doing the implantation. Iliacs really we've kind of talked about. If you get it wrong, this is what happens, is you end up basically with an iliac rupture. So I'm going to summarize there and basically say that the optimizing the imaging, particularly the CT scan, is extraordinarily important for us. The main way in which we select these patients to go ahead and do an intervention is 5 to 5.5 centimeters in the infrarenal aorta, 5.5 to 6 centimeters when we're talking about the descending thoracic aorta. Descending thoracic aorta a lot more straightforward in terms of being able to treat these patients than it is basically in the abdominal aorta. What you will see increasingly are branch grafts. These branch grafts are a way of producing an endovascular solution for all parts of the aorta, and you get it, and there's even an ascending trial going on at the moment with the stent graft. Thank you very much for your attention. Look forward to hearing some of your questions.
Thank you, Dr. Lumsden, for a very detailed overview of aortic aneurysm. Would like to invite our next speaker, Dr. Bavare, Charudita Bavare, who is our eminent vascular surgeon here at Houston Methodist Hospital, and he will discuss the topic of venous disease. Everyone has veins. Dr. Bavare.
Hello, good afternoon, and welcome to the venous disease talk on the cardiology for the non-cardiologist meeting. I'm Charu Bavare, one of the vascular surgeons at the Methodist DeBakey Heart and Vascular Center. Looking forward to help you learn something from Everyone Has Veins. So instead of telling you how we do it, I think I should tell you why we do this. The talk can be divided into some introduction, a clinical presentation, anatomical considerations, and then we talk something about acute venous diseases and then chronic venous diseases. The clinical presentation of vein disease is broadly into three types: acute, which is very dramatic; chronic, which is very annoying; and then the sequelae of all that, which is really annoying. The acute part requires prompt diagnosis and treatment. The chronic part requires early symptom control, and the sequelae are really hard to control, but as much as we can, symptom control is most of the treatment. The symptoms are usually worse than the signs, so patients are found to have more complaints than what actually is seen under the skin or on the skin or on the ultrasound. So just be empathetic to these patients. The acute and chronic DVT can be further classified as acute becomes DVT, which is restricted to the extremities, and then pulmonary embolism, which goes on to the lungs. Chronic DVT could be chronic venous conditions could be chronic DVT, varicose veins, venous ulcers, and then the last but not the least, post-thrombotic syndrome. So the acute DVT, which is essentially in the femoropopliteal vein, or the iliofemoral vein or iliocaval vein, all essentially become lower extremity DVT and central DVT, and they all can embolize and become the infamous pulmonary embolism. So from a non-life-threatening situation, we go to a life-threatening situation. Anatomical considerations for venous disease. At the top, just look at the box there, which says common internal and external iliac veins, which are above in the pelvis. And then below the inguinal ligament is the femoral vein, the common femoral vein, and the great saphenous vein. Remember, the femoral vein is a nomenclature which is designed to avoid confusion between superficial femoral vein DVT and femoral vein DVT. Essentially is the same because they're both deep veins. And so to take away the confusion, the word superficial has now been taken away, and it's only the femoral vein. So acute DVT is the way the clot forms is the clot forms in the common femoral vein, just at the inguinal ligament, and then it starts propagating. So it goes forward and it goes into the external iliac vein and stops where the big flow from the internal iliac vein comes through. And so whenever you have a clot in the common femoral vein, the Doppler never says iliofemoral DVT because they don't look at the iliac vein. They only stop at the groin or the inguinal ligament. So unless you order an abdominal duplex, the iliac veins are not seen. So when you see clot in the common femoral vein on duplex ultrasound, remember that's the notable detail to have a red flag saying this is iliofemoral DVT. And why is that important? because the Society for Vascular Surgery way back in 2012 had come with a consensus that if you have an iliofemoral DVT, then we should try and go after these thrombi so as to prevent post-thrombotic syndromes down the line. So the guidelines from the SVS, or the Society for Vascular Surgery, says that if you have a first episode of iliofemoral DVT, which is less than 14 days, and the patient has a low risk of bleeding with a good functional status and any absence of some unfortunate life-threatening malignancy, and they're expected to have a reasonable life expectancy, we should go after these thrombus. And there could be a variety of things to do. I'll come to that in the next slide. And the earliest thrombus removal is mandatory for people with limb-threatening ischemia due to iliofemoral DVT, which is called phlegmasia, which presents as a surgical emergency. And if the clot is confined to the femoral vein or the popliteal vein, then the consensus is just anticoagulation only. We do not need to go after these thrombi. The patients who can tolerate pharmacomechanical thrombolysis and anticoagulation should not meet criteria for an IVC filter. So no IVC filter is required. If patients have iliocaval DVT with extremely poor cardiac function, or who have had recurrent DVT on anticoagulation, these are the patients where an IVC filter is recommended. There is a buffet of devices to go after these clots. There are some that pulse the clot, some that actually suck the clot, and then some that dissolve the clot. And it's a little beyond the scope of this talk, but just understand there's a huge buffet of devices that we have at our disposal, and we tailor them as to the condition of the patient. Here's a venogram shown. On the left side, slide A shows extensive amount of clot. Clot is the thing that is a defect, which is white amongst all the black contrast marks. And the slide B is where most of the clot is retrieved, but there's some clot in the common iliac vein. And in the slide C, most of that clot is taken off, and then probably some aggressive angioplasty has been done to maintain caliber of that vein. Similarly, in the upper extremity, this is a condition called Paget-Schroeder syndrome, where there is an effort-induced thrombosis of the subclavian and axillary venous system. Here, a wire and a catheter have been passed from the arm going into the central venous system. This patient probably has had some thrombolysis or percutaneous thrombectomy treatment done. And then the lower part of the slide shows an angiogram that shows a pretty significant pinch of the subclavian vein, just when it goes over the first rib. And this is the classic sign, effort-induced thrombosis, or Paget-Schroeder syndrome, or thoracic outlet syndrome. But the job's not done. Usually we see something abnormal in about 30 to 60% of cases, which is the underlying abnormality, which is the cause of the DVT. Multiple X-ray angles may be needed. We may need intravascular ultrasound to actually look inside the vein and know exactly. This is a pretty sensitive modality to pick up any small caliber differences inside the vein. Usually failure to treat the underlying abnormality is what makes the procedure fail, and then patients come back with recurrent problems. So have a high index of suspicion, because the eyes won't see what the mind does not know. So onward to pulmonary embolism, the treatment is usually tailored by the symptoms, and there are plenty of guidelines out there. The last one being the CHEST guidelines in 2016, and then the Pulmonary Embolism Response Team's consortium, or the PERT consortium, they came out with their statement about treatment strategies for PE. But broadly speaking, this is what we should know. Acute PE, which is not associated with hypotension, all they need is anticoagulation, and also provided that the heart function or right heart function is normal. If there is PE with hypotension with less than 90 millimeter of mercury pressure for about 15 minutes, and or accompaniment of right heart failure or increasing troponin leak, then yes, these patients need intervention with systemic thrombolysis. Patients with a moderate bleeding risk, or who have failed systemic thrombolysis, or there is shock, which is not circulatory collapse, but just hypotension, they would meet criteria for being catheter-directed treatment with thrombolysis. Patients with severe pulmonary embolism who are in circulatory collapse and shock with cardiopulmonary resuscitation going on would actually meet criteria for an ECMO placement and then further treatment. Here, the buffet of devices is even larger. So we have amount of devices to suck the clot out, to fragment the clot, to dissolve the clot. Again, beyond the scope of this talk, but just understand we have plenty of options here too. When it comes to IVC filter, this is the most glamorous question people ask and the most confusing question people ask. So when are IVC filters really required is if you have an acute PE, which can be treated with anticoagulation, you do not need an IVC filter. So anticoagulation only. If you have an acute PE, where there is a contraindication for anticoagulation or there is a complication of anticoagulation, say you start the patient on anticoagulation and they have a bleeding gastric ulcer, or they have recent surgery and they cannot be given anticoagulation. So yes, then they are the patients who meet criteria for an IVC filter placement, no doubt about that. And the third one is a patient who's on anticoagulation and has a new clot, a new DVT and PE, for sure meet criteria for an IVC filter placement. Again, a lot of IVC filters available, but we have now uniformly have a statement saying that all IVC filters should be the temporary retrievable ones, which can be taken out. Because this is the question to do or not to do, is to take the filter out or not to take it out. And if you see IVC filter removal, the first thing that comes up is an attorney's website telling us to come and tell them about how bad you're feeling. But jokes apart, the IVC filter retrieval is something that the FDA has made a statement on, saying that they recommend removing the filter as soon as the protection from the PE is no longer needed. And that pretty much sums up the fact that yes, filters are there and filters are going to be removed. There are various tricks, and there's another buffet of solutions, but out of the scope of this talk. But essentially, we do all we can to pull the filter out as soon as possible. Typically, 1 year is the instructions for use limit to take the filter out safely. When you come to chronic venous diseases, it's a long list with a long frustration for the patient and the surgeon or the treating doctor. Chronic venous diseases could be varicose veins, venous ulcers, and post-thrombotic syndrome. We have chronic venous insufficiency. It is a reflux in the vein or obstruction. Combination of that is the worst, actually. And the second one would be an ambulatory venous hypertension, where the skin gets congested and even small pressure changes have a large impact. Unfortunately, not an easy fix to this. There is a CEAP classification where there is a clinical classification, the etiologic and anatomic and pathophysiological, essentially all the boxes and tabs are essentially how bad is the varicose veins or how bad is the degree of varicose veins. The anatomy is a little confusing, but broad brushstrokes saying there's a component of pelvic outflow, there is deep veins, superficial veins, and then the perforating veins. Venous ultrasound is done for varicose veins is not a conventional DVT study. It's called a radiated reflux study, where they look at the diameter of the vein and look at the time that the venous reflow refluxes back and goes forward. And traditionally, more than 500 milliseconds is significant here. The treatment is compression, 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 and sometimes more compression. Essentially, cannot take away the importance of compression here. So when you have reflux along with pelvic outflow obstruction, that's when treatments are done for improving the outflow to the leg by angioplasty or stenting or a combination of both. Really bad situations are long segment occlusions, which are not amenable to any angioplasty, and then they end up having surgical bypasses. It's a pretty morbid procedure to undergo and difficult procedure to do, and overall a high risk procedure for failure. So in summary, when you have an acute DVT, the diagnosis has to be done early and the referral has to be prompt to a treatment facility or a personnel. Have a low threshold for ordering venous duplex if you see swelling in the leg. The correct interpretation is important, so have it done by an accredited vascular lab. If possible, thrombolysis reduces long-term sequelae with post-thrombotic syndrome, and then anticoagulation alone prolongs valvular insufficiency. So we have to be aggressive in treating iliofemoral DVT. In summary, for chronic venous diseases, it's compression, 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 and maybe more compression. It's important to set the right expectations because these patients have a long, prolonged course with mostly not coming back to baseline in some situations. A thorough clinical exam and an ultrasound reflex study is the key. Identify the etiology and then treat accordingly. It could be just reflux, it could be just obstruction, or it could be a combination of reflux and obstruction. Again, I would say continue compression therapy, cannot mince that. And then close procedural follow-up is important so that we ensure compliance to compression, ensure compliance to wound care and skin care, and that would make the entire treatment process successful. I would say thank you for your attention. And this was a big blast through venous diseases, but for the time given, this is all I could cram. Hopefully we can have a detailed session some other time. Thank you for your attention. Bye-bye.
Dr. Bavare, thank you so much for a fantastic presentation on such a complex and a wide topic. I'd like to invite our next speaker, Dr. John Cook. Dr. Cook, again, also does not require any introduction. Dr. Cook is our Rusty Walter and Carol Walter Luke Presidential Distinguished Chair in Cardiovascular Disease Research. He's a chair of Department of Cardiovascular Sciences. He's professor here at Houston Methodist Hospital and the Academic Institute. He's a director for Center for Cardiovascular Regeneration and the medical director for Center for RNA Therapeutics. Dr. Cook has a special passion for vascular biology as well as peripheral arterial disease. I'd like to listen to Dr. Cook's presentation on peripheral arterial disease, how to detect and treat. Dr. Cook, please.
Hi, I'm John Cook. I'm chair of the Department of Cardiovascular Sciences here at Houston Methodist, and I thank Dr. Bill Zoghbi for asking me to present some information to you about peripheral arterial disease, and thank you all for your attention because this is really a very important topic. Peripheral arterial disease, or PAD, can be hard to detect, and it's important to treat it because it has such a morbidity and mortality associated with it. So what I'm going to talk about is why we need to make the diagnosis of peripheral arterial disease and how to treat it, and the evidence-based for treatment principles. Peripheral arterial disease is quite prevalent. It affects at least 8 to 10 million Americans, probably more. It can affect the aortoiliac vessels, the superficial femoral artery, and the infrapopliteal vessels. It may affect those circulations in isolation or together. It's not a benign disease. Even if you look at normal subjects, here's a Kaplan-Meier curve, normal subjects in light blue. If you look at patients with severe symptomatic peripheral arterial disease, let's say someone who has severe difficulty walking, it's not a surprise that after 10 years only 25% of these individuals are still alive because they have coronary artery disease and carotid artery disease in association with their severe peripheral arterial disease. But what might surprise you is that even asymptomatic peripheral arterial disease has a poor prognosis with respect to age and gender matched people without peripheral arterial disease. So this is why it's very important to detect peripheral arterial disease in the office, because even when it's asymptomatic, it's deadly, because it's associated with other cardiovascular disorders. So patients with peripheral arterial disease typically have disease in other circulations, such as the carotid artery, making them susceptible to stroke. They may have renal vascular disease. Someone with uncontrolled hypertension and peripheral arterial disease has renal artery stenosis unless proven otherwise. They may have aortic aneurysm disease. They get mesenteric ischemia. Of course, blue toes are not uncommon in peripheral arterial disease, typically these days after an endovascular procedure, but can occur spontaneously as well. And that augurs an aortic aneurysm or some embolic source from above. Of course, the most common cause of death in these individuals is coronary artery disease causing heart attack. So how do we make the diagnosis of peripheral arterial disease? Well, classically, as shown by this nice Frank Netter slide, it's in an individual who is walking. They develop pain with walking, typically in the calf. It's an aching pain, typically cramping or fatigue. It's made worse if you're carrying something, if you're walking upstairs. It can affect the thigh and or the buttocks, which suggests more proximal disease in the aortoiliac location. This discomfort is typically relieved by standing still. Someone with peripheral arterial disease typically does not get pain when they're waiting in a queue for their groceries. For example, if they're getting pain just standing, think of something else like spinal stenosis. However, I should say that these classic symptoms only occur in a minority of patients with peripheral arterial disease. 10 to 30% of individuals with peripheral arterial disease, documented peripheral arterial disease, have the classic symptoms. That means a majority of patients are, quote, asymptomatic or have atypical symptoms. So it's something that we actually have to look for in the office. In the office, possibly the best way to make the diagnosis is with an ankle brachial index. You just need simple tools for this, blood pressure cuffs and a handheld Doppler. Now you have to use a Doppler, you can't use your stethoscope, because even in a normal adult, the leg arteries have a fairly fibrotic vascular wall. They can have some fibrosis, and that reduces their ability to make carot cough sounds. Remember, the carot cough sounds in the arm arteries are due to the vibration of the vessel wall. Well, the vessel walls are somewhat thickened in the leg arteries, and really in an adult don't vibrate that much. So you can't hear carot cough sounds really even in a normal individual. So you have to use a handheld Doppler. And it's pretty simple. After you get the blood pressure in the upper extremities, get the blood pressure down below at the posterior tibial artery, below the cuff up to suprasystolic pressures. You're listening over the posterior tibial artery, and then you gradually release the cuff until you can actually hear the flow of blood through the posterior tibial artery. You're looking right behind the medial malleolus for that posterior tibial artery. And then you go to the forefoot to look for the anterior tibial artery. You locate it, and then you blow up the blood pressure cuff until you can't hear the signal, and then you gradually relax it until you hear the signal again. That's the pressure at the ankle. And typically what you do is you take the higher of those two pressures and express it over the brachial pressure to create the ankle brachial index. So the ankle brachial index is the ankle systolic pressure over the brachial systolic pressure. It's that simple. The normal ankle brachial index is about 1 or a little bit over 1 because of systolic augmentation of the pulse waveform in the leg vessels. But once you get over 1.4, that's abnormally high, and that indicates calcification, which is common in diabetic patients. So frequently in diabetic patients, you can blow up that cuff as high as you want and not obliterate the flow of blood through the posterior tibial artery, because the vessel is like a pipe. It's become calcified. That's abnormal. Obviously, and that vessel can actually have intraluminal narrowing and yet have an artifactually elevated pressure. Now, below the level of 1 to 0.9, that's borderline. You'd be suspicious of peripheral arterial disease. That might be a person you want to put on a treadmill to see if they develop peripheral arterial disease. Best to send those folks to a vascular laboratory to get further documentation of that abnormality. But if the ankle brachial index is less than 0.9, you have a patient with peripheral arterial disease, whether they're symptomatic or not. In this case, you have to suspect disease in other circulations. Although they may be asymptomatic of their peripheral arterial disease because they're so sedentary they're not getting claudication with their minimal activity, they may very well have disease in the carotid, coronary, renal, mesenteric circulations, or an abdominal aortic aneurysm. So you see peripheral arterial disease, you have to look for disease in other circulations. Now, there's a lot that we can do to manage peripheral arterial disease. That's why we need to diagnose it. So there's quite a bit that can be done medically for these patients, and basically there's two things that you want to do as a physician. You want to reduce the risk for these patients of having a major adverse cardiovascular event, and you want to relieve the symptoms as much as you can with medical therapy. So with respect to reducing the risk, nutrition is a component. A Mediterranean diet is in my feeling is the best best diet for these individuals. There's good data from it dating back to the Diet Heart Lyon study about 15, 20 years ago, which was a randomized controlled trial. You want to modify the risk factors, treat the LDL cholesterol aggressively, treat the blood pressure, the other risk factors, elevated glucose aggressively, stop them from smoking tobacco, and you also want to put them on an antiplatelet or antithrombotic regimen. We're going to be talking about that in some detail. You also want to relieve their symptoms. The best way to relieve symptoms in a person with peripheral arterial disease is get them on a supervised exercise program. In some cases, they may also need intervention. Pharmacotherapy is not terribly good for peripheral arterial disease. Cilostazol, as I'll show you, does improve walking distance, but modestly by comparison to a good exercise program. So we've known for over 20 years that we can reduce morbidity and mortality in peripheral arterial disease by many of the same drugs that we use to reduce mortality in coronary artery disease. So these are data from the HOPE study that showed ACE inhibitors, angiotensin-converting enzyme inhibitor, in this case ramipril, could reduce risk in patients with peripheral arterial disease at least as much as patients without peripheral arterial disease. So the relative risk in the ramipril group was reduced by about 20% with treatment. And of course, statins reduce mortality in peripheral arterial disease. Many studies supporting this observation in the heart protection study, which showed that the odds ratio, again, for statins was over 20% improvement in major adverse cardiovascular events in those patients that received statin, whether or not they had peripheral arterial disease. Statins also increase the walking distance. Of course, they're not approved for that indication, but there's evidence from this study and others that lipid lowering can improve walking distance. The mechanism for that, not well known, may have something to do with improving endothelial function, improving the microcirculation in these patients. Here's the Fourier study of evolocumab, a PCSK9 inhibitor, also shown to reduce major adverse cardiovascular events in patients with peripheral arterial disease. And as you can see here, the absolute risk reduction was 3.5% from risk of 13% major adverse cardiovascular events to 9.5% in patients that received the PCSK9 inhibitor on top of a standard lipid-lowering background therapy. Now let's move on to antiplatelet agents for peripheral arterial disease. The evidence for aspirin in peripheral arterial disease, particularly asymptomatic peripheral arterial disease, is weak, but we do have antiplatelet agents that work. So the Capri study showed that clopidogrel was superior to aspirin in reducing major adverse cardiovascular events in patients with peripheral arterial disease. And in all patients, clopidogrel, the PAD, in patients with peripheral arterial disease, coronary disease, or carotid disease, the risk reduction was about 9% in those patients that got clopidogrel versus aspirin. But the patients with peripheral arterial disease demonstrated even greater benefit, over 20% reduction in major adverse cardiovascular events with clopidogrel. So clopidogrel is useful in peripheral arterial disease in reducing major adverse cardiovascular events. Ticagrelor also on a background of low-dose aspirin is useful in peripheral arterial disease. And here you see in the Pegasus study that there was with ticagrelor a absolute risk reduction rather, of 4.1% in patients with peripheral arterial disease that were treated with ticagrelor on background therapy with aspirin. Here's going to antithrombotics now. There's growing evidence that antithrombotics can also reduce risk of major adverse cardiovascular events in peripheral arterial disease. And in this study, the comparison was between rivaroxaban with or without aspirin. And this is you're seeing the number of the risk factors, cardiovascular events here. And you can see that the patients in aspirin on the red had this increase in risk over time of having a major adverse cardiovascular events, which was reduced in the green line by rivaroxaban, so rivaroxaban alone was better than aspirin. The combination of rivaroxaban plus aspirin, which is a lower line, was even better than rivaroxaban alone. So antithrombotics are useful in peripheral arterial disease. Beta-adrenergic blockers can be used in peripheral arterial disease to treat hypertension. There's no evidence that the beta-adrenergic blocker therapy worsens walking distance in patients with intermittent claudication. So in intermittent claudication, it's okay to use beta blockers. There's still some controversy as to whether or not they can be used in patients with severe peripheral arterial disease who have critical limb ischemia. But the average patient with intermittent claudication, one can use beta blockers. Now, that was about reducing risk of major adverse cardiovascular events in patients with peripheral arterial disease. What about treating symptoms? We really don't have much. Pentoxiflin is approved to treat peripheral arterial disease, but in my view, it's nearly worthless. Cilostazol does improve walking distance, and support for what I just said can be seen in this slide. What you're looking at here is a percentage change in maximum walking distance over time, over weeks of treatment, with pentoxiflin or placebo. There's really no difference between pentoxiflin, which is Trentol, or placebo. But cilostazol does improve walking distance about 30%. However, supervised exercise is much, much better. This is some early work from Bill Hyatt. He showed that you could get about 200% improvement in walking distance with a good supervised exercise program, and that's been supported by more modern studies. Here's a very interesting study, the RACE trial, which combined endovascular revascularization plus or minus supervised exercise, and this study showed that the combination of endovascular revascularization plus supervised exercise was better than supervised exercise alone. So the combination is very useful. So in conclusion, we need to reduce risk and relieve symptoms in patients with peripheral arterial disease. We want to modify their risk factors. We want to treat them with antiplatelet and or antithrombotics. Pharmacotherapy with cilostazol to improve walking distance is reasonable. It's not as good as a supervised exercise program, which can improve walking distance almost 200%. And in some cases, these individuals will need intervention. And even if they do have the intervention, of course, they'll need modification of their risk factors and a supervised exercise program. Thank you all for your attention. And thanks again to Dr. Zoghbi for giving me this opportunity to speak to you.
Thank you, Dr. Cook. We certainly say the best for the last. We do have a few more minutes, see if we can answer some of these questions which have come to us. And I see Dr. Zoghbi has joined us, Dr. Bavari has joined us. So first question is, in patients for preventive therapy, if patient has PAD but no CAD versus PAD with CAD, do you approach it differently?
That question is a very good one, because it allows me to mention that the patients with peripheral arterial disease tend to have polyvascular disease, so that most patients with peripheral arterial disease have some coronary artery disease. We did a study at Stanford where we studied 2,000 patients going to the cath lab, and one of the things we did was to check their ankle brachial index. And we found that about 21% of patients going to the cath lab had peripheral arterial disease. There was a minority of patients, a very small minority, a percent or two, that had peripheral arterial disease and little or no coronary artery disease. So these were patients that had minimal obstructive disease of the coronary arteries. So it's a very small percentage. And these were coronary angiograms, so they were luminograms, and they do not reflect the lesions that might be very dangerous in the coronary arteries. So I would say that a patient with peripheral arterial disease should be treated as though they have disease in other circulations, because they usually do. So aggressive risk factor modification.
Okay. All right, next question. Questions are really popping up, so please try to keep your answers brief, but please, we would love to know these answers. Would you start antiplatelet therapy in asymptomatic PAD?
I would start clopidogrel for patients with peripheral arterial disease, because clopidogrel has been shown to reduce major adverse cardiovascular events in peripheral arterial disease, and that includes asymptomatic patients with peripheral arterial disease, patients that had an ankle brachial index that put them in the category of having obstructive disease in the lower extremities in the Capri study.
So Charu, you probably see similar patients who get referred to you for revascularization but are not very symptomatic. Do you put them on maybe Plavix or rivaroxaban, or what do you tell them?
Well, for a patient that has mild peripheral arterial disease, that's asymptomatic, I think clopidogrel is enough.
Okay.
It's the patients that are at greater risk, that have more severe peripheral arterial disease, that I would consider adding rivaroxaban to their schedule of antiplatelet therapy.
Dr. Bawari, go ahead, please.
To answer your question from my standpoint, I'll be honest, I have not placed them on clopidogrel, but listening to Dr. Cook, I think it's compelling to say that we should at least consider, we reinforce aspirin, but I have not reinforced other antiplatelet agents.
Okay.
I think it's worthwhile doing it.
Next question. What about a patient with acute PE who needs surgery and therefore will need anticoagulation to be held for the surgery? Should IVC filter be placed first prior to the OR?
So yes, that's an indication. If an acute DVT needs anticoagulation and has to be interrupted for more than 24 to 48 hours, it is recommended to place an IVC filter, and it can be retrieved within a few weeks as soon as the patient is started back on anticoagulation and has no complications.
Charu, maybe you can even address this one. There are many advantages, I guess Alan Stock listed, for endovascular treatment of AAA over open surgery, but what are the pros of open surgery over endovascular treatment?
It's a great question, because there is new data coming out, especially from the UK, saying that open surgery is more durable, has more durable results than endovascular. Endovascular does have its own place in patients who are slightly higher risk from a cardiopulmonary standpoint to undergo open aneurysm repair. Endovascular has also pushed the envelope for doing complex repair for patients who have not been considered standard endovascular repair or open repair. But my advice is we always have to tailor it to the patient's needs. The younger the patient, we say an open repair is more beneficial and more durable long term.
I see. Thank you. And we have time for one more question, and I'd like to put forward to both of you. At what point do you decide on limb salvage versus limb amputation? It's a very, very important question. And maybe, John, you can also, given your expertise, add about regeneration and vascular angiogenesis to that answer, if you may. So, Charu, if you can go first.
I think we should make all attempts at limb salvage. For a person who is ambulatory, for a person who has otherwise good quality of life, for a person who is compliant to medication and is known to remain compliant. Because there is no point doing interventions on people who are bedbound or who are non-ambulatory for other reasons, or who are non-compliant, because we depend on medications, especially dual antiplatelet or anticoagulation, to keep our interventions patent. So these are the three things we always start off to begin with. But we do make an effort for limb salvage as much as we can to improve quality of life and to give them, some hope of a challenge to improve themselves. As far as amputation is concerned, there are cases where actually primary amputation may be the right thing to do, because we don't want a patient who has an open wound on the foot for the next 6 months trying wound care and multiple visits to places, not able to even walk on that foot. And sometimes an amputation gets them to a prosthesis, and they are much better served that way.
I think Dr. Pavari's response was great. I don't really have much to add to that. Just to point out that one thing to keep into consideration, these patients, 25% of them will have passed away within a year. They have a very high mortality. So that's another thing to keep in mind. But I think Dr. Bavari addressed the question very well.
Well, thank you both very much. And that concludes our presentations for today. I would like to thank all of you for attending our conference today. As we had stated earlier, all the presentations will be available for the next 2 months using the QR code. We welcome even more questions. We'll be sending it to experts like Dr. Cook and Dr. Bavari. So please keep on sending. Give us your feedback so we can make this even a better conference. I do definitely want to thank our faculty who are just amazing. They are experts at their fields and they've taken their time, volunteered their time to educate us. And I definitely want to thank the team here at Methodist DeBakey CV Education and our AV guys for making this a seamless production. And lastly, I would like to re-invite Dr. Zoghbi, whose passion, this is his brainchild, and I mean the way he has promoted this program through social media and supported every step of the way. We are so grateful to him. Dr. Zoghbi, please for a final word.
Yes, thank you very much, and thank you all really for attending today. This will be and is a yearly event because we love to share this kind of information with you. Yes, you are not a cardiologist, but I know some of them are cardiologists attending. But it is a great forum for us to share information on the latest so it can help you in taking care of patients because, vascular disease or atherosclerosis, doesn't concentrate only in the cardiac vasculature. It really affects almost every organ. So I think sharing this knowledge and the latest of our advances will hopefully help you take care of patients, and then you'll be able to share that knowledge with them. So we can't thank you enough, number one, for attending and spending the day with us. Can't thank enough our faculty and also my co-chair, Dr. Alpesh Shah, whose passion is about education and sharing this information with us. So have a lovely day, and I know we'll see you in different forums. Best wishes.
Thank you again.